Welcome to this video entitled, Clinical Pharmacology of Anti-Infective Drugs. Effective antimicrobial treatment typically begins with empirical therapy at a dose that is most likely to cure the infection with the minimal risk of toxic effects. To select the correct dosage, clinicians need to understand and apply the principles of pharmacokinetics, abbreviated as PK, and pharmacodynamics, abbreviated as PD. This chapter will focus on basic pharmacology and the application of pharmacokinetic and pharmacodynamic principles to the most commonly used anti-infective drugs, to guide optimal therapy of common infections in the newborn and young infant. Since the 7th edition of this book, progress has been made in understanding the pharmacokinetics and pharmacodynamics of many antimicrobial drugs in preterm and term neonates. We have added relevant new information for several drugs and added metronidazole to the list of drugs reviewed. To focus the reader's attention on the most relevant and available literature, we have trimmed the reference list. Information on antimicrobial drugs that are no longer used or rarely used have been omitted to make room for new information. The clinical pharmacology, indication, dosing, and toxicity of licensed drugs from well-controlled studies submitted to and approved by the U.S. Food and Drug Administration, FDA, are included in the product label and available at www.daily.med.nlm.nih.gov or on the FDA General website at www.accessdata.fda.gov. However, the use of many drugs remains off-label in term and premature neonates because of inadequate pharmacokinetics, safety, and efficacy studies. We have organized drugs into the following 5 categories. 1. Gram-positive infections, including methicillin-resistant Staphylococcus aureus, abbreviated as MRSA. 2. Gram-negative infections. 3. Polymicrobial or complicated serious infections. 4. Viral infections. And 5. Fungal infections. The pharmacology of drugs in neonates is unique and should not be extrapolated from data derived from studies in older patients, whenever possible. Few drugs have been adequately studied in the extremely preterm infant, so many of the dosing guidelines in this high-risk patient group remain empirical. In such cases, we will review the mechanism of action and dosing relative to known PK/PD properties and safety. The National Institute of Child Health and Development, abbreviated as NICHD, sponsored Pediatric Trials Network, www.pediatrictrialsnetwork.org, is conducting several antimicrobial trials in neonates with the goal of improved dosing and label guidance. A few antimicrobial drugs have been associated with serious toxicity, as shown in Table 37.1, and therefore their use in neonates is discouraged in developed countries. The most notable on this list is chloramphenicol. Chloramphenicol has been associated with circulatory collapse, otherwise known as gray baby syndrome, and death in infants resulting from drug accumulation after excessive dosages. This complication can be traced to immaturity of the glucuronal transferase activity in the fetus and young newborn infants, coupled with diminished renal function. Chloramphenicol toxicity appears to be related to impaired mitochondrial protein synthesis, as well as to direct inhibition of myocardial contractile activity. Because this toxicity results from free drug accumulation, multiple exchange transfusions or charcoal hemoperfusion may reverse the clinical syndrome by removing the free drug from the blood. Anemia resulting from dose-related marrow suppression is the most common untoward reaction to chloramphenicol. However, Severe idiosyncratic bone marrow aplasia occurs in approximately 1 in 40,000 patients of all ages receiving the antibiotic. Pause the video and carefully scrutinize Table 37(1) suamorizing drugs not routinely used in neonates before advancing to the next slide. We will now discuss the basic principles of clinical pharmacology. The rapidly changing physiologic processes characteristic of fetal and neonatal development profoundly affect the pharmacokinetic properties of antibiotics. Maturation affects total body water, drug metabolism, and drug elimination. Gastric absorption is highly variable. These changes can result either in subtherapeutic drug concentrations, thereby delaying bacterial eradication, or in toxic drug concentrations that cause morbidity. Common pharmacokinetic terms and abbreviations are defined in Table 37(2). The pharmacokinetics of a drug describes the relationship between drug dose and subsequent concentration in the blood over time. 4 basic components explain the pharmacokinetics of a drug include absorption, distribution, metabolism, and excretion. Absorption of drugs administered at extravascular sites typically occurs by passive diffusion across biologic membranes. This process is affected by chemical properties of the drug, such as its molecular weight, ionization, and lipid solubility, as well as by physiologic factors, such as local pH and blood flow, which undergo developmental changes as the newborn matures. The severity of infections and the inconsistent absorption after extravascular administration warrant that most antimicrobial therapies be delivered by the intravenous route in developed countries. Oral absorption of antimicrobial agents is difficult to predict and can only be determined by carefully executed experiments. Bioavailability describes the fraction of an administered dose of a drug that reaches the systemic circulation. By definition, IV medications have 100% bioavailability. However, oral medications have decreased bioavailability because of incomplete absorption and first-pass hepatic metabolism. Unique neonatal features that impact absorption change with gestational and chronologic age include the alkaline gastric pH, slow gastric emptying, high gastrointestinal to whole body surface area ratio, increased permeability of bowel mucosa, irregular peristalsis, prolonged intestinal transit time, differences in first-pass hepatic metabolism, and the deconjugational activity of the intestinal enzyme beta-glucuronidase. Intramuscular absorption of antimicrobial agents is generally comparable to IV administration. However, substantial differences can exist because IM antibiotic absorption is dependent upon regional blood flow. IM absorption can be profoundly reduced in infants with hypoxia, hypotension, or poor tissue perfusion. After drug absorption into the bloodstream, the dose of a drug is distributed into all of the body compartments and tissues that the product is physically able to penetrate, including water compartments and adipose tissue. This distributive phase is typically rapid, and the drug is said to distribute into its volume of distribution, or volume of distribution. This volume is considered hypothetical because it is based on sampling drug concentrations in serum or plasma after dosing. Interpretation of these samples requires the assumption that the drug is uniformly distributed throughout the body. However, drugs do not distribute in a uniform fashion. Drugs that are water-soluble or highly bound to plasma proteins have a high plasma concentration and a low volume of distribution because the drug tends to remain in the blood. Drugs that are lipid-soluble or bind extensively to tissue are present in the plasma in low concentrations, and therefore have large volumes of distribution. Volume of distribution in the neonate is usually larger than in children, and premature infants larger than term infants, because of the larger extracellular water compartment in neonates. The extracellular fluid volume in newborns is considerably greater than that in children and adults. In the first 3 months of life, it decreases substantially and then remains nearly constant throughout infancy and early childhood. Extracellular fluid volume is also increased with prematurity so that peak serum concentrations are lower in preterm infants compared to term infants after similar dosages. Expanded extracellular volumes prolong drug elimination and lead to longer half-lives. The clinical application of these concepts is particularly relevant to aminoglycosides because the efficacy is associated with the peak concentration, whereas toxicity is associated with trough concentrations. Protein binding can also impact drug distribution and elimination. Quantitative and qualitative differences exist between the serum proteins of newborns and those of older infants. These differences affect the degree to which antimicrobial agents are protein-bound. Variables that impact protein binding include concentrations of plasma proteins, such as albumin, concentration of drug affinity for protein binding sites, presence of competing substances for protein binding sites, e.g., furosemide, bilirubin, and plasma pH. Protein-bound drug has negligible antibacterial activity and remains in the intravascular space with limited distribution into tissue and limited excretion. Because only free drug is active and available for elimination, changes in protein binding can dramatically affect exposure and efficacy. Protein binding for some antibiotics is lower in neonates than in adults, so extrapolation is not advised, and the pharmacokinetics of the free drug needs to be determined. Some antibacterial agents are capable of displacing bilirubin from albumin binding sites, including the sulfonamides and ceftriaxone. Theoretically, jaundiced neonates receiving these antibiotics are at increased risk of developing kernicterus. This complication, however, has been documented only for sulfonamides. Most antimicrobial drugs do not displace bilirubin because most have a much lower binding affinity for albumin than bilirubin, and thus the extent of protein binding by an antibiotic does not necessarily correlate with bilirubin displacement. Drugs start to be eliminated from the body as soon as they are delivered. If doses are given at a rate that balances the drug clearance rate, then target steady-state drug concentrations can be maintained. Drug clearance represents the volume of blood, serum, or plasma completely cleared of drug per unit of time and has the units of volume over time, for example, liters per hour or milliliters per minute, or liters per hour per kilogram for weight normalized clearance. Clearance is not only related to infant size, liters per hour per kilogram, but also to clinical characteristics, such as renal disease, hepatic disease, and drug interactions. Clearance of water-soluble drugs usually occurs via excretion into the urine, whereas lipid-soluble drugs are often metabolized to water-soluble metabolites by the liver before they can be excreted. Drug elimination occurs through hepatic metabolism, renal excretion, or both, and is affected by physiologic maturation. 6 Hepatic metabolism involves chemical transformation of the drug into a form that is more fat-soluble for elimination in the bile and feces or a form more water-soluble for elimination by the kidneys. The ontogeny of the cytochrome P450 metabolizing enzymes in newborn development has been evaluated and reviewed. Newborns are at risk for toxicity from drug accumulation because of deficiencies in hepatic glucuronal transferase or hepatic esterases. Drugs can also induce P450 enzyme production, leading to drug interaction. Phenobarbital stimulates hepatic enzyme production, thereby increasing the clearance and lowering serum concentrations of some drugs, including anticoagulants, corticosteroids, phenytoin, metronidazole, and theophylline. Renal elimination of active drug or metabolites occurs via glomerular filtration and/or tubular secretion. Some drugs are reabsorbed in renal tubules, thus further altering their elimination rate. Renal function varies with gestational age, abbreviated as GA, postnatal age, abbreviated as PNA, and postmenstrual age, abbreviated as PMA. Neonatal abbreviations are reviewed in Table 37.2. The constant state of renal function fluctuation has a profound impact on antibiotic pharmacokinetics. In newborns, the glomerular filtration rate is 30% to 60% of adult levels. A remarkable increase in renal function occurs over the first 2 weeks of life. As a result, sustained serum concentrations and prolonged half-life values of many drugs eliminated through the kidneys are observed in the first days of life. After birth, renal function improves more slowly in premature infants, leading to prolonged drug elimination over the first few weeks of life. Drug elimination is also reduced in sick infants because of decreased renal blood flow resulting from respiratory insufficiency, hypotension, or dehydration. For example, hypoxemic infants have a prolonged serum half-life, abbreviated as T-half, of aminoglycosides. Therapeutic hypothermia is associated with reduced hepatic clearance of morphine. Because renal function is constantly changing in the first month of life and with advancing gestational age, a pharmacokinetic profile needs to be determined on multiple occasions during this period to define the proper dosage and frequency of administration of an antibiotic. Most drugs are cleared through first-order elimination. This means that a constant proportion of drug is cleared per unit of time. Initially, there is a steep fall in concentration, after which the decline becomes shallower as the amount of drug remaining decreases. When the concentration time profile is plotted on a log linear scale, the decline is linear because the shape of the relationship between concentration and time is described by an exponential function. The elimination rate constant, Ke, is the ratio of clearance to volume of distribution and is usually expressed in units of liters per hour. Each patient has their own unique elimination rate constant, Ke, that reflects the clearance and volume of distribution of the drug. The elimination rate constant can be converted into the clinically meaningful concept of drug half-life, the time it takes for the concentration of a drug to fall to half. See Table 37.2. Half-life estimates are patient-specific. For drugs eliminated by first-order kinetics, the elimination rate constant represents the ratio of drug clearance and volume of distribution. For patients with renal insufficiency, delayed renal clearance of gentamicin will result in a half-life that can be 3 times as long as patients with normal renal function. Patients with fluid overload have a large volume of distribution and a longer half-life and therefore may need to receive a higher dose of medication less frequently. Pause the video and carefully scrutinize Table 37.2 summarizing common pharmacokinetic and neonatal terminology before advancing to the next slide. And now we will discuss optimizing antimicrobial therapy using PK/PD principles. Optimizing antimicrobial therapy in neonates requires a thorough understanding of the relationship between dose and exposure, that is pharmacokinetics, and between exposure and optimal response to therapy, that is pharmacodynamics. Our goal is to provide an integrative approach using knowledge from microbiology, minimal inhibitory concentration, abbreviated as MIC, minimal bactericidal concentration, abbreviated as MBC, pharmacokinetics, and pharmacodynamics, such that we can have a high probability that a specific dose of an antibiotic can cure a particular infection in a defined population of infants. Carefully designed clinical trials can then be performed to confirm the results of such an integrative modeling and simulation approach. And now we will discuss minimal inhibitory concentration. The in vitro drug susceptibilities of commonly encountered bacterial pathogens allow comparison of potencies for eradication. Ideally, both the MIC and the MBC should be determined. To account for the great variation in pathogens and susceptibilities in different nurseries and geographic regions, this knowledge can be generated for each specific newborn unit. The higher the MIC, the more difficult it is to eradicate a pathogen with that drug, even if the MIC falls within the established sensitivity range. We will now focus on pharmacokinetic data. New analytic techniques and the computer algorithms for population pharmacokinetic model analysis have made PK evaluation of drugs in infants more feasible. Pharmacokinetics explains the relationship between drug dose and the concentration of drug in the plasma or serum over time. Pharmacokinetic studies are performed after a single dose and after multiple doses to determine concentrations at steady state. Drug levels can now be measured using mass spectroscopy in as little as 0.1 milliliters obtained by heel stick. For drugs that exhibit protein binding, it is important to measure the quantity of total and non-protein bound drug. Subsequently, multiple serum samples are obtained to determine concentrations of the drug at a given time after the dose. The serum half-life, T-half, and volume of distribution are calculated by plotting the serum concentration time curves and calculating the clearance, a measure of the disappearance of drug from serum. Population pharmacokinetic analysis allows investigators to study a medication in a diverse group of preterm and term infants of different ages, so that changes in drug clearance and volume of distribution can be explained by maturational covariates, GAR at birth, PNA, PMA reviewed in Table 37-2, weight, or renal function in a mathematical model. Monte Carlo simulation using these models of drug clearance and volume of distribution is used to predict and compare drug exposure from different dosing regimens to provide dose adjustments for maturational changes in an infant. It is clinically important to determine the active drug concentrations in the cerebrospinal fluid, CSF. Central nervous system, CNS, penetration of drugs is usually expressed as the fraction of CSF drug concentrations divided by the plasma or serum concentrations, because most studies link a single cerebrospinal fluid sample with a simultaneous blood sample. In the 1980s, new antibiotics were tested in a rabbit model of meningitis before use in infants to determine the cerebrospinal fluid penetration and bactericidal activity of the drug against commonly encountered meningeal pathogens. More data are needed to understand the cerebrospinal fluid penetration of antimicrobial drugs in the presence or absence of meningitis in neonates. Some current antimicrobial trials are attempting to collect cerebrospinal fluid from standard of care sampling to measure drug levels in cerebrospinal fluid. Although CSF concentrations represent the closest approximation of drug concentration in the CNS, they only represent one compartment and can underrepresent drug exposure in brain parenchymal tissue. Amphotericin and echinocandins have been used successfully to eradicate CNS fungal infections, yet they are detected at very low levels in the CSF. Drugs cross the blood-brain and blood-CSF barrier through diffusion and transport systems. Efflux channels can remove drugs from the CSF. CNS infection also tends to cause an increase in permeability of the blood-brain and blood-CSF barriers. In addition to CSF evaluation, it remains important to consider the physiochemical properties of the drug, including molecular size, lipophilicity, plasma protein binding, and active transport mechanisms. Higher serum exposures are often warranted when treating CNS infections to allow for drug entry into both the parenchymal tissue and the CSF. Intraventricular therapy is traditionally avoided if systemic therapy is available because studies of intraventricular aminoglycosides administration show an association with threefold increase in mortality compared with standard treatment with IV antibiotics alone. Next we will discuss pharmacodynamics. Pharmacodynamics equations describe the relationships between the drug concentration time profile and the ability to eradicate the organism, prevent emerging resistance, and minimize adverse effects. Dose and dosing interval determine the minimum concentration, maximum concentration, and overall drug exposure per 24-hour interval. 24-hour area under the concentration time curve is equal to AUC 24, shown in Figure 37.1. Bacterial eradication is typically evaluated in relation to the maximal drug concentration, the AUC, or the percentage of dosing interval time that the drug concentration is above a minimum threshold, as determined by the MIC of the target organism. See Figure 37.1. We will now switch gears to pharmacokinetic pharmacodynamic approach. To achieve the best therapeutic response, drug dose should be related to antimicrobial effect through an integrated pharmacokinetic pharmacodynamic approach, in which a dose is chosen to target a therapeutic drug concentration relative to the MIC of the offending organism. Three important PK parameters are the peak serum level, C max, the trough level, C mean, and the AUC. See tables 37.2 and 37.3. See Figure 37.1. These pharmacokinetic pharmacodynamic parameters are used to quantify the activity of an antibiotic. Antimicrobial agents are typically associated with one of three patterns of activity. See Table 37.3 and Figure 37.1. 1. Those that exhibit concentration-dependent killing and prolonged persistent post-antibiotic effects, abbreviated as PAEs, and thus achieve optimal killing when the maximum concentration exceeds a threshold peak to MIC ratio. 2. Agents that exhibit time-dependent killing patterns and therefore achieve optimal killing when the duration of drug exposure above AMIC exceeds a percentage of time, T, greater than the MIC, and 3. Agents that are most effective when the maximal total drug exposure exceeds a threshold AUC to MIC ratio. Threshold pharmacokinetic pharmacodynamic therapeutic exposure targets are determined through in vitro experiments, animal models, and human studies that relate drug exposure to MIC and efficacy. Pause the video and carefully scrutinize Figure 37.1 illustrating effects of dose, in milligrams per kilogram, dosing interval and route of administration on total drug exposure, as defined by the AUC and its relationship to the minimal inhibitory concentration, abbreviated as MIC, of the pathogen being treated before advancing to the next slide. Pause the video and carefully scrutinize Table 37.3 summarizing pharmacokinetic pharmacodynamic relationships for optimal antimicrobial treatment before advancing to the next slide. And now we will focus on placental transport of antimicrobial drugs. Antimicrobial agents are prescribed for approximately 20% of pregnant women, and many of these drugs are given at the end of pregnancy for amnionitis or intrauterine bacterial infections. Understanding placental transport is therefore an important component of antimicrobial therapy in the neonate. Drugs may be transported across the placenta either passively, by simple diffusion, or actively through energy-dependent processes. Factors influencing transplacental passage include lipid solubility, degree of ionization, molecular weight, protein binding affinity, surface area of the fetal-maternal interface, placental blood flow, stage of pregnancy, and placental metabolism. Drug transport across the placenta changes greatly with advancing gestational age because of the thickness of barrier and also differential expression of drug transporters. Placental drug biotransformation ensues by oxidation, reduction, hydrolysis, or conjugation with endogenous chemicals. In addition, antibiotics can concentrate to various degrees in fetal tissues, depending on lipid solubility, specific binding to biologic constituents, changes in fetal circulation, and gestational age. Many antimicrobial drugs rapidly cross the placenta, as shown Table 37.4. Maternal serum concentrations are usually lower than those reported in non-pregnant women because of larger plasma VD and an increased renal clearance during pregnancy. As a result of differences in maternal dosage, route of administration, gestational age, timing of sample collection, and methods of measuring antimicrobial activity, a wide range of serum values for pregnant women and infants and of percentages of transplacental penetration is obtained for most drugs. Most penicillins and cephalosporins are considered compatible with pregnancy, typically cross the placenta rapidly, and quickly achieve fetal levels that approach or even exceed those in maternal serum. The high and rapidly attainable fetal penicillin serum concentrations explain, in part, the benefit of intrapartum administration of penicillins to pregnant women colonized with group B streptococci in reducing early-onset neonatal sepsis. Antibiotics with lower transplacental penetration with fetal to maternal ratios of 10% to 50% include dicloxacillin, erythromycin, nafcillin, and aminoglycosides. Serious adverse fetal and maternal events have been associated with antibiotic use in pregnancy. Examples include kernicterus, in the case of sulfonamides, ototoxicity, in the case of streptomycin, inhibition of infant bone growth, tetracyclines, and discoloration of teeth, in the case of tetracyclines. Anecdotal clinical experience is not sufficient to assess properly the safety of antibiotic administration during pregnancy. Rather, carefully planned prospective toxicity studies in the fetus and neonate, first in animals and then in humans, are warranted. Briggs and co-workers published an up-to-date online reference that allows searching for a drug of interest by name and provides succinct summaries of the research on drugs used in pregnancy and lactation and provides pregnancy recommendations and fetal risk summaries. Aminoglycosides are considered low risk in pregnancy, although caution is especially advised for kanamycin and streptomycin. Aminoglycosides rapidly cross the placenta into the fetal circulation. Eighth nerve toxicity in the human fetus has been reported after exposure to kanamycin and streptomycin but not other aminoglycosides. Although possible, ototoxicity has not been directly reported after fetal exposure to tobramycin, amikacin, and gentamicin. Carbapenems are considered low risk in pregnancy based on animal data and sparse human data. Imipenem C. Lastatin crosses the placenta and achieves fetal levels of about 30% of that seen in maternal circulation. No significant fetal toxicity has been observed in different animal models. Placental transfer of meropenem has apparently not been studied. However, the molecular properties of the drug suggest placental transfer will occur with subsequent distribution into the fetus. Pause the video and carefully scrutinize Table 37(4) summarizing transplacental passage of antimicrobial agents before advancing to the next slide. We will now shift gears to medications contraindicated or considered to be high risk in pregnancy. Sulfonamides should be avoided in the third trimester, particularly if close to delivery. Sulfonamides cross the placenta and the fetal levels are 70% to 90% of maternal levels after 2 to 3 hours. Significant fetal levels can persist for several days after birth. Fetal toxicities include jaundice, hemolytic anemia, and, theoretically, kernicterus. Tetracyclines are associated with both maternal and fetal risk and are therefore contraindicated in pregnancy, particularly in the second and third trimester. Tetracycline-induced hepatotoxicity is a rare, although serious, adverse event that does not spontaneously resolve after delivery of infant. Tetracyclines readily cross the placental barrier and concentrate in many tissues of the developing fetus. Of particular interest is the deposition of tetracycline in fetal bones and deciduous teeth. Calcification of deciduous teeth begins during the 4th month of gestation, and crown formation of the anterior teeth is almost complete at term. Tetracycline administered during this gestational period produces yellow discoloration, enamel hypoplasia, and abnormal development of those teeth. These effects have been documented for tetracycline, oxytetracycline, and dimethylchlortetracycline. Chloramphenicol crosses the placenta and achieves fetal levels 30% to 100% of maternal levels. Chloramphenicol use in pregnancy has not been associated with major or minor fetal anomalies. However, chloramphenicol is not recommended in newborns because it has been associated with circulatory collapse, also known as gray baby syndrome, and death. Therefore, many suggest that chloramphenicol should only be administered to pregnant women near term with caution and if alternative medicines are not available. The use of metronidazole in pregnancy is controversial because the drug is mutagenic in bacteria and carcinogenic in rodents. However, these properties have not been shown in humans. Most published evidence suggests that metronidazole does not pose significant risk. However, carcinogenic potential cannot be excluded. The use of metronidazole for trichomoniasis or vaginosis during the second and third trimester is acceptable. For other indications, alternative drugs with acceptable profiles would be preferred. We will now focus on antiviral and antifungal medications in pregnancy. Many antiviral medications can be administered to pregnant women, particularly when the maternal benefit outweighs the potential for fetal risk. Valacyclovir and acyclovir are the most common antiviral medications used in pregnancy, often administered to women for treatment or prophylaxis of genital herpes infections. No increase in fetal abnormalities has been ascribed to acyclovir. Because valacyclovir is quickly converted to acyclovir, the placenta and fetus are most exposed to acyclovir. Acyclovir readily crosses the placenta and achieves a cord blood to maternal ratio of approximately. Pregnancy is also a risk factor for morbidity and mortality caused by severe influenza infections. Oseltamivir is recommended in pregnant women with influenza to decrease mortality and hospital intensive care unit admission. Oseltamivir exhibits low transplacental permeability to the fetus, with fetal concentrations predicted to be less than 20%, with even lower concentrations of the active drug oseltamivir carboxylase. Drug transporters may be important in the apparent restrictive placental transfer of oseltamivir and its metabolites. Case series and a review of the Roche Company safety database suggest that oseltamivir is unlikely to cause adverse pregnancy or fetal outcomes, but available data are limited. Ganciclovir is rarely indicated in pregnancy, and its use is restricted to pregnant women with severe cytomegalovirus, abbreviated as CMV, infections, typically in immunocompromised pregnant women. Both ganciclovir and valganciclovir are associated with concerns for bone marrow toxicity and animal reports of mutagenesis. Very rare cases of ganciclovir used during pregnancy of women with a history of organ transplant have described healthy infant outcomes. Most antifungal medications must be used with caution in pregnant women. Amphotericin B is the only antifungal agent thought to be compatible with pregnancy. Amphotericin does cross the placenta with cord blood to maternal serum ratios ranging from 40% to 100%. No evidence of adverse fetal effects has been reported. Alternatively, fluconazole at doses greater than or equal to 400 mg per day in the first trimester is associated with teratogenicity in human and animal models, similar to the skeletal anomalies seen in Antley-Bixler syndrome. Exposure to short-course, low-dose fluconazole has not been associated with increased congenital anomalies. Fluconazole is a small enough molecule that placental transfer is expected. However, placental transfer across the human placenta has not been evaluated. The echinocandin class of antifungal medications has not been adequately studied in pregnancy. Animal data suggest moderate risk for embryo toxicity and teratogenicity. The physical-chemical properties of caspofungin and micafungin, specifically their relatively large size, low lipid solubility, and high protein binding, may limit placental transfer. However, given the absence of human data and suggestion of risk in animal models, most clinicians would attempt to avoid echinocandins, specifically in the first trimester if alternative agents are available. We will now focus on excretion of antibiotics in human milk. Postpartum women are often prescribed an antibiotic. However, the concentration of antimicrobial agents in breast milk is typically so low that neither therapeutic nor harmful effects are likely to occur. The amount of drug could be significant if the drug accumulates in breast milk, the infant ingests a large volume of milk, infant feeding times correlate with maximal maternal plasma concentrations, or the drug has reasonable bioavailability in the infant. Assessment of the safety of antibiotics in milk has relied primarily on anecdotal clinical experience, rather than on carefully controlled long-term studies. Two important, updated and referenced sources of information to aid clinicians about medications in breastfeeding mothers are LactMed from the National Library of Medicine, http://toxnet.nlm.nih.gov/cgi-bin/cis/htmlgen, LACT, and Dr. Thomas Hale's Medications and Mother's Milk, http://www.medsmilk.com/. Most drugs are transferred into breast milk by passive diffusion, exocytosis, or reverse pinocytosis. Factors influencing the transfer of antibiotics from plasma to milk include maternal serum concentration of unbound drug and the physiochemical properties of the drug, for instance, molecular weight, lipid solubility, degree of ionization, and protein binding capability. Small, lipid-soluble, non-ionized drugs traverse the lipid bilayers into milk more readily than larger, ionized, water-soluble drugs. Although drugs with high lipid solubility tend to accumulate in milk, the extent varies with the fat content of the milk. The ionization power of drugs depends on the pH of the milk and the drug dissociation constant, abbreviated as pKa. Weak bases become more ionized with decreasing pH. Early postpartum human milk has a pH of 7 to 7.1, whereas mature milk after 2 weeks has a pH of approximately 7.3 to 7.4, each compared with the normal serum pH of 7.35 to 7.45. Therefore, drugs that are weak bases, pKa greater than pH, such as erythromycin, isoniazid, metronidazole, and tetracyclines, would be expected to ionize and accumulate in the lower pH environment of colostrum. Weak acids, such as ampicillin, are more likely to be ionized in maternal serum and therefore not transferred at high levels into breast milk. Drugs that are highly serum protein bound, such as ceftriaxone, tend to remain in the intravascular space in the maternal circulation. Data pertaining to antibiotic concentrations in the colostrum are not available. Because blood flow and permeability are increased during the colostral phase, it is possible that these drugs are present in concentrations equal to or greater than those found in mature milk. The maternal serum and breast milk concentrations of commonly used antimicrobial agents have been reviewed. Milk-to-plasma ratios show considerable variability because of the extremely small number of women studied and the differences in age, gestation, dosing regimen, and underlying pathophysiology. In general, the concentrations of metronidazole, sulfonamides, and trimethoprim in breast milk are similar to those in maternal serum, milk-to-serum ratio of 1, whereas those of chloramphenicol, erythromycin, and tetracycline are approximately 50% of maternal serum values. The concentrations of penicillin, oxacillin, various cephalosporins, and aminoglycosides in milk are low. Although the milk-to-plasma ratio is frequently quoted to predict drug distribution into breast milk, its utility for those drugs with higher milk-to-serum ratios is suspect. The milk-to-plasma ratio is typically obtained at a single point in time. However, the concentration of drug in breast milk and plasma is not constant, and the ratio of milk-to-plasma concentrations varies greatly over time. Most studies are not performed at steady state. Furthermore, most studies usually do not expose the infant to the breast milk and cannot comment on infant systemic exposure. Instead, Chung and co-workers recommend that the milk-to-plasma ratio be used as a qualitative estimate of the possible magnitude of infant drug exposure. By taking the peak breast milk concentration and an assumed ingestion of breast milk intake, 150 milliliters per kilogram per day, they have derived an estimated potential infant dose correlated with predicted infant exposure, as shown in Table 37.5. In addition, infant maturity, developmental characteristics of drug disposition, and tolerance of drug when given directly to the infant, and the possible extent to which the drug may modify the infant's intestinal gut flora need to be taken into consideration. Most drugs are predicted to yield limited exposure to newborns. See Table 37.5. Penicillin, amoxicillin, ampicillin, ticagrelin, cephalosporins, and aminoglycosides are detected in very low concentrations in breast milk. Clavulanic acid was not detected in breast milk. One study observed higher than expected concentrations of ceftazidime in breast milk from women receiving a high-dose regimen at steady state. The predicted infant ceftazidime exposure remains limited, especially given the poor bioavailability of ceftazidime. The overall tolerability profile of penicillin and cephalosporins, along with the low concentration of these drugs in breast milk, support their use in breastfeeding infants. The rare possibility of hypersensitivity reactions or altered intestinal flora-associated diarrhea in breastfeeding infants remains a theoretical concern. Broad-acting agents should be reserved for the most serious infections. A recent review of antibiotics in breastfeeding reported personal communication with Merck of limited data on detectable low levels of imipenem in breast milk of women, typically 0.2 to 0.5 microgram per milliliter. Cilastatin was not detected. Despite this low exposure in breast milk, infant exposure would be further limited by poor bioavailability and drug inactivation at alkaline or acidic pH. Meropenem is also detected at very low levels in breast milk, with a maximal infant exposure reported to be less than 1%. The physiochemical properties of aztreonam suggest limited transfer into breast milk, because it is inactivated in acidic solutions and exhibits moderate protein binding and low lipid solubility. Single-dose PK studies confirmed a minimal amount of aztreonam in breast milk of women. The physiochemical properties of fluoroquinolones, weak acid, low molecular weight, high lipid solubility, low protein binding, and good bioavailability, suggest that fluoroquinolones can accumulate in breast milk. However, the predicted infant dose exposure is limited to 2% to 6%. See Table 37.5. A case report of one infant revealed negligible ciprofloxacin infant serum concentrations, that is less than 0.03 microgram per milliliter, despite accumulation in breast milk after 10 days of maternal exposure. Maternal serum, 0.21 mg per milliliter, breast milk, 0.98 microgram per milliliter. This report highlighted the difficulty of predicting infant exposure from maternal plasma and milk concentrations. The risk of fluoroquinolone-induced arthropathies or cartilage erosion in neonates has not been explored. The predicted fluoroquinolone exposure to an infant is predicted to be negligible, and the American Academy of Pediatrics, abbreviated as AAP, and Hale's medications in mother's milk have determined that the medication is usually compatible with breastfeeding and moderately safe. Sulfonamides and tetracycline both distribute relatively poorly into breast milk, yet have theoretical concerns for associated adverse events in neonates. The amount of sulfamethoxazole and tetracyclines in breast milk is low and of unclear clinical significance. One breastfed infant with glucose 6-phosphate dehydrogenase, abbreviated as G6PD, deficiency experienced hemolytic anemia while the mother was receiving sulfamethoxypyridazine. The adverse effects of tetracyclines on developing teeth and bones are well documented when the drug is given directly to infants and children. However, the limited exposure in breast milk has not been directly associated with abnormalities. The AAP and Hale agree that most sulfamethoxazole, with trimethoprim, and tetracyclines are usually compatible with breastfeeding and moderately safe. Caution is advised for infants with jaundice, glucose 6-phosphate dehydrogenase deficiency, severe illness, or significant prematurity. Macrolides, including azithromycin and clindamycin, distribute into breast milk. However, the actual amount the infant would receive from breastfeeding remains very small. See Table 37.5. Neonatal exposure may be further limited by bioavailability. One case report of erythromycin-induced pyloric stenosis during breastfeeding exposure in a 3-week-old infant has been reported. One report incriminated the administration of clindamycin to a mother in the development of antibiotic-induced colitis in her breastfed infant. The AAP has described erythromycin and clindamycin as usually compatible with breastfeeding and moderately safe. Azithromycin is likely to be compatible with breastfeeding as well. Metronidazole effectively distributes into breast milk and achieves infant plasma concentrations approximately 1/5 of the exposure observed in the mother's plasma. The relative infant dose is estimated to be 13% of maternal dose, and metronidazole has been detected in infant plasma. Given the mutagenesis and carcinogenicity in animal models, its use in lactation is controversial. Breastfed infants whose mothers were administered metronidazole therapy had no difference in adverse events compared with infants whose mothers received ampicillin or no antibiotics. The AAP considers metronidazole to have an unknown effect on nursing infants, but may be of concern. Hale, on the other hand, reports metronidazole as safer, and thus usually compatible with breastfeeding. The decision to allow or stop breastfeeding is based on the likelihood that high milk concentrations are attained for a particular antibiotic, whether the drug is expected to be absorbed into neonatal plasma, and whether significant adverse events are commonly associated with this agent. Online resources are now available to rapidly review the most up-to-date knowledge about specific drugs and their use in lactating mothers. In general, the severity of the woman's infection, rather than the drug that she is receiving, most often is the more important contraindication to breastfeeding. Pause the video and carefully scrutinize Table 37.5, which contains a summary of reported breast milk concentrations of selected antibiotic and estimated maximal potential infant daily dose for medications that distribute into breast milk before advancing to the next slide. We will now focus on penicillin. Penicillin has been used for treatment of neonatal bacterial infections for more than 3 decades. It is safe and well tolerated. However, its efficacy is limited by the development of resistance. Many species of streptococci, Listeria monocytogenes, meningococci, and Treponema pallidum remain susceptible to penicillin, whereas most species of Staphylococci, pneumococci, and gonococci have become resistant. And now WQE will look at microbiologic activity. Penicillin and other beta-lactam derivatives interfere with bacterial cell wall synthesis by reacting with one or more penicillin-binding proteins, abbreviated as PBPs, to inhibit transpeptidation. The transpeptidase activity of penicillin-binding proteins is essential for cross-linking adjacent peptides and for incorporating newly formed peptidoglycan into an already existing strand. Subsequently, this event promotes bacterial cell lysis. Several mechanisms of bacterial resistance to penicillin and other beta-lactams have been identified. The most important is by inactivation through enzymatic hydrolysis of the beta-lactam ring by beta-lactamases. These enzymes are produced by most Staphylococci and enteric gram-negative bacilli and by many Neisseria gonorrhoeae strains. Another mechanism of resistance involves decreased permeability of the outer membrane of gram-negative bacteria, which can prevent this drug from reaching its target site. In addition, by poorly defined mechanisms, some group B streptococci are inhibited but not killed by penicillin, a phenomenon termed tolerance. The first group B streptococci isolates with elevated MIC to beta-lactamase antibiotics by a mutation in the penicillin binding protein have recently been described. Usual MICs of penicillin against streptococci are between 0.005 and 0.1 microgram per milliliter. For T. pallidum, the corresponding concentration ranges are between 0.02 and 0.2 microgram per milliliter. Many pneumococcal strains isolated around the world are considered to be relatively, that is MICs of 0.1 to 1 microgram per milliliter, or highly, that is MICs of 2 micrograms per milliliter or greater, resistant to multiple antibiotics, including penicillins, macrolides, and third-generation cephalosporins. We will now focus on pharmacokinetic data of penicillin. Most of the penicillin dose is excreted in the urine in unchanged form. Tubular secretion accounts for approximately 90% of urinary penicillin, whereas glomerular filtration contributes the remaining 10%. Biliary excretion also occurs, and this may be an important route of elimination in newborns with renal failure. A review of the clinical pharmacokinetics of penicillin in neonates has recently been published and serves to reference historical publications. We will now focus on aqueous penicillin G, a mean peak serum concentration of 24 micrograms per milliliter, range 8 to 41 micrograms per milliliter, is observed after a dose of 25,000 units per kilogram of penicillin G is given intramuscularly to infants with birth weights of less than 2,000 grams. The peak values do not change appreciably with increasing birth weight or chronologic age up to 14 days. After a dose of 50,000 units per kilogram, peak serum values of 35 to 40 micrograms per milliliter were detected in neonates of different ages. The concentrations at 4 and 8 hours after the dose were not substantially different from those after a dose of 25,000 units per kilogram. The half-life of penicillin in serum becomes longer in smaller and younger infants. Half-life values of 1.5 to 10 hours are observed in the first week of life, with the longer half-lives being in the smallest infants, having birth weights less than 1,500 grams. A shorter half-life of 1.5 to 4 hours was observed after 7 days of age. The half-life of penicillin also decreases as creatinine clearance improves. Next we will discuss procaine penicillin G. In the first week after birth, a 50,000 units per kilogram IM dose of procaine penicillin G produces mean serum values of 7 to 9 micrograms per milliliter for up to 12 hours and a 24-hour trough concentration of 1.5 micrograms per milliliter. Older neonates have lower 24-hour trough concentrations, that is 0.4 microgram per milliliter, because of their increased clearance and shorter half-lives. These serum values are approximately twice those obtained in the original study, that is 22,000 units per kilogram, and suggest a linear relationship between dose and serum concentration. No accumulation of penicillin in serum is observed after 7 to 10 days of daily doses of procaine penicillin G. The drug was well tolerated, without evidence of local reaction at the site of injection. Next we will look at benzathine penicillin G. Penicillin can be detected in serum and urine for up to 12 days after a single IM injection of 50,000 units per kilogram of benzathine penicillin G in newborns. Peak serum concentrations of 0.4 to 2.5 micrograms per milliliter, that is a mean of 1.2 micrograms per milliliter, are observed 12 to 24 hours after administration, and levels of 0.07 to 0.09 microgram per milliliter are present at 12 days. This preparation has been well tolerated by infants. Muscle damage from IM injection as judged from creatinine values does not appear to be appreciably different from that after IM administration of procaine penicillin. We will now discuss cerebrospinal fluid penetration. Penicillin does not penetrate CSF well, even when meninges are inflamed. Peak concentrations of 1 to 2 micrograms per milliliter occur after an IV dose of 40,000 units per kilogram of penicillin G is given to infants and children with bacterial meningitis. Although these values are 2% to 5% of concomitant serum concentrations, the concentrations exceed the mic values for streptococci and susceptible pneumococci by 50 to 100-fold. CSF concentrations of penicillin are not optimal to treat neonatal meningitis caused by penicillin-resistant pneumococci. CSF concentrations decrease as meningeal inflammation is reduced. Concentrations of penicillin in CSF during the first several days of therapy are maintained in the range of 0.5 to 1 microgram per milliliter. Thereafter, the values are 0.1 microgram per milliliter or less by 4 hours after the dose. Procaine penicillin G administered by IM injection in newborns provides sufficient CSF exposure for the treatment of congenital neurosyphilis. Procaine penicillin G administered intramuscularly at a dose of 50,000 units per kilogram provides mean CSF concentrations ranging from 0.12 to 0.7 microgram per milliliter between 4 and 24 hours after a dose. These CSF values are at least several-fold greater than the required minimal spirochecidal concentration. Benzathine penicillin G does not provide adequate CSF exposure and is not recommended for the treatment of congenital neurosyphilis. We will now briefly discuss safety. All forms of penicillin are typically well tolerated in newborns. Cutaneous allergic manifestations to penicillin are rare in the newborn and young infant. And now we will consider PK/PD and clinical implications for dosing. Penicillin remains effective for therapy for infections caused by group B streptococci and Treponema pallidum. The dosage recommended for neonatal sepsis or pneumonia is 50,000 to 100,000 units per kilogram per day administered in 2 to 4 divided doses, whereas that for meningitis is 250,000 to 450,000 units per kilogram per day in 2 to 4 divided doses, depending on birth weight and chronologic age. The PD target for beta-lactam antibiotics is the T greater than mic. The trough penicillin levels ideally will remain above the MIC for streptococci. Penicillin remains effective therapy for congenital syphilis. However, because CNS involvement in congenital syphilis is difficult to exclude with certainty, benzathine penicillin G is not routinely used for therapy. Benzathine penicillin G is reserved for asymptomatic infants with normal findings on CSF examination and radiographic studies and who have positive results on treponema serologic studies, presumably from maternal origin, and only if follow-up can be ensured. For symptomatic infants and for asymptomatic infants with laboratory or radiologic evidence suggestive of congenital syphilis, the recommended regimen is either aqueous crystalline penicillin G, 100,000 to 150,000 units per kilogram per day, divided every 12 hours for first 7 days and then every 8 hours thereafter, and administered IV for 10 to 14 days. Alternatively, procaine penicillin G, 50,000 units per kilogram per day, can be administered intramuscularly for at least 10 days. We will now focus on ampicillin. Let's begin with antimicrobial activity. Ampicillin remains the preferred penicillin for initial empirical therapy for neonatal septicemia and meningitis because it provides broader antimicrobial activity without sacrificing safety. Ampicillin is commonly used in combination with aminoglycosides. Compared with penicillin G, ampicillin has increased in vitro efficacy against most strains of Enterococci and Listeria monocytogenes, as well as against some gram-negative pathogens, such as Haemophilus influenza, Escherichia coli, Proteus mirabilis, and Salmonella species. It is only rarely active against Staphylococcus aureus. Approximately 90% of Group B streptococci and Listeria monocytogenes organisms are inhibited by 0.06 microgram per milliliter or less of ampicillin. Almost two-thirds of the gram-negative enteric bacilli isolated from CSF cultures of infants enrolled in the second neonatal meningitis cooperative study, from 1976 to 1978, were inhibited by 10 micrograms per milliliter or less of ampicillin. However, an increased rate of ampicillin-resistant gram-negative bacilli has been reported. Next we will discuss the pharmacokinetic data of ampicillin. Ampicillin, similar to many beta-lactam antibiotics, is cleared by renal elimination. Therefore, drug clearance and half-life are dependent on renal maturation. Plasma drug clearance increases, and half-life decreases, with increasing birth weight, gestational age, and chronologic age. Despite its frequent use, the PK of ampicillin in extremely low birth weight, abbreviated as ELBW, infants remains sparse. Serum ampicillin concentration time curves have been determined after IM doses in newborns. The mean peak serum concentrations 0.5 to 1 hour after 5, 10, 20, and 25 mg per kilogram doses were 16, 25, 54, and 57 micrograms per milliliter, respectively, whereas the values at 12 hours were from 1 to 15 micrograms per milliliter, with a mean value of 5 micrograms per milliliter. After 50 mg per kilogram doses, the mean peak values were higher in low body weight infants, that is 100 to 130 micrograms per milliliter, compared with larger term infants, that is 80 to 85 micrograms per milliliter. Peak serum concentrations as high as 300 micrograms per milliliter, that is mean values of 180 to 216 micrograms per milliliter, are observed 1 to 2 hours after a 100 mg per kilogram dose. These latter values exceed the MIC90 values of Group B streptococci by at least 3,000-fold. Half-life decreases with advancing age from 3 to 6 hours in the first week of life to 2 to 3.5 hours thereafter. Serum ampicillin concentration time curves after IV doses have been characterized for preterm and term infants. After a 100 mg per kilogram IV dose, premature infants of 26 to 33 weeks of gestation had a lower mean peak serum concentration, 135 micrograms per milliliter, compared with more mature 34 to 40 week infants, that is 153 micrograms per milliliter. When the loading dose was followed by maintenance ampicillin doses of 50 mg per kilogram IV at 12 to 18-hour intervals, the mean peak and trough serum concentrations in steady-state conditions were 113 and 30 micrograms per milliliter, respectively, for premature neonates, and 140 and 37 micrograms per milliliter, respectively, for full-term neonates. Despite the lower peak concentration in premature infants, the trough value was maintained, likely given the longer half-life in premature newborn, that is 9.5 hours, compared with full-term newborns, that is 7 hours. Trough values of 30 micrograms per milliliter exceed the MIC90 value for group B streptococci by 300-fold. We will now switch gears to cerebrospinal fluid penetration. Concentrations of ampicillin in CSF vary greatly. The largest concentrations, 3 to 18 micrograms per milliliter, occur approximately 2 hours after a 50 mg per kilogram IV dose and exceed the MIC90 values for group B streptococci and Listeria monocytogenes by 50 to 300-fold. By contrast, these peak concentrations equal or exceed the MIC values against many Escherichia coli strains by only several-fold. The values in CSF are lower later in the course of meningitis, when meningeal inflammation subsides. We will now focus on safety of ampicillin. Ampicillin is well tolerated when administered parenterally to newborns. Nonspecific rashes and urticaria are rarely observed, and diarrhea is uncommon. In older children and adults, very large doses can result in CNS excitation or seizures. Moderately prolonged bleeding times have been reported with repeated doses. Elevations of serum glutamic oxaloacetic aminotransferase and creatinine values frequently are detected in neonates and probably represent local tissue destruction at the site of IM injection. Mild eosinophilia may be noted in newborns and young infants. Alteration of the microbial flora of the bowel may occur after parenteral administration of ampicillin, but overgrowth of resistant gram-negative organisms and Candida albicans occurs more frequently after oral administration. Diarrhea usually subsides on discontinuation of therapy. Next we will discuss PK/PD and clinical implications for dosing. Vast clinical experience has demonstrated that ampicillin is a safe and effective drug for therapy for neonatal bacterial infections caused by susceptible organisms. Combined ampicillin and aminoglycoside therapy is appropriate initial empirical management of suspected bacterial infections of neonates because it provides broad antimicrobial activity and potential synergism against many strains of group B streptococci, Listeria monocytogenes, and Enterococci. Beta-lactam antibiotics exhibit time-dependent killing. Therefore the PK/PD target is T greater than MIC. Frequent dosing intervals are used to maintain drug exposure over the dosing interval. For systemic bacterial infections other than meningitis, a dosage of 25 to 50 mg per kilogram per dose given 2 to 3 times per day in the first week of life, and then 3 to 4 times per day thereafter, is recommended. For therapy of bacterial meningitis, we recommend a dosage of at least 200 mg per kilogram per day, although some consultants use dosages as high as 300 mg per kilogram per day. Premature infants may continue to receive ampicillin 2 to 3 times per day for up to 4 weeks, depending on gestational age, chronologic age, and renal function, as shown in Table 37.6. We will now discuss antistaphylococcal treatment. Staphylococcus aureus infections occur in nurseries either as sporadic cases or in the form of disease outbreaks. In recent years, multiply-resistant strains, especially MRSA and CO agulus negative staphylococcal species, such as methicillin-resistant Staphylococcus epidermidis, abbreviated as MRSE, have been responsible for an increasing number of nosocomially acquired staphylococcal infections in many neonatal care units. And now we will discuss antistaphylococcal penicillins, shown in Table 37.7. Let's begin with their antimicrobial activity. Nafcillin and oxacillin are the mainstays of methicillin-sensitive staphylococcal therapy. These semi-synthetic agents are engineered to be resistant to hydrolysis by most staphylococcal beta-lactamases by virtue of a substituted side chain that acts by steric hindrance at the site of enzyme attachment. Most penicillinase-producing staphylococci are inhibited by less than 0.5 microgram per milliliter of nafcillin and oxacillin. We will now look at pharmacokinetic data. See Table 37.7. Nafcillin. Unlike other penicillins, nafcillin exhibits primarily hepatic clearance rather than renal clearance. The administration of 5, 10, 15, and 20 mg per kilogram IM doses of nafcillin to full-term newborns in the first 4 days of life produces mean peak serum concentrations 1 hour later of 10, 25, 30, and 37 micrograms per milliliter, respectively. These concentrations are significantly higher than those obtained in older children receiving comparable amounts of this drug. Preterm infants weighing less than 2,000 grams had higher steady-state peak concentrations, 100 to 160 micrograms per milliliter after receiving 33 to 50 mg per kilogram IV doses. In these preterm infants, the half-life ranged from 2.2 to 5.5 hours. Oxacillin. Oxacillin exhibits primarily renal clearance. Despite this difference in clearance mechanism, the pK of oxacillin in neonates is similar to that of nafcillin. Mean peak serum concentrations of approximately 50 and 100 micrograms per milliliter are produced by 20 and 50 mg per kilogram IM doses, respectively. The serum half-life of oxacillin in premature infants is about 3 hours in the first week of life and 1.5 hours thereafter. We will now talk about their safety. The antistaphylococcal penicillins are well tolerated in newborn and young infants. Repeated IM injections can result in muscle damage, sterile muscle abscess, and elevation of creatinine concentrations. Nephrotoxicity, interstitial nephritis or cystitis, is rare in newborns but occurs in 3% to 5% of children who receive large doses of methicillin and possibly the other antistaphylococcal penicillins, with the exception of nafcillin. Reversible hematologic abnormalities, such as neutropenia or eosinophilia, commonly are observed in children undergoing treatment with these drugs, but their incidence in newborns is unknown. Because nafcillin has a predominant biliary excretion, accumulation of this drug in serum can occur in jaundiced neonates, and potential adverse effects can develop. Extravasation of nafcillin at the injection site can result in necrosis of local tissue. And now we will focus on PK/PD and clinical implications for dosing. See Tables 37.6 and 37.7. Nafcillin and oxacillin are the antistaphylococcal drugs most often used for treatment of methicillin-sensitive staphylococcal infections in neonates. Like other beta-lactam antibiotics, it is important to maintain the drug concentrations over the dosing interval, T above MIC. Therefore, as infants mature, drug clearance improves and dosing intervals shorten. The dosage of oxacillin is 25 to 50 mg per kilogram every 12 hours, that is 50 to 150 mg per kilogram per day, in the first week of life, and every 6 to 8 hours, that is 75 to 200 mg per kilogram per day, thereafter. The larger dosage is indicated for infants with disseminated staphylococcal disease or meningitis. For nafcillin, the dosage is 25 mg per kilogram, and 50 mg per kilogram for meningitis, per dose given every 12 hours in the first week of life and every 6 to 8 hours thereafter. Depending on gestational age at birth and chronologic age, extremely preterm infants may have delayed clearance and therefore should continue twice daily dosing for 2 to 4 weeks, see Table 37.6. If an infant does not respond to antimicrobial therapy as anticipated, one should consider an occult site of staphylococcal disease, e.g., abscess, osteomyelitis, or endocarditis, pathogen resistance, or the need to shorten the dosing interval to maintain the drug concentration above the MIC throughout the dosing interval. Appropriate drainage of purulent foci, addition of an aminoglycoside or rifampin to the regimen, and use of vancomycin are among several options to consider in management of unresponsive infections. Pause the video and carefully scrutinize Table 37.6 summarizing suggested dosage schedules for systemic antibiotics used in newborns before advancing to the next slide. Pause the video and carefully scrutinize Table 37.7 summarizing suggested dosage schedules for systemic antibiotics used in newborns before advancing to the next slide. We will now discuss methicillin-resistant staphylococcal infections, MRSE and MRSA. See Table 37.7. MRSA now constitutes a relatively common cause of infection outbreaks in some nurseries, and MRSE strains are an important cause of catheter-associated disease, particularly among low body weight premature infants. Glycopeptide antibiotics such as vancomycin or teicoplanin, in Europe, are the drugs of choice for infections caused by these resistant strains. Infections may be treated with combination therapy, a glycopeptide with an aminoglycoside or rifampin. More recently, the use of linezolid, clindamycin, and daptomycin have been explored for the treatment of MRSA infections. We will now switch gears to vancomycin. See Table 37.7. Antimicrobial activity. Vancomycin is bactericidal against most aerobic and anaerobic gram-positive cocci and bacilli. The drug interferes with the phospholipid cycle of cell wall synthesis, alters plasma membrane function, and inhibits RNA synthesis. There is no cross-resistance between vancomycin and other antibiotics. Synergistic bacterial killing has been demonstrated for vancomycin with aminoglycosides. We will now progress to pharmacokinetic data. See Table 37.7. Vancomycin is not metabolized by the body and is excreted unchanged in the urine primarily by glomerular filtration. Vancomycin clearance reflects renal maturation and increases with gestational age and chronologic age. Vancomycin is approximately 55% protein-bound. Neonates have increased extracellular fluid volume and limited renal elimination capacity and therefore are expected to have lower C-marks and delayed clearance of vancomycin. The PK of vancomycin in preterm and term infants has been thoroughly reviewed by Pacifici and Allergard. Clearance estimates are lowest in the most preterm neonates, approximately 0.9 ml per minute per kilogram, with a 2 to 3-fold increase in clearance within the neonatal age range, reflecting renal maturation and improvement in renal function, with clinical stability over time. Serum creatinine remains an important predictor of renal clearance, even after accounting for gestational age and post-chronologic age. The use of neonatal creatinine is controversial. However, because it is affected by maternal creatinine load, the natural decline with postnatal age, analytic variation in creatinine measurement, and concomitant diseases and medications. Currently, creatinine remains the best clinically available estimate of renal function despite these limitations. Vancomycin clearance is also reduced in growth restriction and in the setting of indomethacin exposure for patent ductus arteriosus, abbreviated as PDA. Infants on extracorporeal membrane oxygenation, abbreviated as ECMO, have delayed clearance and increased volume of distribution. In the first week after birth, peak concentrations of 17 to 30 micrograms per milliliter are produced at the end of a 30-minute infusion of a 15 mg per kilogram dose given to neonates weighing less than 2,000 grams. Slightly higher values are observed in larger infants. In infants up to 12 months of age, doses of 10 mg per kilogram produce similar peak serum concentrations. Population PK studies have attempted to explain the observed variability of vancomycin with chronologic age, maturity, and renal function. In a large population PK study of 1103 vancomycin concentrations from 374 newborns and infants less than 2 years of age, creatinine levels were strongly correlated with vancomycin elimination, whereas chronologic age and prematurity, that is less than 28 weeks, were significant but less important predictors of vancomycin clearance. Vancomycin clearance for a typical 27-day-old, 1.8 kg, x 33-week gestational age infant with creatinine at 0.6 mg per deciliter is estimated to be 0.1 to 0.12 liters per hour. The volume of distribution, 0.5 to 0.8 liter per kilogram, varies with weight and is larger than that reported in older children. Traditional and population PK studies consistently report improved clearance and shorter half-lives with advancing gestational age and chronologic age. However, PK studies in preterm infants still show remarkable variability. Vancomycin half-life is prolonged in the first week of life, ranging from 6 to 10 depending on prematurity and renal function. The half-life then decreases to 4 to 7 hours in the first 1 to 2 months, then eventually to 2 to 2.5 hours in childhood. Neonates undergoing ECMO receiving vancomycin have a larger volume of distribution, lower concentration, and longer half-life. However, because infants on ECMO typically have renal insufficiency, some of the delayed vancomycin gestational age may be explained by elevated SCR. Vancomycin does not readily penetrate the CSF unless the meninges are inflamed. The CSF concentrations of vancomycin are 10% to 15% of the concomitant serum concentrations in infants with minimal meningeal inflammation. In premature infants born at 26 to 31 weeks of gestational age, dosages of 20 mg per kilogram every 18 to 24 hours were associated with CSF vancomycin concentrations of 2.2 to 5.6 micrograms per milliliter, 26% to 68% of their corresponding serum values. We will now focus on safety. Initial experience with vancomycin in the 1950s suggested a moderate incidence of ototoxicity and nephrotoxicity. These adverse effects were presumably related to the impurities found in early preparations of the drug. Further studies have indicated that vancomycin is well tolerated and safe when administered intravenously, particularly in newborns and young infants. Rare cases of ototoxicity and nephrotoxicity typically involved excessive doses, underlying hearing loss or renal disease, and concomitant therapy with other ototoxic or nephrotoxic agents. To minimize risk of nephrotoxicity or ototoxicity, Vancomycin trough levels are monitored in patients with underlying renal dysfunction or those receiving concomitant therapy with aminoglycoside. There is also no proven association between therapeutic drug monitoring and the prevention of ototoxicity. Renal function should be monitored during vancomycin therapy. In adults, the most important risk factors for developing nephrotoxicity include trough concentrations greater than 10 micrograms per milliliter, concomitant treatment with aminoglycosides, and/or prolonged therapy greater than 21 days. Other risk factors include extremely high peak concentrations greater than 60, high total dose, pre-existing renal failure, and concurrent treatment with amphotericin and/or furosemide. Nephrotoxicity is not well characterized in pediatrics, but appears to be less common in neonates and young infants. After rapid administration, some older patients develop a histamine reaction characterized by an erythematous pruritic rash that can persist for several hours, but tends to resolve with antihistamine medications. Use of a slower infusion rate, i.e., longer than 45 to 60 minutes, usually avoids this adverse event. Vancomycin is irritating to tissue and is thus always administered through the IV route. In neonates, an association between vancomycin exposure and ototoxicity or renal toxicity has not been described. PK/PD and clinical implications for dosing. See tables 37.6 and 37.7. The primary indication for vancomycin therapy in newborns is for infections caused by MRSA and by ampicillin-resistant enterococci. Vancomycin is the initial drug of choice for documented infections caused by S. epidermidis, because most strains are resistant to penicillin, methicillin, cephalosporins, and aminoglycosides. Of interest, Staphylococcus warneri has a somewhat reduced glycopeptide susceptibility, MIC greater than 2 micrograms per milliliter, compared with Staphylococcus epidermidis, MIC less than 2 micrograms per milliliter. The rate of killing of staphylococci is slow for vancomycin compared with beta-lactams. If susceptibility data for staphylococcal infections reveals methicillin sensitivity, then the antibiotic regimen should be adjusted. For beta-lactam sensitive staphylococci and enterococci, vancomycin was inferior to nafcillin and ampicillin when comparing bactericidal rate and rapidity of blood sterility. Vancomycin is a concentration-independent, time-dependent antibiotic with moderate post-antibiotic effect. The continued suppression of bacterial growth against gram-positive bacteria can persist for several hours, depending on the organism and initial antibiotic concentration, typically ranging from 0.6 to 2 hours for Staphylococcus aureus and 4 to 6 hours for Staphylococcus epidermidis. Both increased AUC to MIC greater than 400 and increased T greater than MIC have been shown to promote bacterial clearance. MRSA and Staphylococcus epidermidis are typically sensitive to vancomycin, with MIC less than 2 micrograms per milliliter. Serum bactericidal titers of 1 to 8, approximate serum concentrations of 12 micrograms per milliliter, have been associated with clinical cures in children. Bactericidal activity appears to be maintained if the vancomycin concentrations exceed the MIC for 100% of the dosing interval or if the vancomycin trough concentration is greater than 10 micrograms per milliliter. Therapeutic drug monitoring focused on trough serum concentrations can be used to optimize PK/PD efficacy targets. Trough values of at least 10 ensure that the non-protein-bound vancomycin concentration will typically remain above the MIC of the offending organism and should achieve an AUC 0 to 24 to MIC ratio greater than 400 if the MIC is less than 1 mg per deciliter. In adults, higher trough concentrations, that is, 15 to 20 micrograms per milliliter, are indicated when treating serious MRSA infections, deep-seated infections, or those caused by organisms with AMIC greater than 1 microgram per milliliter. Peak levels are no longer recommended. The safety of these higher exposures has not been evaluated in neonates and children. Extremely preterm infants, infants with renal insufficiency or variable renal function, and infants on ECMO are likely to need more therapeutic drug monitoring. The timing of trough monitoring is critical. Trough values near steady state are typically drawn around the 4th dose. Trough values evaluated before steady state may need to be repeated after subsequent dosing to evaluate probable drug accumulation until steady state is reached, and also with any change in renal function or with prolonged treatment regimens. Several vancomycin dosing regimens have been proposed. The traditional dosage schedule for vancomycin in neonates is typically 10 to 15 mg per kilogram every 12 hours, that is 20 to 30 mg per kilogram per day, in the first week of life, and every 8 hours, that is 30 to 45 mg per kilogram per day, thereafter. Extremely premature infants have unique dosing requirements to account for changes in body water composition and postnatal maturation in renal function. It is also reasonable to consider serum creatinine or changes in serum creatinine in setting of infection when determining vancomycin dosage. The larger dosage, 15 mg per kilogram, is used for treatment of CSF infection or pneumonia. Extremely preterm infants, infants with renal insufficiency or variable renal function, and infants on ECMO are likely to need more frequent drug monitoring. Prospective evaluation of these dosing regimens continues to demonstrate the large degree of variability in exposure, consistent with variability seen in PK studies. Until prospectively validated dosing guidelines are available, individual units should consider monitoring the frequency of vancomycin trough concentrations outside of the target range and the MIC of their local organisms to evaluate the appropriateness of their current dosing guidance in their specific population. To maintain an AUC to MIC PD target and maintain vancomycin concentration above a given threshold, some clinicians have considered dosing by continuous infusion. One study in 145 preterm neonates showed that continuous infusions of either 15 to 25 mg per kilogram per day or 20 to 30 mg per kilogram per day both resulted in therapeutic vancomycin exposures. In another study, one group of 27 to 41-week PMA infants received vancomycin 10 to 30 mg per kilogram per day continuous infusion, whereas a second group of 28 to 51-week postmenstrual age infants received a loading dose of 7 mg per kilogram, followed by a continuous infusion of 10 to 40 mg per kilogram per day, according to postmenstrual age. Both groups had therapeutic vancomycin concentrations at steady state. Group 1 steady-state vancomycin concentration was 11 micrograms per milliliter, and Group 2 steady-state vancomycin concentration after loading dose was 15 micrograms per milliliter. These continuous infusions appear to have been well tolerated. However, the infusions would likely require a dedicated IV line. The dramatic increase in worldwide prevalence of vancomycin-resistant enterococci, abbreviated as VRE, and the serious threat posed by the spread of vancomycin-resistant staphylococci has discouraged the use of vancomycin for antimicrobial prophylaxis or empirical therapy. We will now discuss linezolid, see Table 37.7. We will begin with its antimicrobial activity. Linezolid is a synthetic oxazolidinone antibiotic that inhibits bacterial protein synthesis in a broad range of gram-positive organisms. In kill curve experiments, linezolid is bacteriostatic against staphylococci and enterococci, but can be bactericidal against streptococci. Linezolid has a unique mechanism of action and therefore does not exhibit cross-resistance with antistaphylococcal penicillins or vancomycin. It is FDA approved for treatment of infections caused by glycopeptide-resistant strains of Enterococcus fischum, Staphylococcus aureus, and Streptococcus pneumoniae in neonates. We will now consider the pharmacokinetic data of linezolid. See Table 37.7. Linezolid is known for its rapid and nearly complete absorption after oral dosing. Bioavailability is approximately 100% in adults, but has not been well characterized in neonates. Only 30% of linezolid is eliminated via the kidneys as active drug in the urine. Non-renal pathways account for approximately 65% of total body clearance for linezolid. Linezolid is oxidized on the morpholine ring, resulting in two inactive metabolites that are then excreted in the urine. The specific biotransformation pathways in children have not been defined. Linezolid is not a cytochrome P450 substrate. Single-dose PK for IV linezolid has been assessed in 42 neonates, 5 to 40 weeks of gestation, in the first 80 days of life. Linezolid clearance increases rapidly in the first week of life and is relatively constant from day 8 to 79 after birth. The increases in clearance are likely related to the development of biotransformation pathways after birth and age-associated increases in glomerular filtration for the residual renal elimination of the drug. Linezolid volume of distribution varies inversely with gestational age. In the first week of life, preterm infants have a slower clearance and longer half-life, that is 2 ml per kilogram per minute and 5.6 hours, respectively, compared with more mature infants, that is 3.8 ml per kilogram per minute and 3 hours, respectively. Beyond the first week of life, clearance and half-life estimates are similar, that is 5.1 ml per kilogram per minute and 1.5 hours, respectively, in preterm and term infants up to 90 days of age. Linezolid trough concentrations at 11 hours are 0 to 4 micrograms per milliliter. Infants receiving a 10 mg per kilogram dose are predicted to have a mean AUC of 54.9 mg per hour per liter. Infants have faster clearances and shorter half-lives than older infants, such that infants, that is greater than 7 days of age, dosed every 8 hours achieve AUCs similar to older children. Linezolid rapidly penetrates the CSF in children. However, CSF concentrations are inconsistent. Children with ventricular peritoneal shunts receiving the drug did not consistently achieve or maintain therapeutic concentrations in the CSF. In adults, moderate hepatic or renal insufficiency does alter the PK of linezolid. The drug's metabolites accumulate in adults with renal insufficiency. However, the clinical significance of these metabolites is unknown. And now we will focus on the safety of linezolid. Linezolid has been well tolerated in the small number of infants and children in PK and efficacy trials. In pediatric comparator trials, the most common drug-related adverse events in children treated with linezolid were diarrhea, nausea, vomiting, anemia, and thrombocytopenia. Drug-related adverse events rarely led to discontinuation of therapy. Linezolid is a reversible, non-selective inhibitor of monoamine oxidase. Therefore it has the potential for interaction with adrenergic and serotonergic agents. Patients receiving linezolid may have an enhanced pressor response to sympathomimetic agents, including dopamine. Myelosuppression has been reported, and therefore complete blood counts should be monitored weekly in patients on linezolid therapy, particularly for therapy beyond 2 weeks. One non-comparative study found good therapeutic outcomes, but a high rate of adverse reactions in adults with serious gram-positive infections treated with linezolid for a mean of 28 days. And now we will focus on PK/PD and clinical implications for dosing. See tables 37.6 and 37.7. Linezolid is indicated for the treatment of vancomycin-resistant Enterococcus fischum, abbreviated as VRE, infections, pneumonia caused by MRSA or Streptococcus pneumoniae, and severe, complicated skin infections caused by susceptible organisms. Linezolid penetrates respiratory secretions and epithelial lining fluid better than vancomycin. Linezolid exhibits time-dependent killing with moderate to prolonged persistent antimicrobial effects. The primary PD determinant associated with efficacy in the neutropenic thigh infection model for Streptococcus pneumoniae and Staphylococcus aureus is an AUC to MIC ratio of 50 and 80, respectively. Susceptible strains of Enterococcus and Streptococcus spp. Have MICs less than or equal to 2 micrograms per milliliter, whereas the susceptible strains of Staphylococci have a MIC less than or equal to 4 micrograms per milliliter. In adults with MRSA or VRE, favorable outcomes were experienced in 97% of those who achieved a linezolid AUC to MIC ratio of greater than 95, compared with 75% of those who had lower AUC to MIC ratios. Administration of continuous linezolid infusions, such that drug concentrations are maintained above the MIC for entire dosing interval, has been associated with bactericidal activity. For adults with MRSA infections, there appears to be no significant difference in clinical cure or microbiologic cure between linezolid and vancomycin. However, linezolid was superior to vancomycin in one adult comparator trial of complicated skin and soft tissue infections. Linezolid clinical trials have been performed in hospitalized young infants and children with documented gram-positive infections. Linezolid was well tolerated at a dosage of 10 mg per kilogram every 8 hours and as effective as vancomycin for treatment of resistant gram-positive infections. Infants require dosing every 8 hours to maintain AUCs similar to those achieved in adolescents, and adults dosed every 12 hours. An AUC of 100 would achieve AUC to MIC ratios of greater or equal to 50 if the MIC of the organism was less than or equal to 2, as would be expected for most enterococcal or streptococcal infections. Higher doses may be needed to achieve this AUC to MIC target in infants with faster clearance or infants with MRSA infections, where the MIC may be between 2 to 4 micrograms per milliliter. PD targets have not been confirmed in clinical trials. In the first few days of life, infants may accumulate linezolid as clearance is rapidly changing. For extremely preterm infants younger than 7 days of chronologic age, we would consider a dose of 10 mg per kilogram every 12 hours. The risk of drug accumulation is balanced with the need to rapidly achieve and maintain adequate plasma and tissue concentrations of drug during a developmental period of rapidly improving clearance. The potential for linezolid resistance has been documented. Further emergence and spread of such resistance may depend on its prudent use. A new oxazolidenone antibiotic, tedazolid, marketed as Civextro, was approved by the FDA in 2014 for once-daily dosing against acute gram-positive bacterial infections, including MRSA. Information on its potential use and safety in pregnancy and infants is not yet available. We will now progress to clindamycin. See Table 37.7. Let's begin with its antimicrobial activity. Clindamycin replaced its parent compound lincomycin because it is more completely absorbed from the gut, has fewer adverse effects, and has greater antibacterial activity in vitro. Clindamycin is primarily a bacteriostatic agent that acts by inhibiting protein synthesis through reversible binding to bacterial ribosomes, thus inhibiting bacterial protein synthesis. Clindamycin is active against gram-positive cocci such as Staphylococcus aureus, Streptococcus pneumoniae, including many multi-drug-resistant strains, and Streptococcus pyogenes. It also maintains notable activity against anaerobic bacteria, especially members of the Bacteroides group. Aerobic gram-negative bacteria are not usually susceptible to this antibiotic. Resistance to clindamycin is related to alterations of its target site and not to reduced uptake or to breakdown of the drug by the resistant bacteria. We will now focus on the pharmacokinetic data of clindamycin. Clindamycin pharmacology has been recently reviewed. However, there is a paucity of information in neonates. Clindamycin exhibits significant, that is 94%, protein binding. The drug is eliminated primarily through the liver, with only about 10% excreted in unchanged form in the urine. Clindamycin is reported to be a cytochrome P450 substrate that may increase the neuromuscular blocking action of tubocurarine and pancuronium. Clindamycin has been shown to accumulate in patients with hepatic dysfunction. It is widely distributed throughout the body, including pleural fluid, ascites, bone, and bile. However, no significant levels, that is approximately 20%, are seen in the CSF, even in the setting of meningitis. Experimental meningitis animal models have demonstrated CSF penetration after parenteral administration. In adults, clindamycin exhibits excellent bioavailability after oral administration. When IV clindamycin was administered to infants in the first 4 weeks after birth, in a dosage schedule of 6.5 mg per kilogram every 8 hours, among preterm, or 5 mg per kilogram every 6 hours, among term, the mean peak serum concentration was 10 micrograms per milliliter, and trough values ranged from 2.8 to 5.5 micrograms per milliliter. The serum elimination half-life was inversely related to GAR and birth weight. Premature neonates demonstrated a mean serum half-life of 8.7 hours, compared with 3.6 hours for term newborns. Another study of 12 neonates demonstrated a serum elimination half-life of 3.5 to 9.8 hours, mean 6.3 hours. Neonates have longer elimination half-lives for clindamycin than the 3-hour half-life observed in infants aged 1 month to 1 year of age. We will now focus on the safety of clindamycin. Adverse effects of clindamycin include diarrhea, rashes, elevated levels of hepatic enzymes, granulocytopenia, thrombocytopenia, and, rarely, Stevens-Johnson syndrome. The most serious potential complication to consider is pseudomembranous colitis. Many asymptomatic neonates are colonized with Clostridium difficile, the presumed etiologic agent of pseudomembranous colitis. However, evidence for an association of Clostridioides difficile colonization with colitis in newborns is lacking, and pseudomembranous colitis is rare in both newborns and young infants. This adverse effect also is observed with the use of beta-lactam and other antimicrobial agents. PK/PD and clinical implications for dosing. See tables 37.6 and 37.7. Clinical information suggests that clindamycin can be effectively used to treat MRSA infections. Caution is advised, however, because resistance to clindamycin can be induced after selective antimicrobial pressure, particularly in MRSA organisms that initially are clindamycin susceptible and erythromycin resistant. Use of clindamycin in selected MRSA-infected newborn patients can obviate the need for vancomycin therapy. For treatment of the rare Bacteroides fragilis infections in newborns, especially those involving the CSF, metronidazole or clindamycin have been used. Clindamycin is said to have poor penetration into the CSF, albeit good penetration into brain tissue. Considerable debate exists regarding the optimal dose of clindamycin. Antibacterial activity is concentration independent and time dependent, with considerable post-antibiotic effect. Clindamycin has antibacterial activity that appears to be maximized as drug concentrations approach 1 to 4 times the mic, and also has a considerable post-antibiotic effect, lasting 4 to 6 hours. In the murine thigh infection model, clindamycin has been effective against clindamycin-susceptible and non-inducible MRSA. One proposed PK/PD target is to maintain the clindamycin concentration above the MIC for greater than or equal to 50% of the dosing interval. Most staphylococcal species have a low MIC, that is below 1 microgram per milliliter, for the drug. Much lower dosing than is currently used in adults was shown to achieve equivalent killing and maintain the clindamycin concentration above the MIC for 100% of the dosing interval. Empirical dosing information based upon the limited PK information available is 5 mg per kilogram per dose administered every 12 hours in the first week of life and every 6 to 8 hours thereafter. Preterm infants may have decreased clearance of clindamycin. Therefore, dosing interval is typically maintained at 8 to 12 hours for the first 2 weeks after birth. These doses are less than recommended in infants and young children, 25 to 40 mg per kilogram per day, divided every 6 to 8 hours. More neonatal PK data is needed, especially in ELBW infants with serious bacterial infections in the first 90 days after birth. Because clindamycin is highly protein-bound, assays need to clearly quantify the molecularly active non-protein-bound exposure to clindamycin. We will now progress to rifampin. In selected neonates with persistent, systemic staphylococcal infections, rifampin has been used to provide a synergistic effect when given with other antistaphylococcal drugs. Resistance rapidly emerges with rifampin monotherapy. In adults, rifampin is widely distributed throughout the body, including the CSF. Rifampin is 80% protein-bound and is eliminated in bile after progressive deacetylation to metabolites that remain microbiologically active. No dose adjustment is needed for renal insufficiency. Rifampin is bactericidal through the inhibition of bacterial-specific DNA-dependent RNA polymerase activity. It is active against most strains of Neisseria meningitidis, Mycobacterium tuberculosis, and aerobic gram-positive bacteria, including methicillin-sensitive Staphylococcus aureus, that is both MSSA, MRSA, and Staphylococcus epidermidis. Safety concerns regarding rifampin are focused on thrombocytopenia, liver dysfunction and jaundice. Liver function and blood count monitoring is recommended. Rifampin has been found to compete with lilirubin for biliary excretion, and increased lilirubin has been observed. Rifampin is also known to induce cytochrome P450 enzymes, and therefore drug interactions are possible. Rifampin has been shown to accelerate elimination of drugs that are used in the neonatal population, including phenytoin, azole antifungal agents, narcotic analgesics, diazepam, and corticosteroids. Neonatal PK information for IV rifampin is sparse, and dosing remains empirical. In one small study, infants, mean age, 23 days, received rifampin 10 mg per kilogram per day and had a mean peak concentration of 4.02 micrograms per milliliter and a mean 12-hour trough concentration of 1.11 micrograms per milliliter. In children, rifampin clearance is induced after 8 days of therapy. As rifampin clearance increases and half-life decreases, the dosing interval may need to be shortened to accommodate induced clearance in prolonged therapy. Uncontrolled clinical case series suggest that rifampin used as an adjunct to vancomycin therapy can provide prompt clearance of persistent staphylococcal bacteremia or ventriculitis in high-risk neonates. We will now switch gears to teicoplanin. Teicoplanin is a glycopeptide antibiotic that is almost identical to vancomycin with regard to its antibacterial spectrum of activity. It is used frequently in Europe, where it is approved for the treatment of gram-positive infections. However, it is not approved for use in the United States. Teicoplanin may have some advantages over vancomycin in terms of tolerability, with a lower propensity to cause nephrotoxicity and histaminage-type reactions. Teicoplanin also has a longer elimination half-life, allowing for longer dosing intervals. It rapidly penetrates into tissue and reaches high concentrations in the kidney, trachea, lungs, and adrenals but does not penetrate well into the CSF. It is excreted unchanged in the urine after a prolonged elimination phase. Despite these potential advantages, teicoplanin PK data adequate to formulate dosage regimens in neonates are lacking. In one study, 4 neonates received a single dose of 6 mg per kilogram, and the mean peak serum teicoplanin concentration was 19.6 micrograms per milliliter, with a mean half-life of 30 hours. In several non-comparative trials, the clinical and bacteriologic response rates ranged between 80% and 100% in 173 infected neonates given IV teicoplanin 8 to 10 mg per kilogram once daily after a loading dose of 10 to 20 mg per kilogram. A recent study of 37 episodes of staphylococcal bacteremia in neonates treated with a loading dose of 16 mg per kilogram teicoplanin, followed by a maintenance dose of 8 mg per kilogram per day, achieved bacterial eradication in 89% and survival of 94% with no documented drug-related adverse events. One neonate was reported to have tolerated teicoplanin overdose, that is 20 mg per kilogram per day for 5 days. We will now progress to daptomycin. Daptomycin is the first-in-class member of the cyclic lipopeptide family. Lipopeptides have a unique mechanism of action. They insert into bacteria membranes and cause a rapid membrane depolarization, leading to inhibition of protein, DNA and RNA synthesis, cell leakage, and ultimately cell death. Daptomycin exhibits rapid, concentration-dependent, bactericidal activity against MRSA, MRSE, vancomycin-resistant Staphylococcus aureus, and vancomycin-resistant Enterococci. The product is approved in the United States for the treatment of complicated skin and skin structure infections, and Staphylococcus aureus bacteremia. Daptomycin is not indicated for the treatment of pneumonia because of its inactivation by surfactant. Daptomycin exhibits a high degree of protein binding and is primarily excreted unchanged by the kidney. In clinical trials, a few adults receiving daptomycin had elevated creatine phosphokinase, abbreviated as CPK, enzyme and, rarely, myopathy. The manufacturer recommends monitoring creatine phosphokinase weekly while on therapy and discontinuing therapy for myopathy, myalgia, or creatine phosphokinase greater than 1000 mg per deciliter. Daptomycin is not approved for use in children or neonates. One single-dose PK study of 25 children with suspected or proven gram-positive infections revealed more rapid clearance in younger children. 2 infants with complicated MRSA infections who received 6 mg per kilogram dose every 12 hours had peak and trough concentrations that were consistent with concentrations observed in adults treated with a 4 mg per kilogram daily dose. These infants achieved microbiologic and clinical cure. However, their exposure was less than that achieved in adults receiving daptomycin at the approved dose of 6 mg per kilogram per day for treatment of MRSA bacteremia. A single-dose PK study, after giving 6 mg per kilogram daptomycin IV, was carried out on 20 neonates at risk for infection, having a median gestation age at birth of 32 weeks, range 23 to 40 weeks, and median postnatal age of 3 days, range 1 to 85 days. The median AUC at 24 hours, volume of distribution, total body clearance, and half-life of daptomycin were 262.4 mg per hour per liter, range 166.7 to 340.2, 0.21 liters per kilogram, range 0.11 to 0.34, 0.021 liter per hour per, range 0.016 to 0.034, and 6.2 hours, that is 3.7 to 9, respectively. CPK concentrations were not elevated. No adverse events related to daptomycin were observed. Daptomycin concentrations were lower than that achieved in adults receiving similar doses. Clearance in young infants was similar to that in children 2 to 6 years of age and higher than that observed in adolescents and adults. Young infants are likely to need higher doses of daptomycin to achieve adult efficacy targets. Additional studies, including multiple-dose PK and safety studies, are needed to derive appropriate PK/PD dosing guidance. We will now focus on aminoglycosides, shown in Table 37.8. Let's begin with a history. For more than 3 decades, the aminoglycosides have been relied upon for therapy for neonatal sepsis because of their broad-spectrum antibacterial activity against gram-negative bacilli. However, the use in some centers is decreasing because of the emergence of resistant strains. Currently, gentamicin, tobramycin, and amikacin are the aminoglycosides of choice in most nurseries. Because amikacin is resistant to degradation by most of the plasmid-mediated bacterial enzymes that inactivate gentamicin and tobramycin, some centers have held amikacin in reserve for treatment of nosocomially acquired infections caused by multidrug-resistant gram-negative organisms. Gentamicin resistance occurs frequently enough in some European, Latin American, and US centers to warrant use of amikacin as a first-line drug for therapy of life-threatening gram-negative infections. Thus far, its routine use has not resulted in emergence of resistant strains. The history of aminoglycoside usage in the late 1950s and 1960s is an excellent example of the inherent problems of adapting dosages derived from studies in adults to newborns. Irreversible ototoxicity in neonates was caused by excessive doses of streptomycin or kanamycin. By contrast, the PK of gentamicin, tobramycin, amikacin, and netilmycin were carefully defined in the neonate before routine use of these drugs. Appropriate studies thus provided a scientific basis for safe and effective dosage regimens. The risk of aminoglycoside toxicity is minimal when these agents are administered to infants in the proper dosage and when serum concentrations are closely monitored and kept within the recommended therapeutic range. The evolution of gentamicin dosing over recent years is also an excellent example of dosing modifications that target PD to achieve optimal therapeutic exposure. Aminoglycoside administration using extended dosing intervals appears to be at least as safe and effective as giving these drugs in 2 or 3 divided doses. The extended dosing interval schedule provides a higher peak concentration to maximize the concentration-dependent bacterial killing and take advantage of the prolonged post-antibiotic effect of the aminoglycosides. We will now discuss antimicrobial activity. Aminoglycosides act on microbial ribosomes to irreversibly inhibit protein synthesis. In general, gentamicin, tobramycin, and amikacin have good antibacterial activity against most gram-negative strains. Tobramycin has the greatest antipseudomonal activity, whereas amikacin is the only drug of this class that reliably provides activity against Serratia species and other coliforms with nosocomially acquired resistance. Although Staphylococci are susceptible in vitro to aminoglycosides, infections caused by these pathogens usually do not respond satisfactorily to aminoglycoside therapy alone. Synergistic bactericidal activity between aminoglycosides and the penicillins has been demonstrated in vitro and in animals against Staphylococcus aureus, group B streptococci, Listeria monocytogenes, and Enterococci, despite low-level resistance of each microorganism to the aminoglycoside alone. Possible mechanisms of bacterial resistance to these drugs include alteration of the ribosomal binding site, changes in the cell surface proteins to prevent entrance of drug into the cell, and induction of aminoglycoside inactivating enzymes. Antibiotic resistance in clinical situations is most often a result of extrachromosomally controlled R-factor enzymes. Phosphorylation, adenylation, and acetylation are the 3 most common enzymatic mechanisms encountered. High concentrations of aminoglycosides may reduce the emergence of resistance by targeting resistant subpopulations. Some gram-negative organisms, notably Pseudomonas aeruginosa and Enterobacter species, demonstrate reduced uptake of aminoglycosides after initial exposure. Such reduced uptake can decrease bacterial killing and is referred to as adaptive resistance. It may last for several hours after initial antibiotic exposure, but appears to be reversible after a duration of low plasma aminoglycoside concentrations. Next we will discuss pharmacokinetic data. Let's focus on gentamicin. See Table 37.8. Gentamicin is the most methodically studied aminoglycoside in newborns. However, there is considerable interpatient variability in gentamicin concentrations achieved in neonates. This variability is typically due to changes in renal function and body water composition with advancing GEA, chronologic age, and creatinine clearance, as well as differences in clinical disease state of the infant and concomitant medications. Gentamicin is administered via IM or IV injection. Studies of gentamicin concentrations demonstrate that IM and IV administration of gentamicin provides similar exposure. Aminoglycosides such as gentamicin cannot be administered orally for treatment of systemic infection because they are not absorbed from the intact gastrointestinal tract. Neonates have reduced gentamicin clearance, longer half-life, and increased volume of distribution compared with older patients. Neonatal population PK studies of gentamicin have attempted to explain the variability of gentamicin disposition with demographic and clinical variables. Volume of distribution is consistently associated with infant weight and ranges from 0.45 to 0.69 liters per kilogram. The mean relative clearance is 0.04 to 0.06 liters per hour per kilogram, typically depending on how many premature infants were included in the model and their chronologic age. Clearance improves with advancing gestational age, chronologic age, postmenstrual age, and creatinine clearance as expected for improved renal maturation. Half-life of gentamicin is longer in younger, smaller, more immature infants, and those with reduced creatinine clearance. During the first week of life, premature, that is less than 30 weeks, infants have delayed clearance, approximately 0.03 liters per kilogram per hour, and long half-life, that is 10 to 14 hours, compared with moderately preterm infants, that is 30 to 34 weeks, who have delayed clearance, approximately 0.04 liters per kilogram per hour, and modest half-life, that is 8 to 10 hours. Late preterm and term infants have a much shorter half-life of 4 to 5 hours, given their faster clearance of approximately 0.05 liters per kilogram per hour. Perinatal asphyxia, PDA, or its treatment, and unrepaired congenital heart disease are associated with prolonged serum gentamicin half-life, likely resulting from decreased renal clearance. Pause the video and carefully scrutinize Table 37.8 summarizing aminoglycosides and asteronym for the treatment of gram-negative infections in the first week after birth before advancing to the next slide. CSF concentrations of gentamicin in infants with meningitis are from 0.3 to 3.7 micrograms per milliliter. Mean, 1.6 micrograms per milliliter, 1 to 6 hours after a 2.5 mg per kilogram dose. Peak values are observed 4 to 6 hours after the dose and are correlated with the degree of meningeal inflammation and dosage. During the 1970s, the Neonatal Meningitis Cooperative Study Group evaluated lumbar intrathecal and intraventricular gentamicin administration in comparative studies with systemic antibiotic therapy alone. Despite higher CSF and intraventricular fluid concentrations, neither route of administration of therapy was associated with a better outcome in infants with meningitis caused by gram-negative enteric organisms. In fact, case fatality rates were significantly greater in intraventricular gentamicin recipients. Poor outcomes may in part be explained by the rapid lysis of gram-negative bacteria associated with high ventricular fluid gentamicin concentrations, the subsequent release of significantly larger amounts of endotoxin into the ventricular fluid, and greater meningeal inflammation. Serum gentamicin concentrations are altered by exchange transfusion and ECMO. After a 2-volume exchange transfusion, serum aminoglycoside concentrations are reduced by 19% to 62%. Whenever possible, such procedures are best timed to precede the next scheduled dose of gentamicin. Therapeutic drug monitoring is needed to guide dosing for infants on ECMO, because gentamicin, and probably other aminoglycosides, exhibits a higher volume of distribution, a lower clearance, and a longer half-life. Next we will discuss tobramycin. See Table 37.8. Tobramycin offers 2 theoretical advantages over gentamicin for therapy for neonatal infections: increased in vitro activity against Pseudomonas aeruginosa and decreased nephrotoxicity. The lower incidence of nephrotoxicity for tobramycin has been documented in laboratory animals and human adults, but not in neonates. Neonates appear to be less sensitive to aminoglycoside nephrotoxicity. Therefore, this advantage is uncertain in young infants. Neonatal PK of tobramycin data are not as well defined as gentamicin. After a 2 mg per kilogram dose of tobramycin, mean peak serum concentrations of 4 to 6 micrograms per milliliter are observed at 30 to 60 minutes. Pre-dose trough concentrations are higher in smaller and more premature infants. The serum tobramycin half-life is also prolonged in smaller, younger, and more premature infants and in those infants with delayed creatinine clearance. In the first week after birth, very low birth weight, abbreviated as VLBW, infants, weighing 2,500 grams, and older infants who are 1 to 4 weeks of age. Premature infants born at less than 30 weeks of gestation often require dosage intervals of 18 to 24 hours. More recently, population PK models of tobramycin clearance and volume of distribution have been developed using retrospective, existing datasets of peak and trough concentrations obtained in clinical care. In the largest study, in 470 neonates with suspected septicemia in the first week of life, tobramycin clearance was delayed in prematurity, 0.04 liter per hour per kilogram in equal to or less than 36-week infants and 0.05 to 0.06 liter per hour per kilogram in greater than 36-week infants. And volume of distribution varied with weight, but was somewhat higher in premature infants, that is 0.07 liter per kilogram in equal to or less than 36-week infants compared with 0.54 liter per kilogram in greater than 36-week infants. Tobramycin half-life ranged from 7 hours in mature infants to 11 hours in premature infants. Infants received tobramycin 3.5 mg per kilogram every 24 hours, that is less than 28 weeks, 2.5 mg per kilogram every 12 hours, that is 28 to 36 weeks, or 2.5 mg per kilogram every 12 hours, that is over 36 weeks. Target trough levels, that is less than 2 micrograms per milliliter, and peak levels, that is 5 to 10 micrograms per milliliter, occurred in 67% and 21% of samples respectively. Nearly half of the significant preterm infants less than 28 weeks of gestation had aberrant trough levels. Population PK models determined that dosing of 4 mg per kilogram is needed to achieve desired peak concentration. Dosing intervals to achieve trough concentrations less than 2 micrograms per milliliter varied with degree of prematurity: 24 hours for term, 36 hours for 32 to 37-week infants, and every 48 hours for infants less than 32 weeks of gestation. Using this dosing scheme, Simulated peak and trough targeted concentrations were predicted to be achieved in greater than 90% of infants. Therapeutic drug monitoring and individualization of the dosage schedule are often needed to provide the optimal therapy for very low birth weight infants. We will now progress to amikacin. See Table 37.8. Neonatal amikacin PK data are limited. Historically, infants receiving 7.5 to milligrams per kilogram doses of amikacin achieved mean peak and 12-hour trough serum concentrations of 15 to 25 micrograms per milliliter and 3 to 6 micrograms per milliliter, respectively. Serum half-life of amikacin is longer in younger and more premature infants. Low body weight infants exhibit a half-life of 7 to 8 hours at 1 to 3 days of age, compared with the much shorter half-life of 4 to 5 hours in term infants who are older than 1 week. The serum half-life is also prolonged in hypoxemic newborns. Neonatal population PK studies of amikacin have explored the wide variability of disposition. Amikacin clearance increased with gestational age, weight, and postnatal age, whereas volume of distribution varied with body weight. In the largest dataset created from 874 neonates, gestational age, 24 to 43 weeks, postnatal age, 1 to 30 days, and birth weight, 385 to 4,650 grams, amikacin clearance varied most with postmenstrual age. However, the combination of both birth weight and postnatal age was somewhat superior. Concomitant administration of ibuprofen also was associated with reduced clearance, and many datasets include a high percentage of preterm infants who were receiving ibuprofen. Body weight was the most important covariate for volume of distribution. In the final PK model, clearance was 0.05 liter per hour and volume of distribution was 0.82 liter. De Kock and colleagues concluded that amikacin clearance reflects the glomerular filtration rate in neonates and can therefore be predicted by the birth weight representing the antenatal state of renal maturation, the postnatal age representing postnatal maturation, and co-administration of ibuprofen representing effects of renal perfusion. At birth, clearance varied fourfold from preterm 1 kg infants, with a clearance approximately 0.026 liter per hour, to term 3 kg infants, with a clearance approximately 0.112 liter per hour. Even though clearance improves with postnatal age, premature infants still exhibit delay of clearance at 28 days when compared with larger term infants. Ibuprofen reduced clearance by 16%. Wide patient variability was also observed. We will now progress to amikacin. See Table 37.8. Neonatal amikacin PK data are limited. Historically, infants receiving 7.5 to milligrams per kilogram doses of amikacin achieved mean peak and 12-hour trough serum concentrations of 15 to 25 micrograms per milliliter and 3 to 6 micrograms per milliliter, respectively. Serum half-life of amikacin is longer in younger and more premature infants. Low body weight infants exhibit a half-life of 7 to 8 hours at 1 to 3 days of age, compared with the much shorter half-life of 4 to 5 hours in term infants who are older than 1 week. The serum half-life is also prolonged in hypoxemic newborns. Neonatal population PK studies of amikacin have explored the wide variability of disposition. Amikacin clearance increased with gestational age, weight, and postnatal age, whereas volume of distribution varied with body weight. In the largest dataset created from 874 neonates, gestational age, 24 to 43 weeks, postnatal age, 1 to 30 days, and birth weight, 385 to 4,650 grams. Amikacin clearance varied most with postmenstrual age. However, the combination of both birth weight and postnatal age was somewhat superior. Concomitant administration of ibuprofen also was associated with reduced clearance, and many datasets include a high percentage of preterm infants who were receiving ibuprofen. Body weight was the most important covariate for volume of distribution. In the final PK model, clearance was 0.05 liter per hour and volume of distribution was 0.82 liter. De Kock and colleagues concluded that amikacin clearance reflects the glomerular filtration rate in neonates and can therefore be predicted by the birth weight representing the antenatal state of renal maturation, the postnatal age representing postnatal maturation, and co-administration of ibuprofen representing effects of renal perfusion. At birth, clearance varied fourfold from preterm 1 kg infants, with a clearance approximately 0.026 liter per hour, to term 3 kg infants, with a clearance approximately 0.112 liter per hour. Even though clearance improves with postnatal age, premature infants still exhibit delay of clearance at 28 days when compared with larger term infants. Ibuprofen reduced clearance by 16%. Wide patient variability was also observed. We will now discuss safety of aminoglycosides. The major adverse effects of aminoglycoside antibiotics are renal toxicity, ototoxicity, and, rarely, neuromuscular blockade. Aminoglycosides are eliminated through glomerular filtration, but some drug is reabsorbed in the proximal tubule. Aminoglycosides may accumulate in renal tubular cells, where they fuse with cytoplasmic lysosomes and inhibit phospholipases, with the resultant accumulation of phospholipid aggregates and release of lysosomal contents within the renal tubular cells. The potential for nephrotoxicity varies among the aminoglycosides because of differences in the rate of uptake and amount of drug accumulation in the renal cortex. This renal cortical uptake is saturable in rats. Human nephrectomy studies have also demonstrated saturable uptake, higher renal cortical aminoglycoside, amikacin and gentamicin but not tobramycin, concentrations when doses were administered by continuous infusion or twice daily compared with once daily. Toxicity is correlated with elevated drug trough concentrations and prolonged therapy, but not with high peak concentrations. Extended aminoglycoside dosing intervals produce longer periods at low drug concentrations, thereby lessening the potential for renal drug accumulation and toxicity. Meta-analysis of adult trials of extended-interval aminoglycoside administration compared with conventional multi-dose daily administration showed that the rate of nephrotoxicity with extended-interval dosing was less than or equal to that observed with traditional regimens. In addition to drug dose and administration regimen, the risk factors for nephrotoxicity also include the concomitant medications and the patient's clinical condition. The reported incidence of aminoglycoside nephrotoxicity ranges from 5% to 25% and is thought to be lower in children than adults. It has been suggested that the immature kidney of the neonate may be protected from major toxic effects of aminoglycosides. Transient cylindruria and proteinuria may occur after prolonged administration of any of these drugs, but significant elevations in blood urea nitrogen and creatinine values are rarely observed. In a meta-analysis of neonatal comparative trials of once-daily extended-interval dosing, compared with multi-dose standard dosing of aminoglycosides, nephrotoxicity was rare. and there was no significant difference noted between the two dosing administration groups. Because renal excretion accounts for the elimination of approximately 80% of an aminoglycoside dose, the risk of toxicity is greatest when drug elimination is impaired by reduction in renal function for any reason. Therapeutic drug monitoring is often helpful in neonates receiving greater than 48 hours of therapy. Therapeutic drug monitoring, however, has not been shown to prevent renal or ototoxicity in neonates, but rather serves as a guide to provide individual dosing, given large interpatient variability in kinetics, especially in premature infants or infants who are expected to receive aminoglycosides for greater than 48 hours. Other factors that may be associated with increased risk for aminoglycoside nephrotoxicity include acidosis, hypovolemia, hypoalbuminemia, sodium depletion, duration of therapy, increased total aminoglycoside dose, and frequency of administration and co-administration of furosemide, vancomycin, or prostaglandin synthesis inhibitors such as indomethacin. Neomycin, streptomycin, kanamycin, and gentamicin each have been implicated as a cause of sensorineural hearing loss in infants and children. Gentamicin and streptomycin also have been associated with vestibular impairment. However, it is difficult to incriminate the aminoglycosides as the single causative agent of hearing loss in most studies, because of the high-risk conditions present in affected patients, such as asphyxia, hyperbilirubinemia, and incubator or ventilator noise exposure, that have been independently associated with ototoxicity. In a prospective evaluation of long-term toxicity of kanamycin and gentamicin, neither was incriminated as the sole agent responsible for hearing impairment. Historically, ototoxicity has been related primarily to very high total aminoglycoside dosages. High-frequency sensorineural hearing loss in infants with normal renal function is more likely if the total dosage exceeds 500 mg per kilogram. Data from the first neonatal meningitis cooperative study indicated that profound deafness, potentially related to gentamicin exposure, developed in only 1.3%, of 79 infants who received a minimum of 5 to 7.5 mg per kilogram per day of the drug for 3 weeks or longer. Auditory toxicity was reported in a very small number of infants in the largest meta-analysis to date of once-daily gentamicin compared with standard interval dose regimen. Vestibular toxicity is difficult to assess in neonates and has not been evaluated. The precise mechanism involved in ototoxicity is unknown. Some evidence suggests that point mutations in mitochondrial DNA are relevant to explain hearing loss in selected persons after aminoglycoside treatment. Mutations in 12S ribosomal RNA, rRNA, gene have also been associated with aminoglycoside-induced ototoxicity. However, in a recent study of 436 neonates, mutations in 12S rRNA occurred in only 0.9%. In this cohort, 39, that is 9%, infants failed initial hearing assessment, but only one of these infants had a 12S rRNA mutation. Low birth weight remained the largest risk factor for failed hearing screen. Even for the rare hospitalized infant with ototoxicity after receiving concurrent dosages of aminoglycosides, it is difficult to establish a direct causal relationship in many of the published studies because of the complicated clinical histories. Aminoglycoside-associated neuromuscular blockade has been reported only rarely. The underlying mechanism appears to be inhibition of acetylcholine release at the neuromuscular junction by these drugs. The aminoglycoside may act alone or synergistically with other neuromuscular blocking agents. Hypermagnesemia in newborns, often resulting from antenatal exposure to maternal magnesium administered for preeclampsia, may potentiate the neuromuscular blocking effects of aminoglycosides. Diagnosis is made by nerve conduction studies, which reveal a progressive fatigue and post-tetanic facilitation characteristic of a non-depolarizing, Carrare-like neuromuscular block. Reversal of this block is achieved by neostigmine or calcium, or both. Potentiation of neuromuscular blockade can be observed in infant botulism when aminoglycosides are administered to treat suspected sepsis. Prophylactic treatment with calcium is not indicated because this cation may interfere with the antimicrobial activity of aminoglycosides against certain organisms. Next we will discuss PK/PD and clinical implications for dosing. See tables 37.6, 37.8, and 37.9. The aminoglycosides still remain effective for the initial empirical therapy in newborns with suspected early-onset sepsis. The choice of aminoglycoside to be routinely used is mainly dependent on the patterns of microbial resistance within a nursery. Amikacin remains one option for empirical treatment when multi-drug-resistant coliforms are frequently isolated within an individual neonatal unit. The aminoglycosides are usually safe to use in the newborn when administered according to the recommended dosage schedules. Therapeutic drug monitoring is helpful, particularly in premature infants and infants with hypoxemia, renal dysfunction, or critical illness. Therapeutic drug monitoring is needed to guide dosing in infants on ECMO. Systemic aminoglycoside therapy remains an acceptable initial empirical treatment choice when meningitis is present because, in combination with ampicillin, this agent offers potential synergistic activity against group B streptococci and Listeria monocytogenes. Aminoglycosides have been demonstrated to be effective for therapy for meningitis caused by susceptible gram-negative bacteria. However, if gram-negative bacilli are seen on CSF smears or later isolated as the causative agent of meningitis, third-generation cephalosporins or carbapenems should be considered. Combined therapy with a cephalosporin and an aminoglycoside is often used for the first 7 to 10 days of therapy for possible synergistic bacterial killing and to prevent emergence of bacterial resistance during the treatment, especially for meningitis caused by Serratia, Pseudomonas, Acinetobacter, Citrobacter, and Enterobacter species. Aminoglycosides demonstrate concentration-dependent bactericidal activity. See Table 37.8. In vitro time-kill curves and animal studies both demonstrate increased rate and extent of killing with increasing concentration of aminoglycosides. Early studies in gram-negative infections showed clinical response was associated with peak serum concentrations of greater than 7 micrograms per milliliter for gentamicin and tobramycin and 28 micrograms per milliliter for amikacin. Subsequently, adult studies demonstrated effective response to therapy near 90% for a peak to MIC ratio of greater than 8:1 for Escherichia coli bacteremia or greater than or equal to 10:1 for gram-negative pneumonia. The PD of aminoglycosides in the treatment of gram-negative infections has not been evaluated in infants. In addition to therapeutic killing, high concentrations of aminoglycosides also provide a post-antibiotic effect, that is, the sustained suppression of bacterial growth even after the antibiotic concentration is below the MIC of the target organism. In vitro, Aminoglycosides demonstrate a post-antibiotic effect of 1 to 3 hours against P. aeruginosa and 1 to 2 hours against Enterobacteriaceae. Animal models suggest an even longer period of post-antibiotic effect, 2 to 7.5 hours. The post-antibiotic effect is prolonged by increasing aminoglycoside concentration and in the presence of neutrophils. Post-antibiotic effect has not been demonstrated in clinical trials, given ethical restraints of such studies. The duration of post-antibiotic effect is unknown in neonates, but given the immature immunity of neonates, it may be less than calculated in animal models. Ideally, dosing regimens for aminoglycosides would attempt to maximize killing, take advantage of the post-antibiotic effect, minimize adaptive resistance, reduce emergence of resistance, and diminish the potential for toxicity. Therapeutic drug monitoring is used to individualize dosage regimens. To achieve this PD target, peak serum concentrations should be maintained at 8 to 12 micrograms per milliliter for gentamicin and tobramycin, and at 20 to 30 micrograms per milliliter for amikacin, in other words, a peak, Cmax, to MIC ratio of greater than 8 to 10. To potentially minimize the rare risk of toxicity, trough values are typically kept below 2 micrograms per milliliter for the former drugs and below 5 micrograms per milliliter for amikacin. To determine peak serum concentrations, blood samples are obtained 30 minutes after completion of the IV infusion or 45 to 60 minutes after an IM administration. Trough serum concentrations are measured just before the next dose of the aminoglycoside. Pause the video and carefully scrutinize Table 37.9 summarizing serum peak and trough concentrations of gentamicin in preterm and term neonate before advancing to the next slide. We will now discuss the use of extended dosing intervals to achieve pharmacodynamic exposure targets. See Tables 37.6 and 37.9. Analysis of peak and trough concentrations reveals significant interpatient variability within and between studies. Clinical trials have compared gentamicin concentrations using traditional and extended interval dosing regimens in primarily term and near-term neonates in the first week after birth. A Cochrane Review meta-analysis concludes that once-daily extended interval dosing was associated with fewer failures to attain a peak level of at least 5 micrograms per milliliter and fewer failures to achieve trough levels of less than or equal to 2 micrograms per milliliter compared with multiple doses per day regimens. Ototoxicity and nephrotoxicity were not noted with either treatment regimen. Both regimens showed adequate clearance of sepsis. However, the studies may have been underpowered to show a difference in efficacy with true bacteremia. The rationale for use of extended dosing intervals is based on several PK, PD, and microbiologic principles of aminoglycosides. 1. Aminoglycosides exhibit concentration-dependent bacterial killing in which higher peak to MIC ratios are associated with improved bactericidal response. Cmax to MIC ratios greater than 8 to 10 have been linked to superior efficacy of aminoglycosides against gram-negative bacteria. 2. Aminoglycosides exhibit a post-antibiotic effect in which bacterial growth is suppressed despite serum concentrations below the MIC. Drug concentrations, therefore, can remain below the pathogen's MIC for a period without compromising efficacy. 3. Nephrotoxicity is associated with aminoglycoside uptake into renal cells and possibly into the cochlear and vestibular membrane, but cellular uptake is more efficient with low sustained concentrations, and, in animals, Uptake is a saturable process so that transient high peak levels do not lead to excessive drug accumulation. 4. Gram-negative bacteria have been shown to exhibit adaptive resistance after continuous exposure to aminoglycosides, a property that may be minimized by providing high bactericidal exposures, minimizing time for bacterial growth in presence of antibiotic. 5. The lower glomerular filtration rate in neonates, especially the first few days of life, and preterm infants suggests that more time for clearance may be needed to avoid toxic accumulation of aminoglycosides. 6. Finally, once-daily dosing is associated with lower hospital costs. Although increased peak concentrations lengthen the duration of post-antibiotic effect, the pharmacodynamics of this phenomenon in neonates has not been defined. Considerable evidence generated in adults with extended dosing intervals of aminoglycoside administration prompted studies in the pediatric and neonatal populations. A meta-analysis of the comparison trials has been conducted in neonates to evaluate peak and trough gentamicin, tobramycin, or amikacin concentrations after administration of standard dosing and once-daily dosing regimens. See Table 37-9. Mean peak concentrations in each study were higher in the once-daily regimen than in the twice-daily group, and mean trough concentrations were lower in the daily group than in the standard group. Dose adjustment was indicated more often in the standard dosing groups. One study compared 2.5 to 3 mg per kilogram dosing every 24 hours with 4.5 to 5 mg per kilogram dosing every 48 hours in 58 very low birth weight infants, 600 to 1500 grams. The 48-hour dosing schedule achieved therapeutic serum concentrations and higher peak to MIC ratios for infecting microorganisms. Nearly one-third of these infants, however, had extremely low serum gentamicin concentrations before the next dose, suggesting that a 36-hour interval might be more appropriate for very low birth weight infants. Another study evaluated single doses of 5 mg per kilogram of tobramycin and gentamicin administered at extended intervals, and found that only 1.3% of these infants had subtherapeutic concentrations compared with 26.8% of those given the traditional 2.5 mg per kilogram doses. Once-daily interval dosing was also explored for amikacin. See Table 37-9. In term infants, 15 mg per kilogram daily amikacin therapy in the first 3 days of life leads to significantly increased peak levels that are more likely to achieve the PD target compared with multiple doses per day traditional regimens. Both regimens yield trough levels less than 5 micrograms per milliliter. Preterm infants required higher doses and longer dosing intervals to achieve desired targets, depending on gestational age group. It was also proposed that dosage interval be extended for infants with a history of hypoxia or who were receiving concurrent indomethacin therapy. Amikacin-associated nephrotoxicity was not observed, and results of auditory evaluation were similar in study participants and non-study control subjects. However, when amikacin dosing guidance was prospectively evaluated, patient variability was notable. De Kock and colleagues reviewed amikacin concentrations in 874 neonates, 24 to 43 weeks gestational age, and determined that when routine dosing strategies are used, 20% of infants did not achieve targeted exposure resulting from the inherent inter-individual variability in kinetics of drug clearance in preterm and term infants, typically because of slightly higher peak and trough concentrations. They then created a population PK model from these amikacin concentrations and used simulated exposure profiles to explore dosing strategies for more consistent exposures. Their very detailed dosing algorithm, 10 strata, recommends dose, that is 12 to 20 mg per kilogram, and interval, that is 20 to 48 hours, adjustment based upon current body weight, less than 800 grams, 800 to 1,200 grams, 1,200 to 2,000 grams, 2,000 to 2,800 grams, and above 2,800 grams, and postnatal age, that is less than 14 days of age, equal to or more than 14 days of age. Even using the most elaborate dosing guidance that takes into account weight, postnatal age, and gestational age, therapeutic drug monitoring will likely remain necessary for preterm neonates and those receiving greater than 48 hours of amikacin. In summary, a Cochrane Review meta-analysis concludes that once-daily or extended-interval gentamicin dosing was associated with fewer failures to attain a peak level of at least 5 micrograms per milliliter and fewer failures to achieve trough levels of less than or equal to 2 micrograms per milliliter, compared with multiple doses per day regimens. Analysis of peak and trough concentrations reveals significant interpatient variability within and between studies. Many recommend using population PK-derived dosing for first dose, then therapeutic drug monitoring 24 hours after the first dose to determine the individual patient's kinetics, and then modifying dosing and interval on an individual basis. Ototoxicity and nephrotoxicity were not noted with either treatment regimen. Both regimens showed adequate clearance of sepsis. However, the studies may have been underpowered to show a difference in efficacy with true bacteremia. They conclude that based on PK properties and PD targets, the once-per-day regimen may be superior in treating sepsis in neonates greater than 32 weeks of gestation. Next we will discuss aztaranem. Aztaranem is the first synthetic monocyclic beta-lactam, also called a monobactam, antibiotic approved for use in clinical medicine. Its aminoglycoside-like activity, good CSF penetration, and absence of nephrotoxic or ototoxic side effects make aztaranem potentially useful when combined with ampicillin for initial empirical therapy in newborns with severe, suspected sepsis. We will now discuss the antimicrobial activity of aztaranem. Aztaranem has good activity against a broad spectrum of aerobic gram-negative bacteria, but its activity against gram-positive or anaerobic organisms is poor. Most Escherichia coli, Klebsiella pneumoniae, and Citrobacter species are inhibited by less than 1 microgram per milliliter of aztaranem. Serratia and Enterobacter are less susceptible, MIC 90, 1 to 4 micrograms per milliliter, whereas Haemophilus influenza and Neisseria gonorrhoeae are more susceptible, MIC 90 0.2 micrograms per milliliter or less. Higher concentrations of aztaranem are needed to inhibit growth of Pseudomonas aeruginosa, MIC 8 to 12 micrograms per milliliter. Like other beta-lactams, aztaranem exerts its antimicrobial activity by interfering with bacterial cell wall synthesis by binding to PBPs, especially PBP3 of aerobic gram-negative bacteria. This drug is stable to hydrolysis by chromosome or plasmid-mediated beta-lactamases of the Enterobacteriaceae and does not induce chromosomal beta-lactamase production. We will now progress to the pharmacokinetic data of aztaranem. The PK of IV aztaranem, dosed at 20 to 30 mg per kilogram per dose of body weight, has been evaluated in a limited number of neonates. Serum concentrations and half-life decreased with chronologic age. The mean serum aztreonam concentration was 54 micrograms per milliliter in first week of life and 45 micrograms per milliliter in infants 2 to 22 days of age. The half-life decreased from 3.5 to 6.6 hours in 0 to 3-day-old neonates to 2 to 4 hours thereafter. Small premature infants weighing less than 1,500 grams have longer half-lives compared with larger preterm infants, 5.3 versus 4.1 hours respectively. A larger 30 mg per kilogram IV dose of aztreonam administered to infants weighing less than 2,000 grams during their first week of life resulted in peak serum concentrations from 65 to 79 micrograms per milliliter after the first dose and 77 to 83 micrograms per milliliter after 3 to 6 days of therapy. Trough values were highly variable and ranged between 8.2 and 70.7 micrograms per milliliter. The half-life decreased from 7.6 to 5.5 hours after 3 to 6 doses. Older infants and young children have a shorter mean half-life of 1.7 hours. Aztreonam has good penetration into the CSF of new bones with bacterial meningitis. In a 7-day-old infant with newly diagnosed bacterial meningitis, a CSF concentration of 13.3 micrograms per milliliter was obtained 1.3 hours after an aztreonam dose, representing 18.8% of a simultaneously measured serum concentration. Pediatric patients with acute bacterial meningitis have concentrations of aztreonam in CSF that are 17% to 33% of serum values. We will now progress to the safety of aztreonam. Aztreonam appears to be well tolerated with no apparent side effects when given intravenously to newborns in PK studies. Adverse reactions described in adults include rashes, nausea, diarrhea, and eosinophilia, but their incidence is low. Aztreonam effects on bowel flora are limited to a reduction in coliforms without significant changes in anaerobic bacteria. Colonization by resistant bacteria resulting from aztreonam therapy does not appear to be as much of a problem as that encountered with the use of the third-generation cephalosporins. Because aztreonam contains 780 mg arginine per gram of antibiotic, concern has been raised regarding possible arginine-induced hypoglycemia. Arginine is rapidly metabolized and can be transformed to glucose, leading to transient hypoglycemia. As a result of this transient hypoglycemia, insulin concentrations can immediately rise, with the subsequent induction of hypoglycemia. These fluctuations in blood glucose and subsequent variation in insulin concentration can be potentially important in premature infants exposed to a metabolic stress. A study addressing this safety issue indicated that aztreonam was well tolerated and safe in premature infants when a glucose solution was concomitantly infused, at a glucose infusion rate greater than 5 mg per kilogram per minute. We will now switch gears to PK/PD and clinical implications for dosing of aztreonam. Aztreonam remains off-label for neonates and infants younger than 3 months. Data from a prospective, randomized study of 58 neonates with infections caused by gram-negative bacilli, including Pseudomonas aeruginosa, suggest that the use of aztreonam in combination with ampicillin is as effective as treatment with ampicillin and amikacin. Individual aztreonam doses of 30 mg per kilogram given 2 to 4 times daily can achieve median peak serum bactericidal titers of about 1 to 16 and can maintain trough serum concentrations that exceed the MIC 90 for most gram-negative bacteria. We will now progress to cephalosporins. Cephalosporins are semi-synthetic derivatives of a 7-aminocephalosporinic acid nucleus. Individual derivatives differ chemically by the addition of various side chains. The cephalosporins exert their antibacterial action in a manner similar to that described earlier for penicillin. It has become customary to group cephalosporins into generations of agents on the basis of their antibacterial spectrum of activity. In the following section, we have focused on the most well-studied cephalosporins in neonates. We will now progress to the antimicrobial activity of cephalosporins. The first-generation cephalosporins have good activity against gram-positive organisms but limited activity against gram-negative bacteria. First-generation cephalosporins include cefazolin, cephalothin, cephalexin, and cephadroxil. Susceptible pathogens include streptococci, penicillin-susceptible and penicillin-resistant staphylococci, and penicillin-susceptible pneumococci. Although typically the activity against coliforms is good, other antibiotics are often preferred for treatment of infections caused by these organisms. Pseudomonas aeruginosa, Serratia marcescens, Enterococci, MRSA, Listeria monocytogenes, Enterobacter ceces, indole-positive Proteus species, and Bacteroides fragilis all are resistant to these antibacterial agents. Compared with first-generation cephalosporins, second-generation agents have improved stability to hydrolysis by beta-lactamases and therefore have increased activity against many gram-negative bacteria. Second-generation agents include cefaclor, kevaprozole, cefamondole, cefuroxime, and loracabef. Cefuroxime is more active than cephalothin against group B streptococci, pneumococci, and gram-negative enteric bacilli and also is active against Haemophilus influenza, meningococci, gonococci, and staphylococci. The second-generation agents have very poor activity against Pseudomonas aeruginosa, Enterococci, and Listeria monocytogenes. The third-generation cephalosporins have excellent in vitro activity against Haemophilus influenza, gonococci, meningococci, and many gram-negative enteric bacilli. Third-generation agents include cefpoperazone, cefotaxime, ceftazoxime, ceftriaxone, and ceftazidime. Ceftazidime and cefpoperazone, however, are the only ones with adequate anti-Pseudomonas activity. Listeria monocytogenes and Enterococci are uniformly resistant to these agents. Resistance has emerged as a problem with ceftazidime. Susceptibility of gram-positive organisms to these agents is variable but generally is lower than first- or second-generation cephalosporins. The fourth-generation cephalosporins, notably cefepam, demonstrate activity against gram-positive and gram-negative bacterial pathogens, including Pseudomonas aeruginosa. Cefepam has been shown to be effective for therapy for meningitis in children and is useful for treatment of multi-drug-resistant gram-negative bacillary infections in pediatric patients. Some isolates of ceftazidime and cefotaxime-resistant Enterobacter species are susceptible to cefepam. Resistant organisms include Enterococci, Listeria monocytogenes, MRSA, MRSE, and anaerobes. Cephalosporins interfere with bacterial cell wall synthesis, thus lysing bacteria. Cephalosporins must pass through the bacterial cell membrane and bind the penicillin binding proteins that cross-link peptidoglycan polymers. Enterococcus is resistant to cephalosporins because their penicillin binding proteins do not bind cephalosporins. Resistance to the cephalosporins develops through several mechanisms. cephalothin and cefazolin can be inactivated by beta-lactamases. Exposure of some gram-negative bacteria, such as Pseudomonas aeruginosa or Enterobacter cloaca, to second or third generation agents can induce the production of chromosomally mediated potent beta-lactamases by these bacteria, which can hydrolyze even the beta-lactamase stable cephalosporins. Several plasmid-mediated beta-lactamases have been shown to play a role in the resistance of certain gram-negative enteric bacilli to third-generation cephalosporins. Other mechanisms of resistance include alterations in the permeability of the outer membranes of gram-negative bacteria to these drugs that limit their ability to reach the penicillin-binding protein target sites. Mutations leading to functional or quantitative changes in penicillin-binding proteins constitute an additional means by which bacteria can resist the antimicrobial action of these drugs. We will now discuss pharmacokinetic data. Let's begin with cefazolin, shown in Table 3710. The IM administration of 25 mg per kilogram doses of cefazolin produces peak serum concentrations of 55 to 65 micrograms per milliliter 1 hour after the dose. The concentrations at 12 hours drop to 13 to 18 micrograms per milliliter. IV doses of 25 mg per kilogram administered to 6 premature infants 2 to 12 days of age resulted in mean serum concentrations of 92, 79, 48, and 12 micrograms per milliliter at 0.5, 1, 4, and 12 hours, respectively, after the end of the infusion. In a study of 11 late preterm infants, mean 35 weeks, mean postnatal age 9 days, cefazolin clearance was estimated to be 0.048 liter per hour per kilogram, and volume of distribution was 0.28 liter per kilogram. The drug is excreted in the urine in unchanged form. The serum half-life of cefazolin decreases from 4.5 to 5 hours in the first week of life to approximately 3 hours by 3 to 4 weeks of age. Cefazolin often exhibits significant protein binding, range 20% to 80%. CSF penetration of cefazolin is poor. Next we will focus on cefuroxime. See Table 3710. Intramuscular doses of 25 mg per kilogram given to neonates weighing less than 2.5 kilograms during their first week of life produce mean serum concentrations of 49, 30, and 15 micrograms per milliliter at 2, 4, and 8 hours after the injection, respectively. For larger newborns, the corresponding values were lower, 34, 21, and 9 micrograms per milliliter, respectively. A study of preterm and term infants receiving cefuroxime 25 mg per kilogram every 12 hours resulted in median steady-state serum concentrations of 45, 26, and 11 micrograms per milliliter after 0.5, 5, and 12 hours, respectively. Repeated administration of the drug did not result in serum accumulation. About 70% of the daily cefuroxime dose could be recovered in the urine in a 24-hour period. Half-life times have been reported to range from 2 to 11 hours, mean 6 hours. CSF cefuroxime concentrations of 2.3 to 5.3 micrograms per milliliter were measured in 3 newborns with meningitis. These values represented 12% to 25% of the corresponding serum concentrations. In 3 other neonates without meningeal inflammation, concentrations were lower and ranged from 0.4 to 1.5 micrograms per milliliter. Next we will discuss sfotaxime, see Table 3710. About 80% of the sfotaxime dose is excreted in the urine. However, only a third of the drug is eliminated in unchanged form. Sfotaxime is rapidly metabolized in the body to desacetyl-sfotaxime through the action of esterases found in the liver, erythrocytes, and other tissues. This metabolite is biologically active, but its antibacterial activity is generally lower than that of sfotaxime. Synergistic interactions against many organisms can be demonstrated when these two compounds are combined in vitro. Desacetyl-sfotaxime accounts for 15% to 45% of the peak and 45% to 70% of the trough concentrations of total sfotaxime. Several investigators have evaluated the PK properties of sfotaxime in newborns. A 25 mg per kilogram IV dose produces concentrations of 60 to 80 micrograms per milliliter immediately after the end of drug infusion, which decreases to 35 to 50 micrograms per milliliter 30 minutes later. Serum sfotaxime concentrations are higher in premature newborns and in those younger than 1 week. The administration of a 50 mg per kilogram IV dose during the first week of life results in peak serum concentrations of 116 micrograms per milliliter, range 46 to 186 micrograms per milliliter, in low body weight infants compared with 133 micrograms per milliliter, range 76 to 208 micrograms per milliliter, in term neonates. Values decline thereafter to approximately 34 to 38 micrograms per milliliter 6 hours after the dose. The mean half-life is 4.6 hours for low body weight neonates and 3.4 hours for larger newborns. Both sfotaxime and its metabolite penetrate well into the CSF of infants with meningitis. Concentrations of 7.1 to 30 micrograms per milliliter are detected 1 to 2 hours after a 50 mg per kilogram IV dose and represented 27% to 63%, respectively, of simultaneously measured serum values. CSF concentrations as high as 20 micrograms per milliliter in neonates with or without meningitis have been reported. The PK of sfotaxime and its metabolite desacetyl-sfotaxime was recently described for infants during ECMO. Plasma samples from 37 neonates on ECMO were evaluated. Infants received sfotaxime 50 mg per kilogram every 12 hours, that is a postnatal age less than 1 week, every 8 hours, postnatal age of 1 to 4 weeks, or 37.5 mg per kilogram every 6 hours for infants older than 4 weeks. Sfotaxime clearance was 0.36 liter per hour, with wide variability of 0.19 to 0.75 liter per hour. The volume of distribution was 1.82 liters and ranged from 0.73 to 3.02 liters. Volume of distribution for desacetyl-sfotaxime was very large, 11 liters, range 2 to 28 liters. Elimination half-life for sfotaxime and desacetyl-sfotaxime were 3.5 and 5.4 hours, respectively. Sfotaxime concentrations were well above the MIC of 8 micrograms per milliliter for the entire dosing interval. Desacetyl-sfotaxime concentrations were variable, with a median concentration of 10 micrograms per milliliter in the first 12 hours post-dose. For infants on ECMO, the sfotaxime standard dosing regimen seemed to provide for sfotaxime concentrations to remain above the MIC of typical organisms for the dosing intervals. Pause the video and carefully scrutinize Table 3710 summarizing the pharmacology of cephalosporins before advancing to the next slide. Cefepam. See Table 3710. Cefepime is eliminated through the kidney, mainly unchanged in the urine. PK studies in neonates given a 50 mg per kilogram IV dose every 12 hours have shown a mean C max of 89 to 121 micrograms per milliliter, half-life of 4.3 to 4.9 hours, and clearance of 1.2 milliliters per minute per kilogram. Premature infants have delayed clearance and prolonged half-life because of immature renal function and increased volume of distribution resulting from increased total body water composition. Serum creatinine is negatively associated with cefepime clearance. Penetration into CSF appears to be good, with CSF concentrations averaging 3.3 to 5.7 micrograms per milliliter at 0.5 and 8 hours, respectively, after drug administration. Clearance increases twofold in older infants, leading to a much shorter half-life and drug administration at shorter intervals. We will now discuss the safety of cephalosporins. In general, cephalosporins are well tolerated by neonates. Adverse reactions that have been observed, mostly in older patients, include hypersensitivity reactions, diarrhea, thrombophlebitis, pain on IM injection, eosinophilia, leukopenia, granulocytopenia, and seizures related to the administration of massive doses of these drugs. Falsely elevated serum creatinine concentrations have been observed in patients who received cefoxitin or cephalothin. Alterations of the bowel bacterial flora are most pronounced with the third-generation agents, especially ceftriaxone and cefoperazone, and can lead to intestinal colonization by resistant organisms, such as Candida, Pseudomonas, Enterobacter, or Enterococcus species. Subsequent superinfections by these drug-resistant pathogens have been described in neonates. Another potential adverse effect related to disruption of bacterial intestinal flora by potent cephalosporins is the induction of antibiotic-associated colitis, presumably caused by overgrowth of toxin-producing Clostridioides difficile. Bleeding disorders occurring with the use of cephalosporins have been well documented, mostly in adults. Hemostatic abnormalities associated with the use of cephalosporins can be mediated by several mechanisms. Immune-mediated platelet destruction with resultant thrombocytopenia is very rare, but has been associated with cephalosporin exposure in older patients. A second rare mechanism involves the development of antibodies, usually immunoglobulin G, against certain clotting factors, such as factor V or VIII. Platelet dysfunction can be observed after several days of therapy with any of the cephalosporins. These drugs may inhibit adenosine diphosphate-induced platelet aggregation, with resultant prolongation of the bleeding time. The effect is slowly reversible after discontinuation of the drug. Another mechanism is defective fibrinogen to fibrin conversion, which has been observed with drugs such as cefazolin and cefamandol, particularly in patients with renal failure, who have very high serum antibiotic concentrations. The most important mechanism of hemostatic abnormalities involves interference with the production of vitamin K-dependent clotting factors, that is 2, 7, 9, and 10, with resultant hypoprothrombemia. This effect, observed most commonly with moxilactam and cefamandole therapy and rarely with sfotaxime and ceftriaxone therapy, may be related to, but not necessarily caused by, the presence of the N-methylthiotetrazole side chain in moxilactam, cefamandole, and cefoperazone. In patients with inadequate dietary intake, inhibition of colonic bacteria such as Escherichia coli or Bacteroides, which are capable of vitamin K production, may lead to hypoprothrombemia secondary to vitamin K deficiency. This side effect usually is avoidable or reversible by the administration of supplemental vitamin K. Ceftriaxone is not generally recommended in neonates. Fatal outcomes have occurred in neonates who received ceftriaxone and calcium-containing products and had calcium ceftriaxone precipitates discovered in their lungs and kidneys. In addition, because ceftriaxone has a high avidity for protein binding, a theoretical concern is that its use in the neonatal period can be associated with a significant displacement of bilirubin from albumin binding sites, thereby inducing a hyperbilirubinemia. Ceftriaxone, when given to neonates in the first days of life, has been associated with an immediate and prolonged decrease in the reserve albumin concentration, which could predispose a vulnerable infant to bilirubin encephalopathy. In older children and adults, an immune-mediated severe hemolytic reaction to ceftriaxone has been described in children and adults. We will now switch gears to PK/PD and clinical implications for dosing of cephalosporins. Cephalosporins, like other beta-lactams, have time-dependent bacterial killing properties. Therefore, the PD target associated with bacterial killing is T greater than MIC. For most of these drugs, clearance occurs through renal elimination. As neonatal kidneys mature, dosing intervals need to decrease to provide therapeutic drug concentrations above the MIC of target organisms. The usefulness of first-generation cephalosporins for therapy for neonatal bacterial infections is restricted. Their activity against gram-negative bacteria is limited and unpredictable, and their penetration into the CSF is relatively poor. Thus, these drugs are not typically indicated for initial therapy for suspected neonatal bacterial infections. Cefazolin dosing is typically 25 mg per kilogram given intravenously every 12 hours for newborns weighing less than 2,000 grams in the first 2 weeks of life and every 8 hours for older infants. Extremely preterm infants may continue twice per day dosing for up to 28 days of life. For infants weighing greater than 2,000 grams, the dose is given every 8 to 12 hours in first week of life and every 8 hours thereafter. Use in neonates is generally limited to prophylaxis of perioperative infections and treatment of urinary tract and soft tissue infections caused by susceptible organisms. Although second-generation cephalosporins have been successfully used to treat neonatal infections caused by susceptible bacteria, these antibiotics are not typically recommended for routine use because of limited experience in newborns and because of their inferior activity to that of third-generation agents against gram-negative bacteria. As a group, third- and fourth-generation cephalosporins are useful agents for the treatment of suspected or proven bacterial infections in newborns. Their advantages include excellent in vitro activity against the major pathogens for newborns, including aminoglycoside-resistant gram-negative bacilli, adequate CSF penetration with resultant high bactericidal activity in CSF of infants with meningitis, and a proven record of safety and tolerability. Indications for use of individual agents vary in accordance with their pharmacologic properties. The clinical efficacy and safety of cefotaxime in the treatment of neonatal infections have been well documented in several studies. Cefotaxime is typically not used alone for initial therapy in suspected sepsis because of its poor activity against Listeria monocytogenes and Enterococci. The addition of ampicillin provides antibacterial coverage against these organisms. One potential problem associated with the routine use of this drug is the possible emergence of cefotaxime-resistant gram-negative bacteria in the nursery. Sfotaxime reaches CSF concentrations that are 50 to several hundred times greater than the MIC90 of susceptible gram-negative enteric bacilli or group B streptococci isolated from newborns with meningitis, and has therefore been shown to be effective for the treatment of neonatal meningitis caused by susceptible bacteria. The dosage of sfotaxime in newborns is 50 mg per kilogram every 12 hours during the first week of life and every 8 hours thereafter. In full-term infants older than 3 weeks, a 6-hour regimen can be used for treatment of meningitis. We do not recommend using ceftazidime alone for initial therapy for suspected neonatal sepsis, because this antibiotic is not active against enterococci and Listeria monocytogenes, and because of the possibility for emergence of cephalosporin-resistant gram-negative organisms. Treatment failures have occurred when the offending organism proved to be a gram-positive bacterium. Increased colonization and superinfection by resistant organisms, such as enterococci and Candida albicans, are additional concerns. Other drugs such as piperacillin, tazobactam, cefepime, or carbapenems are preferred for the treatment of Pseudomonas aeruginosa. Cefepime has been evaluated in young children with serious bacterial infections, including meningitis, and has been comparable in safety and efficacy to third-generation cephalosporins. PK information supports the typical dosing regimen, 30 mg per kilogram every 12 hours during first 2 to 4 weeks of life and 50 mg per kilogram every 12 hours thereafter. Meningitis or severe infections caused by Pseudomonas or Enterobacter species may require dosing every 8 hours or prolonged infusion times, lasting 4 hours, to maintain the concentrations above the MIC of offending organism. Although data on the use of cefepime in the neonatal period are sparse, because of its extended activity and stability against beta-lactamase-producing bacteria, cefepime can be used for treatment of multi-drug-resistant gram-negative infections. In a small randomized trial of 90 infants, cefepime was safe and therapeutically equivalent to sfotaxime for treatment of bacterial meningitis in infants and children. We will now switch gears to broad-acting agents with activity against Pseudomonas or anaerobes. See Table 3710. Let's begin with beta-lactam, beta-lactamase inhibitor antibiotics with a focus on antimicrobial activity. Combination beta-lactam and beta-lactamase inhibitor antibiotics, such as piperacillin tazobactam, ticarcillin clavulanet, offer broad-spectrum activity and have re-emerged as an alternative to extended-spectrum cephalosporins, particularly given the development of resistant pathogens. These drugs are bactericidal against many organisms, with the exception of methicillin-resistant staphylococcus and enterococcus, that is ticarcillin clavulanet. Recently, the use of beta-lactam, beta-lactamase combination antibiotics have become appealing in neonates because of their safety profiles and their decreased likelihood to propagate bacterial resistance compared with extended-spectrum cephalosporins. However, more PK and PD knowledge in neonates is needed to optimize dosing guidelines. These agents are not typically recommended for treatment of CSF infections because penetration of beta-lactamase inhibitors has not been well defined. We will now focus on piperacillin tazobactam. Let's begin with its antimicrobial activity. Piperacillin tazobactam is not approved by the FDA for use in infants younger than 2 months. However, it has been considered for neonates with proven bacterial infections, particularly those infected with difficult-to-treat polymicrobial sepsis or infections caused by Pseudomonas aeruginosa, Klebsiella pneumoniae, or necrotizing enterocolitis. Piperacillin is formulated with the beta-lactamase inhibitor tazobactam in an 8:1 ratio for IV preparation. Piperacillin is an acyl ampicillin, a semi-synthetic penicillin that is a piperazine derivative of ampicillin. Piperacillin is active against a broad range of gram-positive and gram-negative bacteria, including Staphylococcus aureus, Streptococci, Haemophilus influenza, Neisseria meningitidis, Listeria monocytogenes, Klebsiella pneumoniae, Proteus mirabilis, Serratia marcescens, and many anaerobes. In contrast to ticarcillin, piperacillin has better activity against Enterococci and Pseudomonas aeruginosa. In vitro synergistic activity with gentamicin has been demonstrated against Pseudomonas aeruginosa, coliforms, and susceptible Staphylococcus aureus strains. Synergy and antagonism has been demonstrated with cephalosporins, perhaps because of the ability of some cephalosporins to induce beta-lactamase production. We will now consider pharmacokinetic data of piperacillin tazobactam. See Table 3710. Piperacillin and tazobactam are widely distributed into tissue and body fluids, including the intestinal mucosa and biliary system. However, distribution into CSF is low in adults with non-inflamed meninges, as with most penicillins. Protein binding is estimated to be 30% for both piperacillin and tazobactam. Each drug is eliminated primarily through the kidneys via glomerular filtration and tubular secretion, with approximately 70% excreted as unchanged, active drug in the urine in children and adults. The primary non-renal route of elimination is biliary excretion. The piperacillin metabolite D-cethylpiperacillin maintains some microbiologic activity, whereas the single metabolite of tazobactam does not. Piperacillin-tazobactam elimination is dependent on renal function and therefore improves with age until adult clearance is achieved at about 2 years of age. Children receiving piperacillin-tazobactam have somewhat reduced piperacillin elimination and prolonged half-life, that is 0.7 versus 0.5 hours, respectively, compared with piperacillin alone, likely the result of competitive antagonism for renal tubular secretion. The PK of piperacillin as a solo agent has been evaluated in 98 neonates, that is 29 to 40 weeks of gestation, in the first 2 weeks of life. Preterm neonates have lower peak piperacillin concentrations because of their higher volume of distribution. In the first week after birth, the mean peak serum concentration after an IV 75 mg per kilogram dose is 180 micrograms per milliliter, 233 micrograms per milliliter, and 207 micrograms per milliliter for infants 29 to 31 weeks, 33 to 35 weeks, or 38 to 40 weeks of gestation, respectively. Immature renal function leads to prolonged half-life and delayed clearance, thus allowing preterm infants to maintain concentrations over the dosing interval. The mean 12-hour trough concentrations decreased from 20 micrograms per milliliter in 29 to 31-week gestational age infants to 5 micrograms per milliliter in term infants. In the second week of life, 8-hour trough concentrations decreased from 19 micrograms per milliliter for less than 33-week gestational age infants to 6 micrograms per milliliter for term infants. Piperacillin half-life similarly decreases with advanced gestational age, chronologic age, and birth weight consistent with renal maturation. The prolonged half-life in neonates decreases from 6 hours in the first 2 days after birth, to 4 hours in the first week, and to 2 hours by the second week. Infants with septic shock and significant renal insufficiency have prolonged half-life up to 14 hours. In older infants, The reported half-life of piperacillin is 0.75 hours in 1 to 6-month-old infants. The PK of piperacillin after administration of piperacillin-tazobactam combination has recently been explored. Piperacillin concentrations were evaluated from 32 young infants younger than 61 days, with a median GAR at birth of 32 weeks, range 23 to 40 weeks, who received open-label piperacillin-tazobactam at a dose of 80 to 100 mg per kilogram every 8 hours based on gestational age and postnatal age. Population PK models determined that clearance improved with postmenstrual age, and volume of distribution varied with weight. Clearance estimates were 0.08 liter per hour per kilogram, 95% confidence interval, 0.068 to 0.93, and volume of distribution was 0.42 liter per kilogram. The estimated half-life of 4 to 6 hours in neonates is longer than the half-life of 1.4 hours reported in older infants aged 2 to 6 months. CSF piperacillin concentrations of 2.6 to 6 microgram per milliliter were measured in 3 neonates without meningitis within 7 hours of the IV administration of a 100 mg per kilogram dose. In one infant with Pseudomonas meningitis, piperacillin reached a concentration of 19 microgram per milliliter in the CSF 2.5 hours after administration of a 200 mg per kilogram IV dose. Human and animal models suggest that modest CSF penetration is expected for beta-lactamase inhibitors. Next we will discuss the safety of piperacillin-tazobactam. In a prospective, randomized, comparative, open-label trial of children with severe intra-abdominal infections, patients receiving piperacillin-tazobactam had a similar rate of adverse reactions when compared with those receiving sfotaxime and metronidazole. Adverse events were reported in greater than 1% of children in this study, including diarrhea, fever, vomiting, local reaction, abscess, sepsis, abdominal pain, infection, bloody diarrhea, pharyngitis, constipation and elevated liver enzyme. These adverse events were infrequent compared with transient complications encountered in adult trials. Bleeding manifestations, neuromuscular excitability, and seizures have occurred in patients receiving beta-lactam antibiotics, including piperacillin. Impaired hemostasis secondary to platelet dysfunction occurs less frequently than with carbenicillin and ticarcillin. The sodium content in piperacillin is less than half that in ticarcillin, which may be important in some newborns with cardiac or renal disease. We will now discuss PK/PD and clinical implications for dosing piperacillin-tazobactam. Piperacillin-tazobactam, either alone or combined with aminoglycosides, has been used successfully for the treatment of bacteriologically proven neonatal infections. Neonatal PK knowledge and clinical experience are limited, and dosing recommendations remain empirical. Piperacillin and tazobactam are both mainly eliminated through the kidney by glomerular filtration and tubular secretion. Therefore, dosing adjustment with postmenstrual age is rational. In a recent review, the most common indications in piperacillin-tazobactam use in pediatric patients were nosocomial infections caused by resistant gram-negative bacteria, exacerbation of pulmonary colonization with Pseudomonas aeruginosa in patients with cystic fibrosis, intra-abdominal infections, and fever and neutropenia in pediatric cancer patients. The PD of efficacy for beta-lactam antibiotics depends on the time that the drug concentration exceeds the MIC for the pathogen. To maintain piperacillin concentrations above the MIC, The dosing interval may need to be shortened or infusion time extended when treating susceptible pathogens with MICs greater than 4 to 8 micrograms per milliliter, such as can be seen for Pseudomonas, Enterobacter, or Klebsiella. Given the modest CSF penetration, higher dosages may be considered for meningitis. Dosing recommendations are variable and hindered by the paucity of PK data. Recent piperacillin-tazobactam population PK study, with modeling and simulation of piperacillin dose-exposure relationship, suggested that a dose of 80 to 100 mg per kilogram every 4 to 8 hours, depending on postmenstrual age, could allow for greater than 90% of infants to maintain piperacillin concentrations above the MIC 32 for at least 75% of dosing interval. Specifically, infants with postmenstrual age less than 30 weeks receive 100 mg per kilogram every 8 hours. Infants with postmenstrual age 30 to 35 weeks receive 80 mg per kilogram every 8 hours, and infants with postmenstrual age 35 to 49 weeks receive 80 mg per kilogram every 4 hours. This target MIC of 32 is the upper breakpoint for susceptibility for very difficult to treat pseudomonal infections. This dosing is consistent with previous recommendations, with more specific postmenstrual age adjustments now offered. Dosing guidance in NeoFAX, 50 to 100 mg per kilogram dose every 8 to 12 hours, based on postmenstrual age and postnatal age, would maintain exposure for at least 75% of dosing interval only if MIC was less than 8 micrograms per milliliter. Evaluation of neonatal trough concentrations at 8 hours would help ensure that levels can be maintained above the MIC for at least 50% to 75% of the dosing interval. We will now focus on ticarcillin clavulanate. See Table 3710. Ticarcillin is a semi-synthetic penicillin with pharmacologic and toxic properties virtually identical to those of other semi-synthetic penicillin. The co-administration of clavulanic acid with ticarcillin significantly enhances the antibacterial activity of the latter drug against several organisms, including some ticarcillin-resistant strains of Escherichia coli, Klebsiella pneumoniae, Proteus mirabilis, and Staphylococci. Enterococcus species are resistant to ticarcillin. Clavulanate is a beta-lactam with weak antibacterial activity, but it has the property of being a potent irreversible inhibitor of several beta-lactamases produced by gram-positive and gram-negative bacteria. Current ticarcillin clavulanate combination formulation, marketed as Tormentin R, is approved for children older than 3 months for the treatment of bacterial sepsis, respiratory infections, urinary tract infections, and intra-abdominal infections. Point 1 Information regarding the use of this compound in newborns is limited. Ticarcillin activity against Pseudomonas aeruginosa and its formulation with the beta-lactamase inhibitor clavulanate make it attractive for serious bacterial disease of neonates. Synergy with aminoglycosides has been demonstrated for the treatment of some strains of Pseudomonas. We will now progress to the pharmacokinetic data of ticarcillin clavulanate. Ticarcillin clavulanate is available for IV administration in a 30:1 ticarcillin to clavulanate ratio. Like piperacillin, ticarcillin is eliminated via glomerular filtration and renal tubular secretion. Approximately 60% to 70% of ticarcillin is excreted unchanged in urine during the first 6 hours after administration. However, only 30% to 40% of clavulanic acid is excreted unchanged in the urine, whereas the remainder undergoes non-renal metabolism. Ticarcillin is approximately 45% protein-bound, whereas clavulanic acid is approximately 25% protein-bound. Ticarcillin penetrates well into bile and pleural fluid. PK data for ticarcillin clavulanic acid has been assessed in a limited number of preterm and term neonates. However, the ratio of ticarcillin to clavulanate was not consistent between reports. In a study of 24 newborns, that is 25 to 39 weeks of gestation, who received 80 mg per kilogram ticarcillin and 3.5 mg per kilogram clavulanate, the ticarcillin peak serum concentrations, mean, 183 micrograms per milliliter. Range, 100 to 400 micrograms per milliliter, and half-life, mean, 4.5 hours. Range, 1.2 to 9.5. Are similar to those observed after administration of ticarcillin alone. The ticarcillin and clavulanate half-lives were shorter in term infants, ticarcillin, 2.7 hours, clavulanate, 1.4 hours, than preterm infants, ticarcillin, 4.2 hours, clavulanate, 2.6 hours. Similar results were reported for the 1PK study that evaluated the commercially available product with a 30:1 ratio of ticarcillin to clavulanate. Ticarcillin and clavulanate have different PK profiles. Ticarcillin is renally eliminated, and clearance improves with renal maturation and chronologic age. Alternatively, clavulanate is eliminated through non-renal mechanisms, and clearance is more rapid. Ticarcillin accumulates in young neonates because of renal immaturity. However, clavulanate does not, and therefore the ticarcillin to clavulanate ratio observed in older patients is not likely to be maintained in neonates. Simulation of ticarcillin and clavulanate exposure using a population PK model suggested that a lower dose, 50 mg per kilogram ticarcillin, administered more frequently, that is, every 6 hours, was needed to maintain both ticarcillin and clavulanate levels. The significance of altered ticarcillin to clavulanate ratios is unclear, because we do not know the optimal duration or concentration for serum clavulanate. We will now discuss the safety of ticarcillin clavulanate. Ticarcillin clavulanate possesses the characteristic safety profile of other penicillin antibiotics. Adverse reactions include anaphylaxis, bleeding disorders, seizures, headache, gastrointestinal disturbances, transient elevation hepatic enzymes, hypernatremia, and hyperkalemia. Ticarcillin clavulanate has been studied in 296 children, that is greater than 3 months of age, in controlled trials and another 408 children in uncontrolled clinical trials. Clinical trials in neonates are lacking. Anecdotal reports and small case series suggest that ticarcillin clavulanate is well tolerated in neonates. We will now focus on PK/PD and clinical implications for dosing of ticarcillin clavulanate. Ticarcillin clavulanate is typically used along with an aminoglycoside for infants with severe gram-negative enteric infections or Pseudomonas sepsis and anecdotally with satisfactory safety and effectiveness. The most consistent dosing recommendation for neonates is 50 mg per kilogram every 6 hours, the same dose as recommended in infants older than 3 months with moderate infections. Frequent dosing is needed to maintain clavulanic acid levels because clavulanic acid clearance is more rapid than ticarcillin in infants. Clavulanic acid CSF penetration is only modest and is inconsistent in adult and animal models. Therefore, its use in treatment of CNS infections is discouraged. Ticarcillin clavulinate should not be mixed in the same container or administered simultaneously with an aminoglycoside because of the physical and chemical incompatibilities between these two drug classes. We will now switch gears to carbapenems. See Table 3710. Carbapenems are beta-lactam antibiotics known for their exceptionally broad activity and activity against extended-spectrum beta-lactamers, abbreviated as ESBL, producing gram-negative organisms. Imipenem was the first drug in this new class. However, imipenem is susceptible to degradation by the enzyme dehydropeptidase 1 in the kidney, and therefore imipenem is now formulated with C-listatin, a dehydropeptidase inhibitor. The co-administration of both imipenem C-listatin, in a 1:1 ratio, increases the urinary concentration of imipenem, prolongs the imipenem serum half-life, and appears to prevent the nephrotoxicity induced by high doses of imipenem. C-listatin itself has no intrinsic antimicrobial activity. Meropenem is a newer carbapenem that is not susceptible to dehydropeptidase degradation. Meropenem is structurally different from imipenem in two ways. The carbapenem ring structure of meropenem includes an additional beta-methyl group in the C1 position, providing stability against the human renal tubular enzyme dehydropeptidase, and a long, substituted pyrrolidine side chain present in the C2 position allows greater activity against intracellular target sites in organisms such as Pseudomonas aeruginosa. Meropenem was approved by the FDA for use in children older than 3 months on the basis of extensive pediatric investigations across a wide range of infections, including meningitis and complicated abdominal infections. Meropenem is being increasingly studied in neonates for the treatment of complicated intra-abdominal infections and infections caused by Pseudomonas or extended-spectrum beta-lactamers producing bacterial infections. The newest carbapenems, ertapenem and doripenem, have yet to be studied in young infants. We will now discuss antimicrobial activity of carbapenems. Imipenem and meropenem have an exceptionally broad spectrum of activity. The bacterial species considered resistant to these drugs are MRSA, methicillin-resistant Staphylococcus epidermidis, Stenotrophomonas multifilia, Burkholderia cepacia, and Enterococcus fiscium. These drugs maintain activity against ESBL-producing organisms. Carbapenems produce in vitro MIC90 values of less than or equal to 1 microgram against the most commonly isolated species of gram-positive and enteric gram-negative aerobic bacteria, including Group B streptococci, penicillin-susceptible and penicillin-resistant Streptococcus pneumoniae, MSSA, Listeria monocytogenes, Citrobacter freundii, Escherichia coli, Haemophilus influenza, Klebsiella, Proteus, Serratia, and Azinetobacter species. The MIC90 values are typically less than 2 micrograms per milliliter for anaerobic bacteria. Pseudomonas aeruginosa has an MIC50 and MIC90 of 1 and greater than 8 for imipenem C-listatin and of 0.5 and 16 for meropenem, respectively. Meropenem is consistently more active against Pseudomonas aeruginosa than imipenem. Synergistic interactions between carbapenems and aminoglycosides can be demonstrated in vitro against Pseudomonas aeruginosa and Staphylococcus aureus isolates. Antagonistic interactions have been observed when imipenem is combined with other beta-lactams, probably as a result of chromosomal beta-lactamase induction by imipenem. Carbapenem's unusually broad antibacterial spectrum is related to its ability to penetrate efficiently the outer membrane of gram-negative bacteria, its high binding affinity for penicillin binding protein 2, and its resistance to hydrolysis by both plasmid and chromosomally mediated beta-lactamases. Some beta-lactamases produced by Stenotrophomonas multifilia, Aeromonas hydrophila, and Bacteroides fragilis, however, are capable of hydrolyzing imipenem and meropenem. Emergence of carbapenem-resistant strains during therapy with this drug is rare, except in the case of Pseudomonas aeruginosa, in which resistance occurs in as many as 17% of isolates. We will now discuss pharmacokinetic data of carbapenems. Let's begin with imipenem C-listatin, Table 3711. For both imipenem and C-listatin, serum concentration is directly proportional to the administered dose. Higher serum concentrations are achieved with C-listatin than with identical doses of imipenem. Imipenem, when co-administered with C-listatin, is eliminated as active drug through the kidneys. C-listatin is excreted primarily unchanged in the urine, but about 12% of the drug appears as the metabolite N-acetyl C-listatin. In neonatal studies, the IV administration of 10, 15, 20, and 25 mg per kilogram doses of both drugs results in mean peak imipenem concentrations of 11, 21, 30, and 55 micrograms per milliliter, respectively, compared with mean peak C-listatin values of 28, 37, 57, and 69 micrograms per milliliter, respectively. After 3 to 4 days of treatment with 20 mg per kilogram IV doses of imipenem C-listatin every 12 hours, peak serum concentrations are 35 and 86 micrograms per milliliter for imipenem and C-listatin, respectively. The mean serum half-life of imipenem is about 2 hours, whereas that of C-listatin is 5 to 6.4 hours. The half-life for both drugs is inversely related to birth weight and gestational age and is considerably longer than the 1-hour half-life reported for both drugs in older infants and in healthy adult volunteers. During the neonatal period, plasma clearance of C-listatin is only about 25% of that of imipenem. Although both imipenem and C-listatin penetrate well into the CSF in the presence of meningeal inflammation, 16 data derived from neonatal studies are scant. In one newborn who received a 15 mg per kilogram IV dose, concentrations of 1.1 and 0.8 microgram per milliliter were noted for imipenem and C-listatin, respectively, at 1.5 hours after injection. In a second neonate who received a 25 mg per kilogram dose, CSF values of 5.6 and 1.8 micrograms per milliliter were found for imipenem and C-listatin, respectively. Next we will focus on meropenem. See Table 3711. Meropenem was approved by the FDA for use in children older than 3 months on the basis of extensive pediatric investigations across a wide range of infections, including meningitis and complicated abdominal infections. Meropenem exhibits dose-proportional linear PK properties with dosages of meropenem from 10 to 40 mg per kilogram. A large PK and safety study of meropenem in 200 infants with a mean gestational age of 28 weeks, range 23 to 40 weeks, and a mean of 21 days of age, range 1 to 92 days, confirmed prior associations of meropenem clearance with serum creatinine and postmenstrual age. Half-life becomes shorter with advancing gestational age and postnatal age, whereas the volume of distribution remains relatively constant. In the first 2 weeks of life, the PK of meropenem was consistent with smaller meropenem PK studies. Preterm, less than 32 weeks gestational age, infants had a longer half-life of 3.8 hours, larger volume of distribution, 0.49 to 0.74 liter per kilogram, and slower clearance, that is 0.089 liter per hour per kilogram compared with more mature, that is equal to or greater than 32 weeks gestational age, infants who had a half-life of 2.7 hours, volume of distribution of 0.46 liter per kilogram, and clearance of 0.135 liter per hour per kilogram. Beyond the first 2 weeks of life, the more premature infants, that is less than 32 weeks gestational age, show improved clearance and shorter half-life, but they continued to differ from the more mature, is greater than or equal to 32-week gestational age, infants, clearance of 0.122 compared with 0.202 liter per hour per kilogram and half-life of 2.68 hours compared with 1.58 hours. The half-life decreases to 1.6 hours at 2 to 5 months of age as renal maturation occurs. We will now focus on the safety of carbapenems. Both imipenem C. Listatin and meropenem appear to be well tolerated when administered intravenously to newborns. In a review of studies conducted worldwide, including thousands of patients, most of whom were adults, it was observed that the nature and frequency of side effects were similar to those of other beta-lactam antibiotics. These adverse effects consisted mainly of nausea, vomiting, diarrhea, thrombophlebitis, thrombocytosis, eosinophilia, and elevation of hepatic enzyme concentrations. Colonization by Candida or imipenem-resistant bacteria occurred in about 16% of patients, and secondary superinfection was noted in about 6%. Alterations of bowel flora in children given imipenem C. Listatin have been minimal in the few patients studied in detail. A worrisome report suggests that imipenem treatment in infants with bacterial meningitis was possibly associated with drug-related seizure activity. In infants with bacterial meningitis, seizures developed in 7 of 21 infants, that is 33%, aged 3 to 48 months, after imipenem therapy. In this study, CSF imipenem and cilastatin peak concentrations ranged from 1.4 to 10 micrograms per milliliter and 0.8 to 7.2 micrograms per milliliter, respectively. It is believed that interference of beta-lactam antibiotics with the inhibitory effects of the neurotransmitter gamma-aminobutyric acid, abbreviated as GABA, can result in epileptiform bursts. In mice, imipenem has been shown to induce seizure activity at serum concentrations 2 to 3 times lower than those of penicillin and sfotaxime. Meropenem has less affinity than imipenem for the GABA receptor and consequently has demonstrated a lower propensity to cause seizures in animal models. In infants and children with meningitis, treatment with meropenem was well tolerated, and no drug-related seizure activity was observed. In a 200-patient PK trial of preterm and term infants younger than 3 months, meropenem was well tolerated, with no adverse events that were probably or definitely attributed to meropenem. The most commonly reported adverse events were sepsis, that is 6%, seizures, that is 5%, elevated conjugated bilirubin, that is 5%, and hyperkalemia, that is 5%. Adverse events associated with carbapenem exposure were recently evaluated in a retrospective study of 5,566 hospitalized infants with a mean gestational age of 29 weeks exposed to meropenem, that is 58.5%, imipenem C. Listatin, that is 37.5%, or both, that is 4%. Infants exposed to meropenem had fewer seizures and death, but a higher incidence of laboratory adverse events, elevated creatinine or liver enzymes, compared with infants exposed to imipenem C-Listatin. This retrospective study was not able to control for carbapenem indication or severity of illness. Although this association does not confer causality, laboratory monitoring is reasonable during exposure to carbapenems. And now we will focus on PK/PD and clinical implications for dosing. See Table 3711. Imipenem C-Listatin and meropenem are not recommended for routine use in the treatment of suspected or proven neonatal infections, with rare exceptions. Both agents should be primarily reserved to treat infections caused by multi-drug-resistant microorganisms or serious abdominal infections. Data in 25 neonates with proven bacterial infections suggest that single drug therapy with imipenem C-Listatin, using a 25 mg per kilogram dose given 2 to 4 times daily, is both efficacious and safe. Because newborns have lower renal clearance capability and somewhat greater blood-brain permeability than those in older infants and children, high concentrations of imipenem C-Listatin could be achieved in the CSF of neonates, especially those with bacterial meningitis, potentially resulting in drug-related seizure activity. Meropenem also appears to be safe and effective for treatment of neonatal infections. Because meropenem is more active against Pseudomonas aeruginosa, not metabolized in the kidney, and has not been linked to the potential induction of seizures, we believe that if a carbapenem is selected for therapy in a newborn, meropenem should be the agent of choice. Meropenem, like other beta-lactam antibiotics, exhibits time-dependent killing, so the goal of therapy is to keep meropenem serum concentrations above the MIC for at least 40% of the dosing interval for immunocompetent patients. Some authors have recommended higher T greater than MIC intervals in immunocompromised patients and particularly those with Pseudomonas infections, resulting from the higher MIC 50 of 4 and MIC 90 of 32. The meropenem dose-exposure relationship has been evaluated using Monte Carlo simulation and population PK models. Monte Carlo simulation of PK/PD relationships using the population PK model derived from the largest dataset determined the following dosing scheme. 1. 20 mg per kilogram every 12 hours if less than 32 weeks gestational age, postnatal age less than 14 days. 2. 20 mg per kilogram every 8 hours if less than 32 weeks gestational age, postnatal age greater than or equal to 14 days. 3. 20 mg per kilogram every 8 hours if greater than or equal to 32 weeks gestational age, postnatal age less than 14 days. And 4. 30 mg per kilogram every 8 hours if greater than or equal to 32 weeks gestational age, postnatal age greater than or equal to 14 days. Using these dosing guidelines, greater than 90% of infants will have simulated meropenem concentrations greater than 4 micrograms per milliliter for 50% of the dosing interval and greater than 2 micrograms per milliliter for 75% of the dosing interval. Neonatal Intensive Care Unit, NICU, specific sensitivities for nosocomial pathogens must be taken into account when considering appropriate exposure. Higher dosage and longer infusion times may need to be considered for the treatment of meningitis and more resistant organisms, such as Pseudomonas aeruginosa with MIC 4 to 8 micrograms per milliliter. We will now zero in on metronidazole. Metronidazole is a synthetic, trichomoniacidal and bactericidal agent, 1-beta-hydroxyethyl-2-methyl-5-nitroimidazole that is produced in an oral and IV formulation. Metronidazole is approved by the FDA for the treatment of adults with serious infections caused by susceptible anaerobic bacteria, but is not approved for use in children. In young infants, the IV formulation is used off-label to treat complicated intra-abdominal infections, such as necrotizing enterocolitis and, in rare cases, anaerobic bacteremia. Clinical pharmacology of metronidazole is not well characterized in either premature or term neonates or young infants. Metronidazole distributes in total body water, to the CSF, saliva, and into erythrocytes and is minimally protein-bound, that is 20%. Metronidazole is extensively metabolized by the liver, yet the specific biotransformation pathways, particularly in neonates, are not well described. Metronidazole and metabolites are primarily eliminated in urine. In adults, single-dose PK plasma clearance is reduced in patients with liver dysfunction, but not renal dysfunction. Hepatic transformation seems to be reduced in neonates. Therefore, the kidneys may be responsible for elimination of higher fraction of unchanged metronidazole. We will now discuss pharmacokinetics of metronidazole. Limited PK data of metronidazole in neonates have led to highly variable dosing recommendations. Recently, 3 population PK studies of metronidazole in a total of 88, mostly preterm, less than 32-week gestational age infants consistently demonstrate that clearance improves with advancing postnatal age and postmenstrual age, whereas volume of distribution is primarily affected by weight. Only 2 infants, that is 2%, were 32 to 37 weeks gestational age at birth. Infants enrolled in these 3 PK studies shared many characteristics, including a median gestational age of 25 to 27 weeks and postmenstrual age of 30 to 32 weeks. They differed in the median postnatal age of infants, ranging from 12 days to 27 days to 41 days. Metronidazole dosing varied. 2 studies had infants treated with standard of care, and 1 study had protocol-derived dosing adjusted for postmenstrual age and postnatal age. All studies developed 1-compartment population PK models, with clearance associated with weight and postmenstrual age and volume associated with weight. Bayesian estimates were similar between studies. Clearance estimates for a 30-week postmenstrual age infant were 0.029, 0.025, and 0.038 liter per hour per kilogram, respectively, whereas volume of distribution estimates were 0.71, 0.735, and 0.93 liter per kilogram, respectively. Sayar and co-workers predicted a 5-fold increase in clearance from a postmenstrual age of 25 to 32 weeks and a concomitant 2-fold reduction in half-life, that is 40 to 19 hours. Clearance also improves with PNA, from an estimate of 0.027 liter per hour per kilogram at less than 14 days of age to 0.042 liter per hour per kilogram at greater than or equal to 14 days of age, whereas the half-life shortens from 24 hours, that is less than 14 days of age, to 15 hours beyond 14 days of age. The most recent study showed somewhat larger volume of distribution and clearance, potentially resulting from slightly lower median gestational age, older postnatal age, relatively small sample size in all studies, and variation in concomitant medications, pathophysiology, and drug metabolizing enzymes. We will now discuss the safety of metronidazole. The safety and efficacy of metronidazole in pediatrics has not been clearly established, especially in the treatment of complicated intra-abdominal infections. It has been well tolerated in small PK studies. Metronidazole has been shown to be carcinogenic in mice and rats. Therefore, unnecessary use of the drug should be avoided. Its use should be reserved for the serious conditions caused by organisms known to be susceptible. Carcinogenic risk has not been established in humans. Adult patients taking metronidazole have experienced seizures and peripheral neuropathy. Therefore, it is used very cautiously in patients with CNS disease. Metronidazole can have significant drug interactions with concomitant medications that affect the P450 cytochrome oxidase systems, such as phenobarbital, phenytoin, and warfarin. Additional adverse reactions typically refer to the gastrointestinal systems, particularly nausea and reversible neutropenia, and rarely thrombocytopenia. Dose adjustments are indicated in adults with severe hepatic dysfunction. We will now discuss PK/PD and clinical implications for dosing. In the absence of well-defined PD targets, recent studies have aimed to have the trough, C minimum, at steady state exceed the MIC, 6 to 8 micrograms per milliliter, of the organisms responsible for intra-abdominal infections. The Clinical and Laboratory Standards Institute recommended that the MIC susceptibility breakpoint of metronidazole for anaerobic organisms is 8 micrograms per milliliter. However, most anaerobic bacteria have an MIC of less than 2 micrograms per milliliter. Loading doses are indicated, given the long half-life and wide distribution. Metronidazole postmenstrual age-based dosing that accounts for apparent developmental differences in clearance is required to achieve the surrogate PD target of C minimum greater than MIC of either 6 micrograms per milliliter or 8 micrograms per milliliter and is superior to commonly used dosing references in clinical pediatrics. Dosing recommendations based on these population PK models and simulation to target C minimum greater than MIC all indicate a loading dose of 15 mg per kilogram, followed by variable maintenance dosing based on postmenstrual age as follows: dosing regimen 1275 for infants 7.5 mg per kilogram, every 12 hours for postmenstrual age less than 34 weeks, every 8 hours for postmenstrual age 34 to 40 weeks, every 6 hours for postmenstrual age greater than 40 weeks, and consider every 24 hours if within the first 14 days of life, or dosing regimen 2274 compared with 7.5 mg per kilogram, every 24 hours for postmenstrual age 24 to 25 weeks, 10 mg per kilogram every 24 hours for postmenstrual age 26 to 27 weeks, 7.5 mg per kilogram every 12 hours for postmenstrual age 28 to 33 weeks, and 10 mg per kilogram every 12 hours for postmenstrual age 24 to 27 weeks. Because the surrogate PD target is to maintain the C minimum greater than MIC, we prefer more frequent interval dosing with advancing postmenstrual age. More prospective evaluations of dose-exposure relationships, safety, and efficacy are needed. We will now focus on antiviral medications. Viral infections in the neonate are fortunately rare yet associated with significant morbidity and mortality. Viral therapy is available for the treatment of human immunodeficiency virus, abbreviated as HIV, herpes simplex virus, abbreviated as HSV, CMV, and varicella zoster virus, abbreviated as VZV. The pharmacology of medications used to treat or prevent HIV infections is discussed in Chapter 22. The pharmacology of acyclovir, ganciclovir, valganciclovir, and oseltamivir will be reviewed here. We will now discuss acyclovir for the treatment of herpes simplex virus. Acyclovir is a nucleoside analog used with HSV and VSV. It is the most common antiviral drug used for the management of HSV. We will now discuss pharmacokinetics of acyclovir. The PK of acyclovir in neonates is limited. In a very small PK study of 3 infants, that is less than 60 days of age, receiving oral acyclovir, dosed at 300 mg per meter squared, for 3 doses showed that the maximum concentration, 1.88 micrograms per milliliter, was higher than observed in adults receiving a larger dose, that is 400 mg per meter squared, and suggests adequate bioavailability. The elimination half-life in infants was longer than adults. IV doses of 2.5 to 15 mg per kilogram are associated with steady-state acyclovir concentrations that range from 6.7 to 20.6 micrograms per milliliter. Acyclovir is widely distributed and achieves high concentrations in the kidneys, lung, liver, heart, and skin vesicles. CSF concentrations are about 50% of those in the plasma. Most of the drug is excreted unchanged in the urine through glomerular filtration and tubular secretion. Acyclovir has a 2 to 3 hour half-life in children and adults. Neonates with normal creatinine clearance have a prolonged half-life of 3 to 4 hours in small studies that do not include the gestational age of infants, and up to 5 hours in a small study that included premature infants, but had a median gestational age of 38 weeks. Elimination is prolonged in patients with renal dysfunction. The PK of the currently recommended neonatal dosing schedule, 20 mg per kilogram per dose every 8 hours, has not been described. Prematurity is a risk factor for mortality in infants with HSV infections. Recently, the PK of acyclovir has been described in 28 preterm and term infants, median range 31, that is 23 to 40 weeks gestational age, and 3.5, that is 0 to 30 days postnatal age. The acyclovir population PK model predicted a greater than 5-fold increase in clearance from 23 to 40 weeks gestational age. Clearance was associated with postmenstrual age. Volume of distribution was larger, that is 3 liters per kilogram, than previously described in infants and adults, likely relating to the increased extracellular water in preterm and very young infants. We will now discuss the safety of acyclovir. Acyclovir is generally a well-tolerated and safe drug. High doses of IV acyclovir, as is used in neonates, have been associated with neutropenia. Less common adverse effects include rash, nausea, headache, hematuria, and hypotension. Renal dysfunction can result from obstructive nephropathy caused by the formation of acyclovir crystals precipitating in renal tubules. Neurotoxicity has been reported in subjects with compromised renal function who attain high acyclovir serum concentrations. In the most recent PK trial of 28 neonates, that is 23 to 41 weeks of gestational age, acyclovir was well tolerated, with only one adverse event attributed to acyclovir, worsening serum creatinine, and no episodes of neutropenia were reported. The study of oral acyclovir suppressive therapy, 300 mg per meter squared per dose bovine serum albumin, abbreviated as BSA, found neutropenia in 20% to 25% of infants compared with 5% to 7% in the placebo arm. These episodes of neutropenia resolved and were not associated with complications. We will now discuss PK/PD and clinical implications for dosing. Mortality was reduced in infants with neonatal HSV disease who received a high dose, 60 mg per kilogram per day, compared with infants receiving 45 mg per kilogram per day, given every 8 hours, for 21 days. The survival rate was similar for infants with CNS disease. Neutropenia was the most significant adverse event reported. However, there were no reported adverse sequelae, and the neutropenia was transient. The dosing interval may need to be increased in premature infants who are expected to have decreased creatinine clearance. HSV isolates typically have an acyclovir half-maximal inhibitory concentration, abbreviated as IC50, of less than 1 microgram per milliliter. It is reasonable to dose acyclovir to maintain acyclovir concentrations greater than 1 microgram per milliliter and greater than 3 micrograms per milliliter if attempting to exceed 1 microgram per milliliter in the CSF. In infants with disseminated or CNS infections, acyclovir should be administered for 21 days and until CSF testing for HSV is negative. Most formularies recommend 20 mg per kilogram dosing every 8 hours, which results in improved survival in efficacy trials. The population PK model of acyclovir in very young preterm and term infants was used to derive postmenstrual age-based dosing to achieve the theoretical PD target of steady-state concentration exceeding 3 micrograms per milliliter for at least 50% of dosing interval. According to simulated dose-related exposures, the most premature infants with postmenstrual age less than 30 weeks should receive 20 mg per kilogram every 12 hours, whereas the more mature 30 to 36-week postmenstrual age infants can receive acyclovir 20 mg per kilogram every 8 hours, and the most mature infants with a postmenstrual age of 36 to 41 weeks should receive acyclovir 20 mg per kilogram every 6 hours. Infants with recurrent skin lesions are at higher risk of neurodevelopmental sequelae. Oral acyclovir has recently been shown to reduce the recurrence risk and improve neurodevelopmental outcomes. Randomized, controlled trials show long-term benefit after 6 months of suppressive therapy, 300 mg per meter squared per dose BSA 3 times per day. Another, uncontrolled study of 16 infants also showed improved neurodevelopmental outcomes after 2 years of treatment with higher dose oral acyclovir suppression. In this study, dosing began at 400 mg twice per day, approximately 1200 to 1600 mg per meter squared BSA, and then was adjusted based on acyclovir concentrations to maintain a minimum concentration greater than 3 micrograms per milliliter. Approximate doses for term infants by age were 400 mg for age 1 to 5 months, 600 mg for age 5 to 9 months, 800 mg for age 9 to 15 months, and 1000 mg for age 15 to 24 months, maximum dosage, 1200 mg. Acyclovir was also well tolerated in both studies. However, there was a trend toward more neutropenia in the acyclovir-treated infants compared with infants receiving placebo. We will now discuss ganciclovir and valganciclovir for treatment of congenital cytomegalovirus with central nervous system sequelae. Let's begin with antimicrobial activity. Ganciclovir is approved for the prevention or treatment of CMV virus in adults. Ganciclovir is a synthetic guanine derivative that specifically inhibits viral DNA synthesis by inhibiting viral DNA polymerase, resulting in termination of viral DNA elongation. Ganciclovir is active against CMV and, to a lesser extent, HSV. We will now discuss the pharmacokinetic data of ganciclovir. Ganciclovir is phosphorylated by viral protein kinases to ganciclovir triphosphate, the active metabolite that persists for days in CMV-infected cells. To a lesser degree, normal, uninfected cells can generate monophosphorylated ganciclovir, thus possibly explaining its cytotoxic side effects. Ganciclovir exhibits low protein binding. CSF penetration is 24% to 70% of the respective plasma concentrations. Renal excretion of unchanged drug occurs by glomerular filtration and active tubular secretion. The half-life in adults is 3.5 hours. Dose adjustment is advised in renal insufficiency. Ganciclovir exhibits linear kinetics with dose escalation. Single dose, IV ganciclovir PK has been evaluated in 27 neonates younger than 50 days. After a 4 or 6 mg per kilogram IV dose, the peak concentration was 5.5 and 7 micrograms per milliliter respectively. Systemic clearance was 3.14 and 3.56 milliliters per kilogram per minute, respectively, and the half-life was 2.4 hours for both doses. Clearance was less than reported in children, but the half-life was similar. Neonates had high interpatient variability. Population PK analysis of these newborns showed that ganciclovir clearance was associated with body weight and creatinine clearance. The mean population clearance was 0.4 liter per hour, and the volume of distribution was 1.73 liters. A recent population PK analysis in young infants receiving IV ganciclovir or oral valganciclovir showed similar results, namely, a mean clearance of 0.32 liter per hour and volume of distribution of 1.78 liters. Because ganciclovir is eliminated through the kidney, ganciclovir clearance accelerates with postnatal age such that the AUC at the end of 6 weeks of therapy is expected to be less than the AUC during the first week. Extremely preterm infants with decreased renal elimination pathways would be expected to have delayed clearance. Valganciclovir is the oral prodrug of ganciclovir. Valganciclovir is rapidly hydrolyzed to ganciclovir and has similar indications to ganciclovir when oral therapy is acceptable. The bioavailability of valganciclovir exceeds 60% and is enhanced by concomitant administration of food. Typically, the AUC of ganciclovir after oral administration of valganciclovir is 33% to 50% of that which would have been achieved with IV ganciclovir. Dosing is modified for age and renal function. PK studies of valganciclovir show adequate bioavailability. A recent study of 24 neonates reported that 16 mg per kilogram per dose oral valganciclovir administered twice daily achieves similar exposure as the 6 mg per kilogram per dose IV ganciclovir regimen and the target AUC 0 to 12 of 27 mg per hour per liter. The median bioavailability was 41%. Ganciclovir clearance doubled over the 6 weeks of therapy in young infants. However, Infants receiving valganciclovir had more consistent AUC over 6 weeks of therapy compared with those receiving IV ganciclovir, likely because the valganciclovir bioavailability increased by 32% over the course of treatment. This dose was consistent with the 15 mg per kilogram dose recommended in smaller studies. Viral load decreased in all infants. Median 0.7 log viral DNA copies per milliliter. However, this decrease in viral load was not associated with Cmax or AUC. Neutropenia remained the most significant adverse effect. We will now discuss the safety of ganciclovir. Ganciclovir label contains a black box warning for risk of granulocytopenia, anemia, and thrombocytopenia, and the drug should be avoided in patients with cytopenia or history of cytopenia. Dose reduction is also indicated in renal impairment. Dose-related neutropenia is the most common hematologic abnormality with both ganciclovir and valganciclovir and occurs in approximately 40% of patients and is reversible. Less frequent reported adverse events include fever, anorexia, vomiting, rash, elevated hepatic enzymes, and seizures. Ganciclovir has important drug interactions. It should not be combined with imipenem-cilastatin because of concern for seizures, and caution is required when combined with other nucleoside analogues, cyclosporine, and amphotericin B because of potential additive toxicity. In a placebo-controlled trial of ganciclovir in infants, neutropenia occurred in 63% of infants receiving ganciclovir compared with 21% in the control infants. Adverse events in infants participating in a Phase 2 study of 8 versus 12 mg per kilogram per day included retinal detachment, neutropenia, and a moderate increase in creatinine and liver enzymes. It remains unclear if these adverse events were attributed to either progression of CMV disease, adverse drug effect, or both. In valganciclovir trial for congenital CMV, neutropenia remained the most significant adverse effect, and grade 3 to 4 neutropenia occurred in 38% of infants and was correlated with a higher Cmax and a higher AUC. Periodic monitoring of blood counts, serum creatinine, and liver function is recommended. Hematologic manifestations are transient. PK/PD and clinical indication of ganciclovir. Ganciclovir is licensed outside the newborn period for the treatment of CMV retinitis in immunocompromised patients and the prevention of CMV disease in transplant recipients. The relationship between ganciclovir exposure and clinical response has not been established. In vitro studies have shown that median inhibitory concentrations ranged from 0.02 to 3.48 micrograms per milliliter. A placebo-controlled trial in neonates with CSF manifestations of CMV demonstrated a reduction of hearing deterioration in infants receiving IV ganciclovir 12 mg per kilogram per day, 6 mg per kilogram, dose administered every 12 hours, for 6 weeks. Safety and efficacy of ganciclovir have not been established for congenital CMV disease without CNS manifestations. However, There was a high incidence of neutropenia in infants receiving ganciclovir compared with placebo, and dose modification was common. Controversy exists regarding the potential benefits of prolonged ganciclovir therapy to neonates, given the prolonged duration of IV access required and risk of adverse drug events. Oral valganciclovir, an oral prodrug of ganciclovir, has been shown to have adequate bioavailability in neonates to achieve therapeutic ganciclovir plasma concentrations. We will now progress to oseltamivir for the treatment of influenza. The Centers for Disease Control and Prevention, CDC, estimates that each year more than 200,000 hospitalizations and 36,000 deaths are attributable to influenza in the United States. In the 2003 to 2004 influenza seasons, the CDC reported 153 influenza-related deaths in children with a median age of 3 years. The highest mortality rate in children was among children younger than 6 months. In addition to mortality, children are known to have high rates of hospitalization and can suffer chronic neurologic or neuromuscular conditions. Neonates and young infants are particularly vulnerable because vaccination is ineffective and antiviral treatment was previously not recommended in infancy. Immunization of pregnant mothers and all adults who contact infants is the best means of preventing influenza infection in infants. Neuraminidase inhibitors are effective in the treatment of sensitive influenza species in infants older than 1 year if initiated within 48 hours of symptoms. We will now discuss antimicrobial activity of neuraminidase inhibitors. Neuraminidase inhibitors inhibit influenza virus type A and type B by binding to a highly conserved region of the neuraminidase protein on the viral surface, to inhibit viral penetration, replication, and disease. The only neuraminidase inhibitor available for oral treatment in children younger than 6 years is oseltamivir. Oseltamivir has been shown to be safe and effective at reducing both the duration and severity of influenza symptoms in adult and pediatric patients older than 1 year. 1. However, neuraminidase inhibitor resistance among circulating influenza strains is increasing. We will now focus on pharmacokinetic data of oseltamivir. Oseltamivir PK has been established in adults and children older than 1 year. Oseltamivir has excellent bioavailability after oral dosing and is extensively converted by hepatic esterase to oseltamivir carboxylate. In adults, at least 75% of an oral dose reaches the systemic circulation as the active form oseltamivir carboxylate. This active form is then renally excreted. Oseltamivir carboxylate is not a substrate for, nor an inhibitor of, cytochrome P450 enzymes. PK analysis in children revealed that younger patients cleared both the prodrug and the active metabolite faster than adult patients, resulting in a lower exposure for a given milligrams per kilogram dose. In animals, oseltamivir carboxylate accumulates in the lung, middle ear, and nasal mucosa at concentrations exceeding those measured in the blood. The PK of oseltamivir in young infants has only recently been reported. Neonates are expected to have unique and variable PK properties, because they typically exhibit altered renal clearances of drug and metabolite, variation in oral bioavailability, and large variability in the expression of human carboxylesterase. As infants mature, human carboxylesterase 1 increases expression and exhibits decreased intersubject variability. What is most striking in these studies is the large variation in oseltamivir and oseltamivir carboxylate exposure. Fortunately, preterm and term neonates are able to generate active oseltamivir carboxylate at plasma concentrations that are associated with antiviral efficacy. This extreme variation in exposures likely reflects differences in bioavailability, carboxylesterase expression, efflux of drug out of the liver and renal elimination, disease state, and enteral feeding frequency. The first PK reports described preterm and term infants in the NICU, who were treated with oseltamivir for post-exposure prophylaxis, or a few were treated for influenza infections. These studies all show large between-subject variability, delayed gastric absorption, effective albeit slower conversion to oseltamivir carboxylate, slower metabolite appearance, and accumulation of oseltamivir carboxylate over time. However, the observed oseltamivir concentrations reported as AUC 0 to 12 are relatively consistent, 2,900 to 6,700 micrograms per hour per liter, for preterm neonates with PMA of less than 37 weeks receiving 1 mg per kilogram twice daily, and in older subjects receiving 2 to 3 mg per kilogram twice daily. A larger PK of oseltamivir in 87 infants younger than 2 years was recently published. This study is unique in that all infants had confirmed influenza and that the investigators set the desired oseltamivir carboxylate AUC 0 to 12 target to be 3,800 nanograms per hour per milliliter. Acceptable range 2,660 nanograms per hour per milliliter to 7,700 nanograms per hour per milliliter. This target was based on effective adult AUC targets, and the lower limit was set to minimize the development of antiviral resistance previously observed in 1 to 2-year-old infants who received 2 mg per kilogram dosing and had an AUC 0 to 12 of 2,880 nanograms per hour per milliliter. Dose adjustment in study protocol occurred if the first 9 subjects did not achieve this target. Infants 0 to 8 months of age receiving twice-daily dosing of 3 mg per kilogram had drug exposures within the target range. Older 9 to 11-month-old infants needed a higher dose of 3.5 mg per kilogram to produce adequate drug exposure targets. For 11 to 24-month-old infants, standard non-weight-based 30 mg dosing, as recommended in clinical guidance, did not consistently produce target drug exposures, but the increased weight-based dosing of 3.5 mg per kilogram was able to achieve the target. The youngest infants, that is less than 3 months of age, showed the highest degree of variation. They had a delay in the formation of the metabolite. However, the overall oseltamivir carboxylate exposures were similar. We will now discuss the safety of oseltamivir. Oseltamivir has been well tolerated in adult and pediatric clinical trials. The most common reported adverse events are related to gastrointestinal disturbances, particularly nausea and vomiting. Initially, there was concern about the safety of oseltamivir in infants younger than 1 year. Roche Laboratory issued an alert in 2003 that oseltamivir should not be used in infants younger than 1 year because an animal study revealed CNS toxicity and death in some very young rats who were exposed to excessively high doses of oseltamivir, dosed at 500–1000 milligrams per kilogram. There was great uncertainty in extrapolating juvenile animal data to human infants. Early retrospective case series in more than 300 oseltamivir-exposed infants revealed no serious complications or neurotoxicity. In response to the 2009 H1N1 flu pandemic, the FDA issued an emergency use authorization for oseltamivir in young infants. Subsequently, safety data have been collected in hospitalized neonates and young infants who were receiving oseltamivir for treatment or prophylaxis. Oseltamivir was well tolerated in young infants, with rare association with gastrointestinal symptoms and no reports of encephalopathy. In one retrospective study of infants with confirmed influenza, vomiting was noted to be present upon admission before receiving oseltamivir and improved with treatment. In one study, 3 infants presented with seizures as a symptom of illness before the receipt of oseltamivir, and seizures did not recur on therapy. No neurologic side effects were seen. A few infants exhibited gastrointestinal symptoms, vomiting and diarrhea, during their course of treatment, and causality to oseltamivir was unclear because symptoms were also attributed to concomitant antibiotics or associated viral gastroenteritis infections. Oseltamivir was well tolerated in the largest published study of oseltamivir in 87 infants younger than 2 years with confirmed influenza. No unexpected adverse drug events were reported. No infants had the drug discontinued because of tolerability issues, and no seizures were reported. Expected adverse events considered related to oseltamivir were rare and included emesis, N equals 5, 6%, and skin rash, N equals 2, 2.5%. One infant had a serious adverse event, cutaneous hypersensitivity reaction, that was considered related to oseltamivir. We will now discuss PK/PD and clinical implications for dosing. Infants are at high risk for influenza-associated morbidity and mortality. In infants hospitalized with influenza, the possible benefit of therapy likely outweighs the risks. More PK studies are needed to better define the dose-exposure relationship in young infants. PK/PD studies are needed in young infants to best define exposure targets based on infant outcomes. At this time, twice-daily dosing recommendations based on the most thorough PK study are stratified by age: 1 mg per kilogram in preterm infants with PMA less than 37 weeks, 3 mg per kilogram dose in 0 to 8-month-old infants, 3.5 mg per kilogram dose in 9 to 11-month-old infants, and 3.5 mg per kilogram dose in 12 to 24-month-old infants. Some clinicians recommend 30 mg flat dosing for 12 to 24-month-old infants. A lower dose of 2 mg per kilogram has been advocated for young-term infants with severe pre-existing medical problems, prolonged newborn ICU hospitalizations, or infants on parenteral nutrition instead of enteral nutrition. We will now discuss antifungal therapy. In the extremely premature infant, invasive candidiasis is common, often fatal, and frequently results in severe neurodevelopmental impairment. The therapeutic agents of choice in the nursery have been fluconazole and amphotericin products. Echinocandins are emerging as first-line therapy in older patients, and their PK, safety, and efficacy are under investigation in young infants. A hallmark of neonatal candidiasis is CNS infection. The incidence of CNS involvement is higher in the young infant than older patients, and invasive candidiasis, isolation of candida from normally sterile body fluids, from any source has been associated with neurodevelopmental impairment. The diagnosis of CNS disease is very difficult. Thus CNS involvement should be presumed in the young, premature infant. We will now progress to meningoencephalitis. Central nervous system infection is not limited to meningitis. CNS infection with candida is more accurately described as meningoencephalitis. Because the infection is based in brain tissue, it is likely that brain tissue penetration of antifungal drugs is more important to management of CNS infection with candida rather than a strict assessment of penetration into the CSF. CSF concentrations do not reliably predict outcome. This helps explain why amphotericin B deoxycholate and the echinocandins are likely to be effective in treating invasive candidiasis in young infants, provided that the levels of these products in the blood are sufficiently high to drive the product into the brain. We will now switch gears to amphotericin B. Amphotericin B, approved in 1958, is so named because it is amphoteric, forming soluble salts in both acidic and basic environments. However, because of its insolubility in water, amphotericin B for clinical use is actually amphotericin B mixed with the detergent deoxycholate in a 3-to-7 mixture. Next, W will focus on antimicrobial activity of amphotericin B. Amphotericin products bind to ergosterol, the major sterol found in fungal cytoplasmic membranes. The lipophilic amphotericin B acts by preferential binding to fungal membrane ergosterols, creating transmembrane channels, which result in an increased permeability to monovalent cations. The fungicidal activity is believed to be due to a damaged barrier and subsequent cell death through leakage of essential nutrients from the fungal cell. Amphotericin B also has oxidant activity, which disrupts cellular metabolism, inhibits proton adenosine triphosphatase pumps, depletes cellular energy reserves, and promotes lipid peroxidation to result in an increase in membrane fragility and ionized calcium leakage. We will now discuss pharmacokinetic data. Amphotericin B is released from its carrier and is distributed very efficiently, that is greater than 90%, with lipoproteins. The antifungal drug is taken up preferentially by organs of the reticuloendothelial system and follows a three-compartment distribution model. There is an initial 24 to 48-hour half-life, reflecting uptake by host lipids, very slow release and excretion into urine and bile, and a subsequent terminal half-life of up to 15 days. In a small series, N equals 13, evaluating the PK of amphotericin B among premature infants, 27.4 plus/minus 5 weeks, 9 subjects showed elimination of amphotericin B at steady state, with an estimated elimination half-life of 14.8 hours. The rest of the infants, however, showed minimal drug elimination during the dosing interval, suggesting substantial drug accumulation and interindividual variability in a small series of premature infants born at 27.4 plus/minus 5 weeks gestational age, N equals 5. In one study of 5 premature infants and 5 older children, the VD was smaller and the elimination clearance more rapid than previously reported in adults. Serum levels were approximately half of those in adults with comparable doses, and interpatient variability was marked in the premature infants. We will now focus on the safety of amphotericin B. Tolerance to amphotericin B deoxycholate is limited by its acute and chronic toxicities, particularly in children and adults. In addition to fungal ergosterol, the drug also interacts with cholesterol in human cell membranes. This likely accounts for its toxicity. Amphotericin B also has a constrictive effect on renal arterioles, leading to a reduction in the glomerular filtration rate. Up to 80% of older patients receiving amphotericin B develop either infusion-related toxicity or nephrotoxicity. However, the product is likely better tolerated in young infants. Renal function usually returns to normal after cessation of amphotericin B, although permanent renal impairment is common after larger doses in older patients. Next we will look at PK/PD and clinical implication for experimental in vitro and in vivo studies support concentration-dependent killing with a prolonged post-antifungal effect, suggesting large daily doses will be most effective and that achieving optimal peak concentrations is important. Peak levels are achieved 1 hour after a 4-hour infusion and reach a plateau at the 3rd consecutive day of a constant dose. There is a relationship between total dose administered and tissue concentrations, suggesting a progressive accumulation with continued drug administration. However, there is no evidence of a clinical dose effect to support higher doses, above 1 mg per kilogram per day, of amphotericin B. CSF values are only 2% to 4% of serum concentrations and sometimes difficult to detect, yet a small case series completed in young infants suggests that the penetration of the product may be greater in this population. As the drug penetrates well into brain tissue, 1 mg per kilogram dosing should be sufficient for CNS infections, c. meningoencephalitis. We will now focus on amphotericin B lipid-associated formulations. In addition to conventional amphotericin B deoxycholate, 3 fundamentally different lipid-associated formulations have been developed that offer the advantage of an increased daily dose of the parent drug, better delivery to the primary reticuloendothelial organs, lungs, liver, or spleen, and reduced toxicity. Amphotericin B lipid complex, abbreviated as ABLC, amphotericin B colloidal dispersion, abbreviated as ABCD, and liposomal amphotericin B, abbreviated as L-amphotericin B. ABLC is a tightly packed, ribbon-like structure of a bilayered membrane formed by combining dimeristoyl phosphatidylcholine, dimeristoyl phosphatide L-glycerol, and amphotericin B in a ratio of 7:3:3. ABCD is composed of disc-like structures of cholesterol sulfate complexed with amphotericin B in an equimolar ratio. L-amphotericin B consists of small, uniformly sized unilamellar vesicles of a lipid bilayer of hydrogenated soy phosphatidylcholine disteroyl phosphatide L-glycerol cholesterol amphotericin B in the ratio 2:0.8 to 1:0.4. We will now focus on pharmacokinetic data of amphotericin B. Lipid formulations of amphotericin B generally have a slower onset of action and are less active than amphotericin B alone in time-kill studies, presumably because of the required dissociation of free amphotericin B from the lipid vehicle. It is postulated that activated monocytes, macrophages, take up drug-laden lipid formulations and transport them to the site of infection, where phospholipases release the free drug. The different PK and toxicities of the lipid formulations are reflected in the dosing recommendations. ABLC is recommended at 5 mg per kilogram per day, ABCD at 3 to 5 mg per kilogram per day, and L-amphotericin B at 1 to 5 mg per kilogram per day. However, most clinical data have been obtained with the use of these preparations at 5 mg per kilogram per day. The dosage of 5 mg per kilogram per day is especially pertinent to the young infant, given the frequency of CNS disease, c. meningoencephalitis. Animal studies suggest that on a similar dosing schedule, the lipid products are almost always not as potent as amphotericin B, but that the ability to safely administer higher daily doses of the parent drug improves their efficacy such that they compare favorably with the amphotericin B deoxycholate preparation with less toxicity. A multi-center maximum tolerated dose study of L-amphotericin B, using doses from 7.5 to 15 mg per kilogram per day, found a nonlinear plasma PK profile with a maximum concentration at 10 mg per kilogram per day and no demonstrable dose-limiting nephrotoxicity or infusion-related toxicity. Lipid formulations have the added benefit of increased tissue concentration compared with conventional amphotericin B, specifically in the liver, lungs, and spleen. However, it is not entirely clear whether these higher concentrations in tissue are truly available to the microphagy of infection. Liposomal amphotericin B has a comparatively higher peak plasma level and prolonged circulation in plasma, whereas ABCD has a lower plasma level than amphotericin B after infusion but a longer half-life and larger volume of distribution. The PK of amphotericin B lipid complex, abbreviated as ABLC, has been investigated in 28 neonates, median gestational age, 27 weeks, weight, 1 kg with range 0.48 to 4.9 kg with invasive candidiasis. Infants received IV ABLC at 2.5, N equals 15, or 5, N equals 13, milligrams per kilogram per day for a median of 21 days. Weight was the only factor that influenced clearance. The terminal half-life was estimated to be 395 hours. CSF concentrations in a limited number of samples were very low or undetectable. Dosing is therefore recommended at 2.5 and 5 mg per kilogram per day for treatment of invasive Candida infections in neonates, with higher dosing for any infant with suspected CNS involvement. High doses, that is 5 to 7 mg per kilogram per day, and early treatment have been associated with improved outcomes. We will now focus on the safety data of amphotericin B lipid formulations appear to stabilize amphotericin B in a self-associated state so that it is not available to interact with the cholesterol of human cellular membranes. Another theory for the decreased nephrotoxicity of lipid formulations is the preferential binding of its amphotericin B to serum high-density lipoproteins compared with amphotericin B's binding to low-density lipoproteins. The high-density lipoprotein-bound amphotericin B appears to be released to the kidney more slowly, or to a lesser degree. For infusion-related toxicity, there is a general agreement that L-amphotericin B has less toxicity than ABLC, whereas ABCD appears closer in toxicity to conventional amphotericin B. Liposomal amphotericin is generally well tolerated in very low body weight neonates. In a recent cohort of 71 infants, nephrotoxicity, defined as a hyperkalemia, elevated creatinine levels, or decreased urine output, occurred in 2.8% of infants who were receiving 3 to 5 mg per kilogram per day for an average of 14 days. A small case control study of ABLC in 35 very low body weight infants also concluded that treatment with ABLC for 2 weeks did not increase blood urea nitrogen or serum creatinine, nor decreased sodium or potassium. We will now progress to PK/PD and clinical implications for dosing of amphotericin B. Antifungal efficacy is dependent on the AUC 0 to 24. The key target organ is the brain, even if the lumbar puncture is normal. Killing of the organism in the brain depends not only on AUC 0 to 24, but also total AUC exposure during therapy. That is, CNS disease usually requires extended therapy. The typical duration of therapy is at least 21 days. We acknowledge that the optimal length of therapy is not known as of this writing. There are no data or consensus opinions among authorities indicating improved efficacy of any new amphotericin B lipid formulation over conventional amphotericin B, especially in neonates where renal toxicity is uncommon. The clearest indication for a lipid formulation over amphotericin B is to reduce nephrotoxicity. However, nephrotoxicity in the young infant is thought to be uncommon. In neonates, early administration of high dose, 5 to 7 mg per kilogram per day, liposomal amphotericin has been associated with improved outcomes in retrospective analysis. We will now switch gears to pyrimidine analogues, 5-fluorocytosine. 5-fluorocytosine, abbreviated as 5-FC, is a fluorinated analog of cytosine synthesized as a potential anti-tumor agent and initially approved for use in 1972. Unfortunately, most reports detail clinical failure with monotherapy for yeast infections. The antimycotic activity of the drug results from the rapid conversion of 5-fluorocytosine into 5-fluorouracil, abbreviated as 5-FU, within susceptible fungal cells. The two mechanisms of action of 5-fluorouracil are incorporation into fungal RNA in place of uridylic acid to inhibit fungal protein synthesis, and inhibition of thymidylate synthetase to inhibit fungal DNA synthesis. The latter appears to be the dominant mechanism. Clinical and microbiologic antifungal resistance to 5-fluorocytosine monotherapy appears to develop quickly. And now we will look at pharmacokinetic data of 5-fluorocytosine. Fungistatic 5-fluorocytosine is thought to enhance the antifungal activity of amphotericin B, especially in anatomic sites where amphotericin B penetration is often suboptimal, such as the CSF, heart valves, and the vitreal body. 5-fluorocytosine penetrates well into most body sites because it is small, highly water-soluble, and not bound by serum proteins to any great extent. In a study involving 33 neonates in the United Kingdom treated with IV or oral 5-fluorocytosine, who underwent therapeutic drug monitoring, drug concentrations were low, trough 40 micrograms per milliliter or peak greater than 80 micrograms per milliliter, in 38.9%, and potentially toxic, that is greater than 100 micrograms per milliliter in 9.9%. We will now discuss the safety of 5-fluorocytosine. The mechanism of toxicity for 5-fluorocytosine is unknown, but toxicity is common and substantial. 5-fluorocytosine may exacerbate myelosuppression. Toxic levels may develop when in combination with amphotericin B because of the nephrotoxicity of the amphotericin B and the decreased renal clearance of 5-fluorocytosine. If 5-fluorocytosine is used, routine serum level monitoring is warranted because peak serum concentrations of 100 micrograms per milliliter or greater are associated with bone marrow aplasia. Approximately 50% of patients who receive the product experience substantial toxicity, including azotemia, renal tubular acidosis, and myelosuppression. The product is also known to cause gastrointestinal complications, and in the premature infant at risk for necrotizing enterocolitis, its use should be undertaken with extreme caution. Given the narrow therapeutic range and need for therapeutic drug monitoring and the need for oral administration in the United States, This drug is seldom used in neonates. And now we will look at clinical implications. Nearly all clinical studies involving 5-fluorocytosine combination antifungal protocols for cryptococcal meningitis because of the inherently rather weak antifungal activity of 5-fluorocytosine monotherapy. The use of 5-fluorocytosine in premature neonates is discouraged. A study evaluating risk factors and mortality rates of neonatal candidiasis among extremely premature infants showed that infants with Candida meningitis who received amphotericin B in combination with 5-fluorocytosine experience a prolonged time to sterilization of the CSF, compared with those receiving amphotericin B monotherapy. Median of 17.5 versus 6 days, respectively. We will now progress to azoles, fluconazole and voriconazole. The azoles are subdivided into imidazoles and triazoles on the basis of the number of nitrogens in the azole ring. The structural differences result in different binding affinities for the cytochrome P450 (CYP) enzyme system. The triazoles are the products used in young infants and will be covered here. Fluconazole is effective against most Candida spp, but it is unreliable for the treatment of Candida glabrata, and it is ineffective against the very rare cases of neonatal Aspergillus infections. Newer, second-generation triazoles, voriconazole, posaconazole, and ravuconazole, are modifications of prior triazoles with an expanded antifungal spectrum of activity and generally lower MIC values than the older compounds. Only voriconazole has been investigated in children younger than 12 years. And now we will look at antimicrobial activity. The azole antifungals are heterocyclic synthetic compounds that inhibit the fungal cytochrome P450-14-DM, also known as lanosterol 14-alpha-demethylase, which catalyzes a late step in ergosterol biosynthesis. The drugs bind to the heme group in the target protein and block demethylation of the C14 of lanosterol, leading to substitution of methylated sterols in the membrane and depletion of ergosterol. The result is an accumulation of precursors with abnormalities in fungal membrane permeability, membrane-bound enzyme activity, and lack of coordination of chitin synthesis. We will now switch gears to fluconazole. Fluconazole, marketed as diflucan, Pfizer, New York, is a bistriazole approved by the FDA for use in treating cryptococcosis and Candida infections in 1990. An in vitro time-kill study showed that the rate of fluconazole fungistatic activity was not influenced by concentration once the maximal fungistatic concentration was surpassed, which is in contrast to the concentration-dependent fungicidal activity of amphotericin B or caspofungin. Fluconazole is well absorbed from the gastrointestinal tract and is cleared predominantly by the renal route as unchanged drug, whereas metabolism accounts for only a minor proportion of fluconazole clearance. Binding to plasma proteins is low, that is 12%. Gastric absorption of oral fluconazole is virtually unaffected by pH or the presence of food in the stomach. Fluconazole is available as either an oral or an IV form. Oral fluconazole has a high bioavailability of approximately 90% relative to its IV administration. Fluconazole passes into tissues and fluids very rapidly, probably because of its relatively low lipophilicity and limited degree of binding to plasma proteins. Concentrations of fluconazole are 10 to 20-fold higher in urine than in blood, and drug concentrations in the CSF and vitreous humor of the eye are approximately 80% of those found simultaneously in blood. The concentrations of fluconazole in body fluids, such as vaginal secretions, breast milk, saliva, and sputum, are also similar to those in blood, and the fluid-to-blood ratio remains stable after multiple doses. There is a linear plasma concentration-dose relationship. Simple conversion of the corresponding adult dosage of fluconazole on a weight basis is inappropriate for young infants. A population PK study in premature infants showed that volume of distribution varies with weight, and clearance varies with renal maturation. Maintenance fluconazole doses of 12 mg per kilogram per day are necessary to achieve exposures similar to older children and adults. In addition, a loading dose of 25 mg per kilogram is necessary to achieve therapeutic concentrations after the first dose. Candida infections are a leading cause of infectious disease-related death in infants supported with ECMO. The PK of fluconazole in 10 infants supported by ECMO demonstrated that infants on ECMO had higher volume of distribution but similar clearance. Oxygenator extraction was minimal. A fluconazole dose of 25 mg per kilogram once per week was able to provide adequate exposure for prophylaxis. However, higher doses would be indicated for treatment of invasive Candida infection. We will now discuss the safety of fluconazole. Side effects of fluconazole are uncommon. In one study of 24 immunocompromised children, elevated aminotransferases were observed in only 2 cases. A large review of 78 reports of fluconazole use in a total of 726 children younger than 1 year showed it was generally well tolerated. Another review of 562 children from 12 clinical studies confirmed that pediatric results mirror the excellent safety profile seen in adults. The most common side effects were gastrointestinal upset, that is 7.7%, vomiting, diarrhea, and nausea, and a skin rash, that is 1.2%. Fluconazole affects the metabolism of cyclosporine, leading to its increased concentration when they are used together. We will now focus on PK/PD and clinical implications for dosing of fluconazole. Fluconazole may be used as monotherapy for treatment of candidiasis in the nursery. It should be given 12 mg per kilogram daily. There does not appear to be antagonism if the product is used with amphotericin B in a multi-center trial of 236 patients with invasive candidiasis. Those treated with fluconazole plus amphotericin B versus fluconazole alone trended toward better success and more rapid resolution of Candida fungemia with the combination. Fluconazole is particularly appropriate for urinary tract infections because of its concentrating effect in the bladder. Fluconazole is also effective for superficial skin infections because the stratum corneum to serum ratio is high. Some centers use fluconazole for prophylaxis. However, this is not yet considered standard of care. In a single-center blind trial over a 30-month period of 100 infants with birth weights less than 1,000 grams, those infants who received fluconazole for 6 weeks had a decrease in the development of invasive fungal infection compared with placebo, 0% versus 20%. A larger prospective, randomized double-blind, controlled trial conducted in 8 NICUs in Italy among 322 infants with birth weights less than 1,500 grams showed that a fluconazole prophylaxis regimen of 3 to 6 mg per kilogram several times per week for 4 to 6 weeks reduced the incidence of Candida colonization, that is 9.8% in the 6 mg group, 7.7% in the 3 mg group, and 29.2% in the placebo group, with a p-value less than 0.001, and invasive fungal infections, that is 2.7% in the 6 mg group, with a p-value less than 0.005, 3.8% in the 3 mg group, with a p-value less than 0.02, and 13.2% in the placebo group. A retrospective study evaluating the incidence of invasive candidiasis and candida-related mortality among infants with birth weights less than 1,000 grams who received fluconazole prophylaxis, dosed at 3 mg per kilogram several times per week, for 6 weeks showed that the incidence of invasive candidiasis and candida-associated mortality decreased. In the group receiving fluconazole, no increase in fluconazole-resistant Candida strains was observed. Similarly, another report demonstrated that the use of fluconazole prophylaxis for 4 to 6 weeks in infants with birth weights less than 1,500 grams did not increase the incidence of fungal colonization and infections caused by natively fluconazole-resistant Candida species. Results of fluconazole prophylaxis studies in premature infants are encouraging. However, the universal implementation of such strategy across nurseries has not been recommended because 1. The rate of Candida infections varies greatly among centers, and 2. There are insufficient neurodevelopmental follow-up data in these infants to justify prophylaxis. A multi-center international trial is underway to answer questions regarding the need of prophylaxis based on rates of systemic Candida infections in individual nurseries. We will now focus on voriconazole. Voriconazole, marketed as V-Fend by Pfizer, is a second-generation triazole and a synthetic derivative of fluconazole. Voriconazole has activity against most Candida species and against Aspergillus. It is not well studied in neonates and young infants, and therapeutic drug monitoring is advised. We will now discuss the pharmacokinetic data of voriconazole. Voriconazole is extensively metabolized by the liver, and its bioavailability in adults is approximately 90%. It appears that CYP2C19 plays a major role in the metabolism of voriconazole, and this enzyme exhibits genetic polymorphism, dividing the population into poor and extensive metabolizers as a result of a point mutation in the gene encoding the protein CYP2C19. About 5% to 7% of the white population has a deficiency in expressing this enzyme, so genotype plays a key role in the PK of voriconazole. As many as 20% of non-Indian Asians have low CYP2C19 activity and can achieve voriconazole levels as much as fourfold greater than those homozygous subjects who metabolize the drug more extensively. Voriconazole is 44% to 67% plasma bound with nonlinear PK, has a variable half-life of approximately 6 hours, with large interpatient variation in blood levels, and good CSF penetration. Time-kill studies against Candida species and Cryptococcus neoformans revealed in vitro non-concentration-dependent fungistatic activity, similar to that of fluconazole. Oral absorption is nonlinear and rapid, with an approximately 5-fold accumulation over 14 days in one study of hematologic malignancy patients. In a study assessing voriconazole levels after IV to oral switching, mean voriconazole levels did fall after oral administration compared with IV administration, but most subjects achieved steady state 4 days after dosing began. Maximal plasma voriconazole levels occurred at the end of the 1-hour IV infusion and between 1.4 and 1.8 hours after oral administration. A PK study in 6 cirrhosis patients demonstrated hepatic-impaired patients should receive the same oral loading dose, but half the maintenance dose. In contrast to adults, elimination of voriconazole can follow linear kinetics in children, although large interpatient and intrapatient variation remains. They have a higher elimination capacity and therefore require a larger, dosed at 4 mg per kilogram twice daily versus 3 mg per kilogram twice daily, maintenance dose after a 6 mg per kilogram load for 2 doses the first day of therapy. The kinetics of the product in young infants are not known. One case series describes the therapeutic drug monitoring of voriconazole in 10 young infants and toddlers, aged 2 weeks 35 months. These young children received doses of 3.4 to 14.7 mg per kilogram per dose administered every 12 hours. Trough concentrations ranged from 0.1 to 3.2 micrograms per milliliter. Only 3 trough values met the PD target of greater than or equal to 1 microgram per milliliter. Most patients experienced dose increases after therapeutic drug monitoring to meet this metric. Trough levels were difficult to predict based on weight-based dosing. Variation in young children may be exacerbated by developmental changes in CYP2C19 expression, differences in protein binding, drug interaction, and underlying disease states. And now we will focus on the safety of voriconazole. Vorikonazole's main side effects include reversible dose-dependent visual disturbances, increased brightness, blurred vision, in as many as 1/3 of treated patients, elevated hepatic aminotransferases with increasing doses, and occasional skin reactions likely resulting from photosensitization. The visual side effects have resulted in great caution in the use of the product in premature infants, because of the concern of the developing retina as a target organ for toxicity. No such long-term effects have been observed, nor studied in the young infant. However, most clinicians reserve this product for the occasional case of aspergillosis and as a third-line agent for candidiasis. Trough values exceeding 5 to 6 micrograms per milliliter have been associated with increased risk of adverse events. We will now switch gears to the PK/PD and clinical implications of voriconazole. Voriconazole is recommended for the treatment of invasive aspergillosis. There are insufficient data to guide dosing in neonates and infants. Very high variation of voriconazole levels makes therapeutic drug monitoring imperative. Voriconazole therapeutic drug monitoring may improve efficacy and safety. Trough levels greater than or equal to 1 microgram per milliliter are associated with improved response, and trough levels exceeding 5 to 6 micrograms per milliliter are associated with adverse events. A multi-center trial of voriconazole versus fluconazole in treating esophageal candidiasis in 391 immunocompromised patients showed similar success rates with voriconazole, that is 98.3%, and fluconazole, that is 95.1%. Overall, safety and tolerability of both antifungals was acceptable. In an open-label evaluation of 58 children with a proven or probable invasive fungal infection, most had aspergillosis, 45% of children had a complete or partial response, and only 7% were discontinued from voriconazole because of intolerance. The most commonly reported adverse events in these children included elevation in hepatic aminotransferases, skin rash and photosensitivity reaction, and abnormal vision. Intravenously administered voriconazole has been used successfully in very low body weight preterm infants with primary cutaneous aspergillosis. We will now switch gears to echinocandins. Let's begin with their antimicrobial activity. A relatively new class of antifungals, the echinocandins and the amino-containing pneumocandin analogues, are cyclic hexapeptide agents that interfere with cell wall biosynthesis by non-competitive inhibition of 1,3-beta-D-glucan synthase, an enzyme present in fungi but absent in mammalian cells. This 1,3-beta-D-glucan, an essential cell wall polysaccharide, forms a fibril of 3 helically entwined linear polysaccharides and provides structural integrity for the fungal cell wall. The use is increasing in NICUs, yet PK, safety, and efficacy data are limited. All of these agents remain off-label by the FDA for neonates. Echinocandins prevent cell division by Candida, inhibit germination, and interfere with hyphal tip growth, thus converting the mycelium into small clumps of cells. Therefore, the echinocandin activity endpoint is morphologic change, not in vitro medium clearing. Echinocandins are generally fungicidal in vitro against Candida species, although not as rapidly as amphotericin B, but appear to be fungistatic against Aspergillus. As a class, these agents are not metabolized through the CYP enzyme system, but through a presumed O-methyltransferase, lessening some of the drug interactions and side effects seen with the azole class. The echinocandins appear to have a prolonged and dose-dependent fungicidal antifungal effect on Candida albicans compared with the fungistatic fluconazole. 3 compounds in this class, caspofungin, micafungin, and anadulafungin, are FDA approved for use in adults. Recently, more studies have evaluated the use of echinocandins in children. Most constitute early phase 1-2 safety and PK studies. Micafungin is the only well-studied echinocandin in neonates and young infants. Because neonates with candidemia often suffer from disseminated disease in the CSF, which is associated with neurodevelopmental impairment, dosing of antifungal agents in this population should target the CNS. Echinocandins are relatively large molecular weight compounds. Therefore, large doses are likely required to penetrate the CNS. We will now focus on micafungin. Let's begin with its pharmacokinetic data. Micafungin is the only echinocandin lipopeptide compound authorized for neonatal use in Europe, but it is not approved for use in neonates by the FDA. It exhibits linear PK, with the highest drug concentrations detected in the lung, followed by the liver, spleen, and kidney, and does not require dose adjustment for patients with renal disease. Micafungin, like the other echinocandins, does not penetrate the CSF, but levels were detected in the brain tissue, choroidal layer, meninges, and cerebellum in an experimental rabbit animal model. Therefore, the product can be considered in premature and young infants. See meningoencephalitis. A time-kill study of micafungin against Candida species demonstrated potent fungicidal activity against most isolates, including a concentration-dependent post-antifungal effect. The PK of micafungin has been well studied in young infants, perhaps more thoroughly than any other antifungal agent as of this writing. Of interest, micafungin clearance in premature infants weighing greater than 1,000 grams is 1.7 times greater than children 2 to 8 years of age and 2.6 times greater than adults and older children. This higher clearance may be attributed to differences in micafungin plasma protein binding in neonates. A Phase 1, sequential and single dose, 0.75, 1.5, and 3 mg per kilogram, study of IV micafungin in 18 premature infants, mean gestational age, 26.4 plus minus 2.4 weeks, weighing greater than 1,000 grams showed that micafungin PK in preterm infants were linear. Premature infants displayed a shorter half-life, 8 hours, and a more rapid rate of clearance, approximately 39 milliliters per hour per kilogram, compared with older children and adults. In this study, an additional 4 infants weighing less than 1,000 grams received 0.75 milligram per kilogram per day of micafungin and demonstrated shorter mean half-life, that is 5.5 hours, and more rapid mean clearance per body weight, 79.3 plus minus 12.5 milliliters per hour per kilogram, when compared with the heavier infants. These results suggest that young infants may require higher micafungin doses when compared with older children and adults. Data from 12 premature infants, mean birth weight and gestational age, 851 grams and 27 weeks, respectively, suggests that a micafungin dose of 15 milligrams per kilogram per day achieves similar exposures, mean AUC, 437.5 plus minus 99.4 milligrams per hour per liter, to adults receiving 5 milligrams per kilogram per day. Micafungin doses of 7 milligrams per kilogram per day, infants greater than 1,000 grams, and 10 milligrams per kilogram per day, infants less than 1,000 grams, administered to 13 premature infants, mean birth weight and gestational age, 1449 plus minus 1,211 grams and 27.3 plus minus 4.68 weeks, respectively, provided adequate exposures, median AUC of 258.1 and 291.2 milligrams per hour per liter, respectively, to treat CSF candidiasis, as determined in animal models. PK of micafungin in the first 48 hours of life has been evaluated in one small, n equals 25, PK study in very low body weight, that is less than 1,500 grams, infants that evaluated exposure after low dose, 1 milligram per kilogram per day. Micafungin was administered on the day of birth and continued for an average of 13 days, range 4 to 32 days, for prophylaxis. The volume of distribution and clearance were larger and the half-life shorter than previously reported in older neonates and young infants. These differences likely result from dynamic changes in extracellular fluid volume, particularly in preterm infants shortly after birth. The average micafungin concentrations after the first dose were peak, 2 hours, of 1.3 micrograms per milliliter, range 0.39 to 3.1 micrograms per milliliter, and 24-hour trough of 0.2 micrograms per milliliter, range 0.076 to 0.62 micrograms per milliliter. Micafungin accumulation over time was minimal, with last dose trough values of 0.26 micrograms per milliliter, range 0.1 to 0.73 micrograms per milliliter. We will now focus on the safety of micafungin. The safety profile of micafungin is optimal when compared with other antifungal agents in adults and children. In clinical trials of micafungin, patients have demonstrated fewer adverse events compared with liposomal amphotericin B and fluconazole. No dose-limiting toxicities have been described. The most common adverse events include liver function test abnormalities, headache, diarrhea, vomiting, arthralgias, hypophosphatemia, insomnia, and rash. Hypersensitivity reactions associated with micafungin have been reported, and 5% of patients receiving the product may develop liver enzyme elevation. Hyperbilirubinemia, renal impairment, and hemolytic anemia related to micafungin use have also been identified in post-marketing surveillance of the drug. One 44-day-old premature infant developed hepatitis after micafungin, dosed at 8 mg per kilogram per day, was added to an ongoing regimen of amphotericin for the treatment of protracted candidemia. The most common adverse events in a Phase 1 micafungin study of 77 children, 2 to 17 years of age, with fever and neutropenia were diarrhea, that is 19.5%, epistaxis, that is 18.2%, abdominal pain, 16.9%, and headache, 16.9%. Micafungin has very few drug interactions. However, when administered simultaneously, it increases overall exposure, AUC, of sirolimus, that is 21%, nifedipine, that is 18%, and itraconazole, that is 22%. Higher doses of 10 to 15 mg per kilogram per day have been well tolerated in small PK studies in neonates and young infants, and rare adverse events included elevated liver function tests, hyperkalemia, and elevated temperature. In a pooled analysis of pediatric trials, 2% of children stopped treatment because of adverse events that were possibly drug-related because of neutropenia, jaw and joint pain, rash, and abnormal liver function tests, with 2 serious adverse events reported to be hyperbilirubinemia and increased serum creatinine. And now we will focus on PK/PD and clinical implications of micafungin. Clinical studies in adults suggest that micafungin dosed at 100 to 150 mg per day provides a similar clinical response compared with caspofungin, 70 mg load, followed by 50 mg per day. However, given infants' predilection for disseminated candidiasis with CNS involvement, higher doses are necessary. A micafungin AUC 0 to 24 of 166.5 mg/h per liter in a rabbit model of hematogenous Candida meningoencephalitis has been associated with reduction in CNS fungal burden. Dosages of at least 10 mg per kilogram per day are required to achieve this PD target. Higher dosages in infants likely reflect increased rates of clearance and also increase the need to penetrate the CNS. A pediatric sub-study, N equals 106, ages 0 to 16 years, including 14 neonates, was conducted between 2003 and 2005 as part of a double-blind, randomized, multinational trial comparing micafungin, 2 mg per kilogram per day, with liposomal amphotericin B, 3 mg per kilogram per day, as first-line treatment for invasive candidiasis. Treatment success was defined as clinical and mycologic response at the end of therapy. The median duration of study drug administration was 15 days for micafungin, range 3 to 42 days, and 14.5 days for liposomal amphotericin B, range 2 to 34 days. In a modified intent-to-treat analysis, the rate of overall treatment success was similar for micafungin, 72.9%, 35 out of 48, when compared with liposomal amphotericin B, 76%, 38 out of 50, with an adjusted difference between treatment groups of -2.4, 95% confidence interval of 15.3 to 20.1, when stratified by neutropenic status. However, when stratified by age group, liposomal amphotericin B outperformed micafungin in all age groups except for the neonatal group. This observation could be related to the low micafungin dose used in this trial. In general, micafungin was better tolerated than liposomal amphotericin B, as evidenced by the fewer adverse events that led to discontinuation of therapy. Dosing has been recently derived from population PK analysis using data from 47 infants with proven or presumptive disseminated candidiasis previously enrolled in 3 clinical trials. Infants received a daily micafungin dose of 0.75 to 15 mg per kilogram and had serum concentrations evaluated after the first dose and at steady state. In the final population PK model, weight-based estimates of clearance and volume of distribution approximated those previously described for adults. Monte Carlo simulation of dose-exposure relationships in young infants suggested that 82.6% of infants receiving a dosage of 10 mg per kilogram per day would have an AUC greater than or equal to 166.5 mg/hour per liter. The PD target was associated with near maximal decline in fungal burden in a rabbit model of Candida meningoencephalitis. All neonates also achieved an AUC to MIC ratio of at least 1332 for MICs of 0.007 to 0.0625 micrograms per milliliter. We will now switch gears to caspofungin. Let's begin with its pharmacokinetic data. Caspofungin, marketed as Cancidus, is a fungicidal, water-soluble, semi-synthetic derivative of the natural product pneumocandin BO. It has linear PK, is hepatically excreted with a beta-phase half-life of 9 to 10 hours in adults, and has uncommon adverse effects. Parenteral administration is preferred due to the low bioavailability when administered orally. It is not metabolized by the CYP isozyme system. The rate of killing for caspofungin in time-kill studies is greater than that of amphotericin B. There is no known maximal tolerated dose and no toxicity determined maximal length of therapy in adults. The usual course is to begin with a load, followed by a lesser daily dose. PK appears slightly different in children compared with adults. Smaller children exhibit lower levels and shorter half-lives. PK projections suggest that dosing at 50 mg per meter squared appears to be more appropriate in children, rather than using 1 mg per kilogram per day. The PK in young infants are highly variable and not well described, especially at dosages that should be used to clear CSF infections. Peak and trough levels were evaluated in 18 infants, gestational age, 24 to 41 weeks, with a postnatal age of 1 to 11 weeks, who received caspofungin at a daily dose of 25 mg per meter squared. Caspofungin given 25 mg per square meter is thought to provide similar exposure to adults receiving caspofungin at 50 mg per day for the treatment of esophageal and/or oropharyngeal candidiasis. However, this exposure is unlikely to clear CNS infections in young infants. Thus, a recommended dosage cannot be provided from these data. Caspofungin exhibits reduced clearance in neonates and young infants relative to older children. Clearance appears to be primarily determined by the rate of distribution from plasma to hepatocytes and possibly other tissue. Differences in clearance could be due to difference in hepatic uptake transporters, organ size, or blood flow velocity. We will now discuss the safety of caspofungin. 1. 3-beta-D-glucan is a selective target present only in fungal cell walls and not in mammalian cells. Therefore, the echinocandins are rarely toxic in humans. There appears to be no apparent myelitoxicity or nephrotoxicity with the agent. Adverse events reported in a small retrospective study of caspofungin-exposed neonates included thrombophlebitis, hyperkalemia, and elevated liver enzymes. We will now discuss PK/PD and clinical implications of caspofungin. Caspofungin was approved by the FDA in February 2001 for refractory aspergillosis or intolerance to other therapies, and in January 2003, it was approved for candidemia and various other sites of invasive candida infections in adults. In a multi-center trial of 239 patients with invasive candidiasis, 73.4% of patients who received caspofungin had a favorable response at the end of therapy compared with 61.7% in the amphotericin B group. Mortality was similar in both groups, and the proportion of patients with drug-related adverse events was higher in the amphotericin B group. Caspofungin in newborns has been used off-label as single or adjuvant therapy for refractory cases of disseminated candidiasis. A study from Costa Rica reported the use of caspofungin that is 0.5 to 1 mg per kilogram per day for the first 2 to 3 days and 1 to 2 mg per kilogram per day for the remainder of the course, among 10 neonates. Mean gestational age, 33.5 plus minus 1.77, with refractory disseminated candidiasis. All patients had a sterile blood culture within 3 to 7 days of starting caspofungin, and the drug was well tolerated. Through a retrospective chart review, another center identified 13 cases of neonates with a median gestational age of 27 weeks. Range, 24 to 28 weeks, who were treated with caspofungin, 1 to 1.5 mg per kilogram per day, for refractory disseminated candidiasis. 11 of the infants achieved blood sterilization within a median of 3 days, range, 1 to 21 days. However, all but 3 patients had their intravascular lines removed before the onset of caspofungin therapy. Additional studies of caspofungin in the neonatal and young infant population are necessary to assess its safety and efficacy. In addition, PK studies in neonates, to determine optimal dose, are needed before the widespread use of this antifungal agent in the nursery. We will now progress to anadulafungin. Let's begin with its pharmacokinetic data. Anadulafungin, marketed as Araxis by Pfizer, is a semi-synthetic terphenol-substituted antifungal derived from echinocandin B, a lipopeptide fungal product. It has linear PK, with the longest half-life of all the echinocandins, approximately 18 hours, and has shown fungistatic or fungicidal activity in different settings. Analysis in healthy rabbits revealed linear PK with dose-proportional increases in AUC. Anagulafungin lacks significant hepatic metabolism and is not renally excreted. Therefore, neither end-stage renal impairment, dialysis, nor mild to moderate hepatic failure changes the PK of anagulafungin in adults. Tissue concentrations after multiple dosing were highest in the lung and liver, followed by the spleen and kidney, with measurable concentrations in brain tissue. The PK showed approximately 6-fold lower mean peak concentrations in plasma and 2-fold lower AUC values compared with values with similar doses of caspofungin and micafungin. PK data of anagulafungin in children and young infants are sparse. 2 commercially available anagulafungin formulations exist. One requires reconstitution with 20% dehydrated alcohol and therefore is not appropriate for young infants. One PK study in 15 young infants and neonates used a newer formulation that is alcohol-free. Young infants and neonates received a loading dose of 3 mg per kilogram, followed by maintenance dosing of 1.5 mg per kilogram per day, and PK samples were collected after the first dose and at steady state around dose 3 to 5. The concentration time profiles and steady state AUC estimates in these young infants and neonates. Median AUC was 75 micrograms hour per milliliter in neonates and 98 micrograms hour per milliliter in infants, was similar to the AUC of 100 micrograms hour per milliliter seen in older children receiving the same weight-based dosing and adults receiving 100 milligrams per day. Neonates had a faster median steady-state clearance of 0.02 liter per kilogram per hour, compared with young infants' clearance of 0.015 liter per kilogram per hour. Because anagulafungin undergoes non-enzymatic degradation in blood and is not renally cleared nor metabolized in the liver, consistency across patient age populations is not too surprising. We will now discuss the safety of anagulafungin. Anagulafungin has an excellent safety profile and appears to be well tolerated. A Phase 1 study reported anagulafungin to be well tolerated in 29 healthy volunteers, with the highest dose cohort experiencing transient liver function test elevations that exceeded twice the upper limit of normal. In a separate study, 12 subjects with mild or moderate hepatic impairment did not show clinically significant changes in the PK parameters of anagulafungin. However, in patients with severe hepatic impairment, the plasma concentrations of anagulafungin are decreased and plasma clearance increased. In a study of 25 neutropenic children receiving anagulafungin as empirical therapy, rare adverse events included facial erythema and rash, elevation in serum blood urea nitrogen, fever, and hypotension. Anagulafungin was well tolerated, with few adverse events in a small PK study in neonates and young infants. 2 infants had worsening in elevated bilirubin levels. However, these biliary effects were not attributed to study drug because these infants had pre-existing hyperbilirubinemia. Larger pediatric trials are warranted to evaluate a possible association with hepatobiliary side effects. We will now focus on the PK/PD and clinical implications of anagulafungin. Clinical trials with anagulafungin are ongoing. A Phase 3, randomized, double-blind study of adult patients with invasive candidiasis showed that anagulafungin was not inferior to fluconazole in the treatment of invasive candidiasis. The frequency and types of adverse events were similar in the 2 groups. Neonatal and pediatric studies are needed. The dose and drug exposure necessary to treat Candida meningoencephalitis is unknown. We will now draw a few conclusions. Effective dosing of antimicrobial therapy for neonates must be based on rigorous PK studies performed in premature and term neonates. We remain grateful to the exhaustive efforts of Dr. George McCracken, a previous author of this chapter for many editions and author of more than 500 publications, many relating to the pharmacology of antimicrobial drugs and the treatment of neonatal infections. Advances in tandem mass spectroscopy are now allowing drug concentrations to be measured in very small blood samples and even dried blood spots. Population PK trials allow sparse sampling that accommodates standard of care blood drawing times. Research networks have emerged that support collaborative efforts designed to perform rigorous studies that will lead to approved drug labels for neonates. We anticipate continued improvements in our understanding of the PK/PD of antimicrobial drugs in neonates and thus improved dosing guidance. Thank you.